Hey there. All right. I'm going to ask everyone, please, to take their seats. God bless you. Good morning. I'm Judy Wasserheit. I'm the chair of the University of Washington's Department of Global Health. And it is a tremendous, long-awaited pleasure and honor to welcome all of you to this symposium, Global Health, Next Decade, Next Generation. Now, this symposium actually is a landmark celebration, because this is a Jubilee year for global health in our extraordinary global health community, what I like to call our global health ecosystem here in the state of Washington. Originally, this symposium was going to be a celebration of our department's 10th birthday. We are officially tweeners now. But then we realized that actually ours was the first in a whole series of birthdays, actually major 0 birthdays in 2017 among our remarkable partners here in Seattle and across Washington. There are actually 4 other 10th birthdays. The Global Alliance to Prevent Prematurity and Stillbirth, the Institute for Health Metrics and Evaluation, Washington State University's School of Global Animal Health, and the Washington Global Health Alliance. So there was clearly something in the water about 10 years ago. Something very special was going on. But then in addition, there's a 30th birthday, Health Alliance International, and 2 40th birthdays, PATH and the Center for Infectious Disease Research. So we decided that this symposium would be much more productive and our birthday parties would be much more fun if we celebrated them and planned them together. I am extremely grateful to the leaders of these organizations, which you see listed on the slide, and the Bill and Melinda Gates Foundation, which has launched and nurtured the work of so many of us, for their wonderful collaboration with us over the last year in planning today's symposium. Now, actually, along the way, we learned about 2 more birthdays, actually 3 more birthdays. It turns out that Literacy Bridge is celebrating its 10th birthday, and the Max Foundation is celebrating its 20th. Which means that collectively we have to celebrate about 190 years worth of birthdays today. So we really need to get started. And then that's actually not counting Carrie Farquhar's birthday. Carrie is our associate chair for academic programs in the department, and today really is her birthday. So, you know, that puts us over the top, over 200 years worth of birthdays to celebrate. So, I also want to thank our very generous sponsors who co-funded this symposium with our Department of Global Health, the University of Washington Schools of Medicine and Public Health, and our Center for Global Studies. As we worked together on this symposium over the last year, I was struck repeatedly by how very lucky we are to be part of this unique, incredibly dynamic and collaborative global health community. And for those of you who are not familiar with our amazing global health ecosystem here, I want to highlight a few examples of the impact of these Washington state global health organizations. So let me start with WSU's Paul Allen School for Global Animal Health, which has provided global leadership in control of diseases transmitted from animals to humans. And among its many accomplishments, it has developed innovative approaches to canine rabies vaccination in low-income countries with an eye toward eliminating human rabies, which is currently responsible for about 60,000 human deaths annually. PATH is now working in 70 countries with more than 2,000 partners. And among its many contributions, PATH has helped develop and deliver the first vaccine for Africa created in Africa, a vaccine that's leading to the virtual elimination of meningitis A in the places in which it's being used. The Center for Infectious Disease Research has developed a novel malaria vaccine that looks very promising in test systems and early human trials and is now moving into larger clinical trials. And of course, if that's proven effective, it has the potential to save hundreds of thousands of lives each year. The Institute for Health Metrics and Evaluation has changed the game in terms of measuring and understanding the burden of disease and related risk factors around the world, and also in terms of the use of rigorous health evidence by policymakers and program managers. And I think it's fair to say that IHME can be credited with establishing the field of health metrics sciences. And then more broadly, in our own Department of Global Health, we have rapidly become one of the world's leading academic global health programs, working now in about 130 countries to achieve what I like to call our mantra, impact at scale with partners around the world. Our research on HIV and other infectious diseases, particularly as they affect the health of women, adolescents, and children, has shaped policies and programs worldwide, including the 2015 World Health Organization guidance on HIV pre-exposure prophylaxis, the new WHO partner notification recommendations that were released on World AIDS Day just this past December, and the HIV program strategy of the Kenyan Ministry of Health. We've also played a pivotal role in developing the next generation of global health leaders and innovators through our 8 Seattle-based and 9 international education and training programs. More than 3,400 students have enrolled in our global health education and training programs here in Seattle over the last 10 years. And in just the last 4 years, more than 11,000 students from 59 countries took our online courses. Finally, thanks to the Washington Global Health Alliance, which is the first organization of its kind in the world, we now know that there are more than 168 Seattle-based or Washington-based global health organizations working in 150 countries. We know where they're working, what they're working on, and with whom they're partnering. We also know that global health is a major economic engine here in the state of Washington. Statewide, global health employs more than 12,000 people, with thousands more working in countries around the world. And global health provides about $46 million in tax revenue here in Washington state every year. Now, there are many more accomplishments that we can and should and will celebrate in 2017 and beyond. But the focus of today's symposium is actually not on past accomplishments, but on the future. So we're going to talk about the grand challenges that we face in the coming decade, innovative solutions that we envision or that are already emerging because of the work here, and the development of the next generation to address these major challenges. We're going to start with 2 short plenaries by 2 very distinguished and very insightful global health leaders to lay the foundation for our discussion. First, Dr. Margaret Chan will lead off by focusing on grand challenges for the next decade in global health policy and programs. And then Dr. Peter Piot will focus on grand challenges in research and training. Then we'll move into 4 panels to explore 4 of our biggest challenges: pandemic disease, preparedness and response, prevention and care for non-communicable diseases, the impact of global environmental change on human health, and innovative approaches to global health education and training. For each panel, after the introductions by the moderator, one of the panelists will set the stage with a brief overview. Then each of the other panelists will briefly share their initial perspectives. And then we should have at least 45 minutes for far-reaching and, I hope, very thought-provoking discussion. So I think that today will offer all of us a real feast of issues and ideas and perspectives to chew on. We have an all-star, truly stellar group of panelists, and I'm very grateful to each one of them. But I particularly want to thank Dr. Ala Alwan, whose presence here today is a testimony to his resilience and perseverance in the face of President Trump's executive order banning travel from 7 countries. And I think it's also a reminder to all of us that now, more than ever, it is so important that we work together to safeguard human rights, basic health services, and the liberties and democratic principles that we all hold very dear. So, with that, it is a tremendous delight for me to welcome Dr. Margaret Chan, who has served as the Director General of the World Health Organization since 2006 and will complete her second 5-year term this coming June. Before being elected Director General, Dr. Chan was WHO's Assistant Director General for Communicable Diseases and representative of for pandemic influenza. And she came to that with lots of experience and expertise, having previously, prior to joining WHO, been the Director of Health in Hong Kong, where during her 9-year tenure, she successfully managed the first human outbreak of H5N1 avian flu, as well as SARS. She brings unparalleled experience and expertise to considering the grand challenges that we face in global health policy and programs. So please join me in welcoming Dr. Margaret Chan.
What a celebration. I love birthday parties. So, honorable ministers, distinguished fellow speakers, faculty and staff of the University of Washington, colleagues in public health, many of my old friends and colleagues are in the audience, and of course, ladies and gentlemen. Judy, first and foremost, let me thank you. Thank you very much for inviting me to join your birthday celebration. For global health, truly, this is a Jubilee year for the University of Washington's Department of Global Health. And at least, I have done some homework as you were counting the birthdays, at least 7 other Washington-based health organizations. So congratulations to all of you, but a special congratulations to you, Judy, to the Department of Global Health on its 10th anniversary celebration. As I said, I have done some homework before I came. With well over 600 current research projects in nearly 130 countries, your contribution, friends and colleagues, to global health is broad and your productivity is astonishing. Many of these projects are operating at cutting edge of innovation, and several are being conducted in close collaboration with WHO. I just talked to Craig And thank you for that collaboration. And I'm sure many of you also work with WHO in other important projects. And I have to say, several of these projects are very dear to my heart. Let me just mention a few, particularly in the era of sustainable development. Like support the school feeding programs that use homegrown food. That's very important. The integration of cervical cancer control into existing HIV services, and the promotion of community-based primary health care, especially by training rural health workers. I've been asked by Judy, of course, to speak about grand challenges for health policy and programs in the coming decades. Your interdisciplinary, can never say that word in the morning. Chris, where are you, Chris Elias? Too much to drink last night. Your interdisciplinary panels will be exploring 4 of these challenges: preparedness for outbreaks of emerging and re-emerging diseases, the control of non-communicable diseases, the health impact of environmental degradation and climate change, and the need for innovative approaches to education and training. Allow me to add another one to that list, and it is antimicrobial resistance and its nightmare bacteria to that very important list. In our world of radically increased interdependence, the forces that shape these challenges are universal, and they are not easily reversed. The world has changed dramatically since the start of this century, when the Millennium Development Goals were put forward as the overarching framework for development cooperation. World leaders at the Millennium Summit sought to create what they call, and let me quote, a more peaceful, prosperous, and just world, end of quote. Unfortunately, that did not happen as planned. To understand the newer challenges now embodied in the 2030 Agenda for Sustainable Development, we need to look at the largest sea in which these trends are set afloat. Since 2001, terrorist attacks that deliberately target civilians have become more deadly, daring, and common. Armed conflicts are now the largest and longest experienced since Second World War. The refugee crisis in Europe taught the world that wars in faraway lands will not stay remote. International humanitarian law is now largely ignored. We should condemn all the attempts to bomb healthcare facilities and the use of siege and starvation as weapons of war. Warnings about the consequences of climate change are increasingly threefold. Records of extreme weather events are being broken a record number of times. And ladies and gentlemen, the past 3 years have been the hottest ever. The phrase mega disaster enter into the humanitarian vocabulary following devastating earthquakes, tsunamis, tropical cyclones, droughts, and floods. The world population is now bigger, more urban, and a lot older, including me. And adding dementia to the list of top health priorities. Everywhere in the world, people are living longer, unfortunately, some with sicker lives, increasing the burden on health services, budget, and the workforce. Hunger, ladies and gentlemen, has persisted, but most of the world get fat. The world now has 800 million chronically hungry people, but it also has, side by side, where in many countries, where more than 70% of the adult population is obese or overweight. And I'm sure you will hear more about the impact on NCDs from, Dr. Ala Wan, my very good friend and colleague. The globalized marketing of unhealthy products. Chris, what did you do to me last night? Other than the wine. No, jokes aside. The globalized marketing of unhealthy products opened wide the entry point, we call it, for the rise of lifestyle-related chronic conditions. Non-communicable diseases have overtaken infectious diseases as the biggest killers worldwide. This is a unique time in history where economic progress, improved living conditions, and greater purchasing power are actually causing more diseases instead of reducing them. Social media are becoming a new voice with considerable force, and yet very few safeguards governing the accuracy of the... What is your name?
I'm Cyril Langman.
Oh, you are so good. Thank you. What a gentleman. Well, let me come back to social media. It has become a new voice, as I said. And unfortunately, there are very few safeguards governing the accuracy of its content. And the proliferation of front groups and lobbyists protecting commodities that harm health has created arguments that further muddle public thinking and challenges the authorities, your good self, your science, and your evidence. The Oxford Dictionary of the English language chose post-truth as its word of the year in 2016. A lot of food for thought. In a post-truth and post-fact world, views that appeal to emotions and personal beliefs are more influential than objective evidence based on science, based on the very important work that so many of you are engaged. We need to defend science and evidence like never before. Now, with this kind of landscape, what does it mean for public health? And what does it mean for public trust in the evidence produced by science, medicine, and public health? The 21st century has been rocked, by the emergence of 4 new human pathogens. I'm happy to see Paul Allen School for Animal Health. I mean, what you are saying is so correct. The ecosystem, the animal-human interface is giving us more and more surprises. Just 4 new, let me mention 4 new human pathogens. SARS, the H5N1 and H7N9 influenza viruses, and the MERS coronavirus, and the list will go on. I've been in public health for more than 40 years, and I have to tell you, I have seen more than 30 new diseases. So, about 1 new disease a year. So, is the world prepared to deal with this? I don't think so. Now, it's not just new diseases. Other older diseases have re-emerged in very bad ways, including Ebola in West Africa, yellow fever, and Zika virus disease. As the century progressed, more and more first and second-line antibiotics failed. The pipeline of replacement products are nearly empty, raising the specter of a post-antibiotic era in which common infections will once again kill. What will happen to modern medicine? What will happen to me when I need a hip replacement? So these are things we really need to think about. So that's why I suggested, adding to your list of challenges, we need to pay attention to antimicrobial resistance. The world, ladies and gentlemen, is also much richer than at the start of this century. Countries like India, like China, they have lifted millions and millions of people from their countries out of poverty. But unfortunately, in far too many countries, the benefits of growing wealth have gone to the privileged few. the number of rich countries full of poor people has grown, changing the poverty map. Today, 70% of the world's poor live in middle-income countries. The consequences of the world's extreme social inequalities are profound. Last month, in January, the World Economic Forum identified growing inequalities in income and wealth as the single most significant trend that will shape global development over the next 10 years. In essence, the Sustainable Development Goals are a corrective strategy that looks at the root causes of inequality and aims to transform them. The international systems that govern finance, business relations, trade, and foreign affairs need to change and need to be adapted as a corrective strategy as well. As some critics argue, the long-standing social contract that obliges the privileged few to care for those less fortunate has been broken. It has been broken, and we are now living in a world that has lost its moral compass. Ladies and gentlemen, as we collectively address these challenges, allow me to ask you to keep in mind 4 overarching priorities that should guide health policies and programs. First, tackle inequality. Second, improve information. Third, stimulate innovation. Fourth, and above all, show impeccable integrity. For inequality, the 2030 Agenda for Sustainable Development has the focus right, leaving no one behind. And this is not easy, especially in these uncertain times. Decades of experience tells us that this world will not become a fair place for health all by itself. Health systems will not automatically gravitate towards greater equality or naturally evolve towards universal coverage, making sure that nobody's financial situation is broken and that you have to sell your house, sell your cow in order to pay for the healthcare costs. Economic decisions nowadays within a country will not automatically protect the poor or promote their health. Globalization will not self-regulate in ways that ensure fair distribution of wealth and benefits. International trade agreements will not, by themselves, guarantee food security or job security or health security or access to affordable medicines. All of these outcomes require deliberate policy decisions made by policymakers. I call on you to promote the SDG target for universal health coverage as the ultimate expression of fairness. It is one of the most powerful social equalizers among all policy options. For information, if I tell you 85 countries in WHO's membership, we have 194 countries, 85 of them, representing 65% of the world's population, do not have reliable cause of death statistics. This means that the causes of death are neither known nor recorded. And the health programs are left to base their strategies on crude and imprecise estimates. Thanks to the IHME, their work. I hope Chris is in the audience. Hello, Chris. Oh, okay. Until more countries have good systems for civil registration and vital statistics, health programs will be working in the dark, throwing money into a black hole. This is totally unacceptable in the current climate that places a premium on transparency, accountability, and independent monitoring of results. I'm aware of the many current projects undertaken by the Global Health Department, Judy, and its partners, which are using the latest information technologies to address precisely this problem. For innovation, we know that the supremely ambitious health targets set out in the SDGs cannot be met without powerful new medical tools. We know that new vaccines can prevent infections that currently contribute to the overuse of antibiotics. And of course, we must defend vaccines as the most cost-effective means to prevent diseases. We know that at least 11 epidemic-prone human pathogens, including Zika, Lassa fever, and Nipah virus, have no vaccines to protect population during outbreaks. And I'm extremely happy to hear that CEPI and the Gates Foundation, along with many others, Norway, Wellcome Trust, and the industry have come together and formed an alliance to promote R&D and to promote the incentives to make sure that, medical interventions, new products for these pathogens are accessible. And it is not accessible only to markets that can pay. One strategy that has worked very well at WHO is to let the people working in the field and seeing practical constraints on a daily basis design the profile of an ideal new product right down to its price. I'm very happy to hear from Judy that, she mentioned about the collaboration between WHO and PATH, supported by the Bill and Melinda Gates Foundation to develop the meningitis vaccine for African countries. We work very closely with African scientists, so kudos to all of you, Minister, for the first innovation being designed, clinical trial, and used in African countries. And I'm so proud of this project that shows the power of partnership in global health. Finally, we must all work according to the highest standards of scientific integrity. Like others, I see a number of disturbing trends. And let me respond to just one. Regulatory agencies everywhere must resist the push to replace randomized controlled trials, for a long time the gold standard for approving new drugs. Do not allow it to be replaced with research summaries provided by the pharmaceutical companies. As some argue, making this change will speed up regulatory approval, maybe, lower the cost to industry, certainly, and get more products onto the market sooner. It's true. But allow me to argue, this kind of thinking is extremely dangerous. We must not let anything, including economic arguments or industry pressure, lower our scientific standards or compromise our integrity. This is an absolute duty. And don't let politicians, the public, or industry forget the lessons from the thalidomide disaster. Thank you.
Thank you so much. That was a wonderful kickoff for us. I would, for those of you in the back, there actually are some seats up here. They have little signs that say reserved on them, but if people aren't here at this point, come fill them in. So, can I ask you a couple of questions?
Well, it depends on what are the questions.
Maybe she was going to say. All right.
Okay.
So, how do you see WHO's evolving role, not just in global health, but more broadly in terms of functioning as an influential political body in our very hyper-political times?
Judy, thank you for that question. the World Health Organization is the lead health agency in United Nations system. As a normative organization, we must be the guardian and the defender of science and evidence. That is a very important foundation for policy formulation, for monitoring progress or otherwise, and make course adjustment to make sure at the end of the day, we advocate interventions, advocate policies, advocate for programs that will benefit the health and the well-being of people of all ages. I need to add the last 3 words. To
Especially
benefit
as-
myself.
Right,
Yeah.
both of us.
I need to declare interest.
All right. We're going to be going into a day in which we will be looking at least some of the major challenges ahead of us in the next decade. Pandemic disease preparedness and response, and as you pointed out very correctly, I would add to that antimicrobial resistance, non-communicable diseases, global environmental change. So what, in your view, what are the really salient lessons from our experience over the last decade to inform how we should think differently about programs and policies in those areas? Because if we just do more of the same, we're going to have the same outcome, right?
Allow me to say this, this has been, something I've been advocating. It is okay when you look at program in silos, but it is not okay to look at it from the delivery perspective. Now, if we talk about communicable diseases, there are so many of them. They are all very important. HIV, TB, malaria, and other communicable diseases. And then let's not forget the importance of NCDs, cancer, mental health. Now, from the person who is delivering services, it's incomprehensible for them to think of, what am I doing? Am I treating the patient as a collection of organs? Today I deal with the heart, tomorrow I deal with the lung. So, yes, it is okay to think of, what works in terms of guidance, but at the delivery level. And that's why WHO working very closely with many countries and supported by countries and scientists to advocate for universal health coverage based on primary health care. It is the delivery system that is important to deliver either communicable diseases, non-communicable diseases, and have the capacity to prevent, detect, and respond to crisis. And we have seen in countries in West Africa, learned the lessons from Ebola. The countries were hit by Ebola, a new disease. They don't know, they have no knowledge of the disease, unlike other countries in Africa. And these are countries post-conflict and post-war, and they are at the, I'm sure Minister Dow will tell you more, in the process of building systems. But before they have the capability and the capacity, and they were hit by Ebola. Now the fear, as well as many other reasons, and also more and more people live in urban cities. And movement of people, unprecedented movement of people, either it is rural, urban migration, or across boundaries, will spread disease. So let's go back to basics. We need a resilient, functional health system with the right healthcare workers, information system, infrastructure, as well as, access, essential medicines to make sure things work. And there is no replacement going forward that we need to pay more attention on prevention. And I'm sure Dr. Alawan will make a lot more comments. How can the world, no matter how wealthy you are, pay its way out of all these diseases? We need to go back to prevention. So the importance of vaccines, the importance of many other interventions. Now on research, it's extremely important for innovation. But I would encourage you, at this point in time, we invest a lot of attention on biomedical research and clinical studies, that's important. But let's not forget delivery research and linking it to policy. And researchers should include policymakers right at the beginning to collapse the timeline to implement and of course to embrace the good work that are coming out of your research. That's very important. The lessons we learned is also from the Ebola. Mm-hmm. In the past, sorry.
No. This is great. Go for it.
Okay, in the past, the way things are done is they are done in a sequential manner. Scientists work very hard to develop vaccines or medicines. Once they get that delivery, that may be bought by a pharmaceutical company, right? And then they go through the registration process. It takes a long time for good product to get to market. So we need to collapse that. During Ebola, what we did was we bring all the partners together. We brought the industry together, the regulators, civil society, the experts from the African countries to look at what kind of vaccines can we develop? What are the potential candidates? What can we do together in a coordinated manner right from the outset instead of taking a sequential manner? Now, of course, WHO, we would like to thank the people and the government of Guinea to give us a chance to do the clinical trial on the Ebola vaccine. And now we have 100% effective Ebola vaccine. And so the world is, in terms of innovation, is better prepared for the next Ebola crisis than a couple of years ago.
So your comments about research are a beautiful segue into my last question for you and to Peter Piat's next plenary. And so this last question is, we keep talking about evidence-based programs and policy. But the reality is that in most programs at all levels, there are very limited resources for research and evaluation. So what are your thoughts about how we change that if we really believe that programs and policy need to be based on evidence, and the evidence comes from research and evaluation, as you pointed out repeatedly? How do we do better on that at all levels?
There is no replacement of results and impact to convince governments or development partners to support programs. And that's why the work done by Chris and many people are so important. What gets measured gets done, first and foremost. And then with the evidence and showing the impact of, vaccine. How many? Well, I better not say anything because I had the privilege to preview the letter from Bill Gates yesterday. I'm not going to make comment on that because, those are very important results to show to development partners or supporters or even governments to continue to invest in evidence, for monitoring, for policy formulation, and for cost adjustment. So don't give up, Research money is never enough. So one way is don't work in silos. It's easier said than done. Isn't it? I'm just being frank with you. We like to be the discoverer of everything. But I think the day of Superman and Superwoman is gone. It's all about alliances, teamwork, and collaboration going forward. Partnership.
Well, thank you. Please join me in thanking Dr. Chen for a wonderful kickoff. Thank you so much.
Happy birthday.
All right. We are now going to move into our second plenary, focusing on grand challenges in research, education, and training. And it is a wonderful pleasure to welcome a long-standing friend and colleague, Dr. Peter Piat, who is the director of the London School of Hygiene and Tropical Medicine, and the Honda Professor of Global Health. He was the founding executive director of UNAIDS and Undersecretary General of the United Nations from 1995 to 2008. As many of you are aware, Peter was the co-discoverer of the Ebola virus in Zaire in 1976, and he has led really groundbreaking research on HIV and other sexually transmitted infections, women's health, and public health in Africa. He's a member of the U.S. National Academy of Medicine. He chairs IHME's Independent Advisory Committee on the Global Burden of Disease, and of course, most importantly, he is the chair of our department's External Advisory Board. He has received too many awards for me to go through them, but I think you can tell from what I've said already that it's hard to think of anyone in the world who would be better to help us begin to think about grand challenges in research, education, and training. So with that, please welcome Dr. Peter Piot.
I have to give that to you. This is that's a birthday present.
I appreciate
Water,
that.
yes.
Such a gentleman.
Yeah, thank you. Well, good morning, everybody, and thanks so much, Judy, for this kind introduction, and come back to that. And also thank you, Margaret, for setting the scene, and also asking some of the difficult questions that not only research, but I think a lot of it will have to be solved by politics. Now, when I landed here in 1978, and most of you weren't born yet, to work with King Holmes, the founding parent of global health here, and Stanley Falco, there were hardly any foreigners here at the University of Washington. And I came basically straight from Central Africa, and they thought I was kind of a bit weird. And also the term global health didn't even exist. I was reminded of that yesterday when Minister Dam from Liberia, who's an alumna from University of Washington here, her degree is in international health. It's not in global health. And international is far away. Doesn't affect us here. But the world is a bit different, as we know. And it's only around the millennium that the term global health actually emerged. I've tried very hard to find when was this term used for the first time, and I can't find it except in some Canadian publication, and it was about that was not really about global health. And it really emerged as a field of inquiry. I can't say a discipline because it involves many disciplines. It was driven by the AIDS movement. And it's the AIDS movement that really set the values of this of global health. And today it's very thriving. Every university that respects itself has a global health institute, department, and what have you. Some are big, some are small. And now I think we're moving into the next phase of global health. And I think that's why celebrating a birthday is a good thing also to look forward. And so many congratulations to you, Judy, and your team, and all the institutions represented here. Seattle, Washington State, the academics, the research institutions, the Bill and Melinda Gates Foundation, NGOs, have contributed tremendously to shaping the field of global health. Because that's been really the exciting thing as far as I'm concerned. It was something that was just two words, global health, and And then there were fierce debate, what does it mean? My position has always been, let's not try to define it too precisely. Sometimes being a bit vague is not too bad, because it has to be, by definition, a big tent in order to address the very complex challenge that we have here. So we're entering into a new phase, and that's what I will talk about, and what does it mean for research and for training and education. Now, as we heard from Dr. Chan, the health challenges are changing in the world. And today we know that more precise than before because of the global burden of disease exercises. And here I summarize them in, but there are more, but there are still, there's enormous demographic change and aging population. And it would be a big mistake to think that long life is the privilege and the, the exclusivity of high-income countries. There are, particularly in Asia, but even in Africa and certainly also in Latin America, people are living much longer at an accelerated rate. Sorry, I have some cold here, as you can hear. And that has many, many implications. And it's one of the reasons that the National Health Service in the UK is not saying imploding, but is in deep, deep trouble at the moment. Because that was not really included in the projections. And we heard chronic conditions. I don't like the term non-communicable diseases, because anything that starts with non is a non-starter and a non-issue. And this is a big issue. It's chronic conditions, and also some are caused by viruses. Think of cervix cancer, for example. And also multimorbidities. So it's not, when you are dealing with particularly from the clinical side, but also it means from the prevention side, it's not just one particular disease, because that's what I, of course, in infectious diseases, although there's also multimorbidity, certainly with the chronic types like HIV, you have one bug, one disease, and one treatment, and one vaccine, and that's it. That's over. We have still epidemics that will come up, emerging infections, and as Margaret said, one new one a year, and that's going to accelerate for many reasons. One is has to do with the demographic change and pressure, with climate change, with greater mobility, and so on. So we need to continue to deal with that. Climate change and health. Yesterday, Patti Garcia, the Minister of Health of Peru, told us when she got this award from the School of Public Health that what has kept her busy are natural disasters that are clearly linked to climate change. So climate change and the impact on health and on society is not something for in 100 years or so, because that's how we've been thinking in terms of climate. It's the unit of the time unit is much, much longer than when we deal with, with the disease as such. It's already there, the impact. But we haven't really figured out the science, the evidence, and what to do. Margaret mentioned universal health coverage, so I don't need to do that. We're also having massive opportunities in terms of innovation. And I'm not only thinking in terms of new vaccines and new therapies, but also the impact of artificial intelligence, for example, on decision-making, both at the individual level, but also at the population level, and in designing new ways of managing health systems, that new diagnostics and so on. And then we have trust. Trust is the basis of public health. If people have no trust, forget it. We saw that in an acute way in some of the Ebola outbreak issues. We see it in declining rates of acceptance of immunization, the most cost-effective intervention in public health. One of the paradoxes of our time is that You know, people don't do that. So these are all big challenges that we have to deal with. Now, what I'm going to say is about a theme that I first developed here at the CUGH, the Consortium of Universities for Global Health meeting in Seattle, I don't remember, 5 years ago or whenever it was, something like that. And what I'm saying is that we have to move to the next stage of global health. We can call it 2.0 or 3.0 or whatever, since this is an IT city more and more. And there are many shifts that are already occurring, and where I think here the global health community, and it's true, I mean, coming together in something that's quite unique with the Washington Global Health Alliance. You know, I wish that every country or so had that. We don't have that in the UK. Up to now, it's been mostly or nearly exclusively on infectious diseases, maternal and child health, malnutrition, and malnutrition meaning undernutrition of humans, of human animals, of us. So that should continue. The job is not over. We should not fool ourselves. The end of AIDS is absolutely not in sight, despite what some people may say. But it's the chronic conditions that we have to really work on far more and do research. But it's not only the health aspects themselves, you know, through a spectrum of One Health, particularly when it comes to emerging infections, but not only. But it's also this whole issue about the environment, climate change, and urbanization. The Lancet published, I think, a few weeks ago, there was a series on slum health in the slums, which opened my eyes that it's not the same thing as urban health. There are specific issues and opportunities. Secondly is that up to now in global health, when we think of it as international health, it is like you know, investigators from here, Europe, Japan, going and do the trials and do some epidemiology and all that, and then come back, publish it, and so on. Today, there is discovery going on in low and middle-income countries. Discovery, so there's the whole pipeline now, which was the exclusivity of high-income countries, is now also being globalized. Not yet fully, but I think that's really there, and we've seen now, for example, the first new class of anti-malaria drugs were developed in South Africa by a Zambian. And that means also that we need to go to not only from the full spectrum of translation to discovery, but also be far more multidisciplinary. And that means also moving from a purely biomedical approach to greater prioritization of behavioral and operational research. So, see, Margaret and I, we didn't discuss the talk before, but at least we agree. Now, we've been very good at what I would call supply-side innovation. New drugs, new vaccines, spectacular, what we've seen the last 15 years particularly. But where we've really paid less attention is what I call demand-side innovation. I don't like the term kind of delivery, because delivery means that, you know, I'm going to deliver this, and you have to take it on. Although I say in my second line here, it's not only about delivery of innovation, but also innovation in delivery. But this demand-side innovation is, I think, probably the greatest need for innovation and where we need to invest in, because the rest I see the supply side innovation is you know, running its own course, and I think there are also market forces that favor it, and that not always, but yes. And the rest, I think, is just some changes that we are seeing that are along the same lines, where we see far more now that the principal investigator is more global. I think we should drop and ban the term "my study site," you know, because it reflects a lot, just that term. Language is important. The centers of excellence that are popping up everywhere. And we have also seen a very interesting phenomenon, from a pure brain drain to what is circular migration. People come and go and so on. So that's what I think has got Global Health 2.0. Now, when we think of population health, I won't go into like clinical medicine and so on, individual medicine. I think here, clinical medicine is now, the mantra is precision medicine. But it misses a big chunk of opportunities, and we should talk about precision health, or precision public health, as Hellman has launched it, or precision population health. And that we can do today. We couldn't do that before. And it requires investments in better data, but data of the kind of that also companies and people into marketing use. It's not only the genomic makeup of populations. That's okay, that will give us precious information, particularly when it comes to the use of certain interventions, therapeutic interventions. Think of, for example, for HIV treatment. But it's having the data that are not so much the global ones, but as local as possible. Because the more local they are, the more useful they will be. So that's why the work of IHME here is so important and game-changing. So local data, but also the infrastructure locally to manage that. There's no use of publishing all kinds of interesting stuff about a country or a community in some global journal if there's nobody in that community that one has access to it, reads it, or can use it. It means also that we need to invest far more into, the laboratory infrastructure, health and social systems, marketing and behavior analysis, and actually try to integrate that. Companies, particularly in companies that are into consumer goods, they know this already. It's extremely sophisticated, this consumer-specific type of marketing. We don't do that in health. And that brings me to systems design and also the need to go for better forecasting and so on. So this is an area that I find very exciting where we need research. Now, the bad news is that the easy gains are over. I think it hasn't been easy, but dealing with infectious diseases and bringing them down, sometimes even wiping it out, and I don't pretend that the final elimination phase of polio is easy, but I think it's easier than what we are confronted with now in terms of dealing with chronic conditions, the climate change, urbanization, universal health coverage, and so on. But we should also make sure that we are not compromising there in the sense that we need to make sure that that is as evidence-based as possible. Now, that evidence base is not always there. And there, we will need mixed methods of evaluation or to see what works. So there are rarely single technical innovations, and politics are far more important than we can even imagine. Now, this was all about the what and a bit about the how. Margaret mentioned what we launched 2 weeks ago in Davos, the Coalition for Epidemic Preparedness Innovations, but I think it's a good model for many things. Why? Because it brings everybody into the tent, from big bad pharma to small pharma to biotechnology to the foundation here, the Wellcome Trust, governments and so on. And that was not easy, but I think it will result into products, in this case innovation. My final slide here is on training and education. Now, the needs are pretty unclear, and we need to think about, just as for research, 20 years or 30 years ahead. And in Europe, there's an enormous uncertainty of the future labor market into global health, particularly with the current nationalism and closing the borders and so on. What will that mean? And at the moment, also at our school, the emphasis is on quantitative skills, analytic skills, clinical skills, and they'll always be important. But what we need is actually trained people who have can work in a multidisciplinary, multi-sectoral environment and have the leadership. We'll have the distance and blended learning, lifelong learning, and sometimes I wonder maybe the ultimate success will be when global health will disappear and that it's completely part of normal way of dealing with health in all sectors. So to end, new phase, but we have now external factors, external to global health, but that are actually have always been part of it, that mean that we, the future is uncertain, but let's never forget that we can shape the future. And we should not take anything for granted and not complain all the time, because then we get into a self-fulfilling prophecy. So let's work on that. Thank you very much.
Microphone, so
Yeah.
we don't need the other one.
Yeah,
Okay,
yeah.
great, good. Well, I'm going to lead off with one question for you, and then if people want to come to the microphones, we'll take questions from the floor. But let's start off with the whole area of research. And what if you think about the major research advances over the last decade or so, what do you think, which do you think have the greatest potential in terms of helping us as we look toward these grand challenges that both you and Margaret have started to talk about? So what from our experience in the past on the research side do you think would be most?
Yeah, well, there is always better tools, better vaccines, better or new vaccines and new therapies. I mean, who would have thought 10 years ago that we can cure hepatitis C virus infection? Cure. Much better than antiretroviral therapy. Maybe we'll have something like that for HIV, although I think that'll be much more of a challenge. So we should not neglect that. So the biomedical research will give better tools, and that can be game changers, always. But I think in terms of the population level, it's the data revolution, I think. But big data in itself is meaningless. You know, you have to do something with them, and you have to interpret, and I think that's where the connection with artificial intelligence, with forecasting, with scenarios, is really going to be key. And again, that's something that has exploded over the last 10 years. And now I think it's ripe to be used in, I think at several levels. And for example, what I'm seeing is that PSI, Population Service International, social marketing, quite impressed how they're already doing, I mean, because they're into marketing, so they maybe have been much faster in taking up this kind of data for their programming, for their management. And then thirdly, I think, is on, most difficult one is on what I call this demand-side research, the systems, the task shifting. We know more or less what will work, but we don't have the evidence base, and we need to look into that. I think these are some of three, so that's more the operations type of research.
I'm going to grab this microphone because I'm being told my microphone didn't work, so I apologize. All right. Do people from the floor have questions? I could go on forever here, but if we do have questions from the floor. Okay. Let's start on this side. Why don't you introduce yourself, and then please go ahead.
My name is Dr. Wicklund. I'm Director of Health Teams International, leading a team in 4 weeks into Africa. In the last day, there's been 5 Red Cross workers killed in Afghanistan. In this past year, a number of Doctors Without Borders. I'm just questioning, where does global health interact with that sort of concern?
Yeah, so this is the something that Margaret also alluded to, is that we see increasing violation of humanitarian space, to say so, with bombing of MSF hospitals in Afghanistan, in Syria, and also many others. These are the ones we know about, and there must be more. I think that the whole health and humanitarian crisis has not been really part of global health enough. I mean, it's in many places. So all I can say is that we need to work on it. Not only, the talk was about research on the evidence base, but also at the political level and raise our voices. And that's where, this is not just an academic issue.
Thank you.
Thank you. Wonderful talk. Amy Hagopian, I'm on the faculty here. And my question is actually very aligned with the previous person. It seems to me that Global Health 2.0 needs to very squarely face the issue of war as a public health problem. Yep. We have been content as a field and a profession to clean up afterwards. I think it's fair to say polio is entirely attributable to war at this point. And it's time for us to embrace war as a public health problem, to aim some resources at research and prevention. And this is the duty of public health workers in the future.
Yeah, I fully agree. And at the London School of Hygiene and Tropical Medicine, actually, we created last year, a bit late maybe, but a center for health in humanitarian crisis. And that's why, and it's not only war, but it's also violence, from domestic violence to all kinds of violence. So there are many entry points. The problem often is that in humanitarian crisis, trying to learn from them and try to develop some more evidence base is very difficult, because the imperative is saving lives every day, and the pressures are enormous. But I agree with you.
Let's go over here. And we're going to take the questions from the people who are standing now, and then I hope others will ask questions throughout the day.
So I wanted to ask a follow-up. I'm so glad you distinguished...
Would you mind introducing yourself?
Oh, sure. I'm Catherine Cheney, and I'm the West Coast correspondent for DevX.
Perfect, yeah.
We're a media company focused on global development. So often in my West Coast coverage, the word innovation comes up, and I just wanted to dig into that a little bit more. You also mentioned artificial intelligence and the impact it could have on global health. So I'm wondering what sort of advice you have for the global health, global development community when it comes to being open-minded to emerging technology, things like AI and how it'll affect their work, but also perhaps not getting overly excited about innovations that don't necessarily have relevance yet in addressing some of these problems. So kind of, again, just advice on innovation, how it plays in this field when it comes to helpful someday or affordable, appropriate, accessible now.
Yeah, you gave the answer to your question already. Thank you. No, but it's really, I like that. I've been going and giving talks last year and the year before quite a lot to IT and innovation conferences and so on. I don't understand most of it, but I want to, and the reason I'm going there is to bring a message. These are the issues. These are the problems that we need help with, because people in innovation, that kind of innovation, they're driven by the innovation kind of, addiction nearly, but not necessarily by trying to solve a question. Because a lot of the products that have come out of, let's say, Silicon Valley and so on, they actually created the demand. It's not because there was a demand. It's when you think of it, it's quite extraordinary, and they've been very successful. And a big debate is always that a lack of understanding in the world of IT innovation, that in health there's so much regulation, and that side effects and whether something works and all that is very important, is a very big concern, who pays and all that. But on the other hand, I mean, this is particularly when it comes to, and my app will solve poverty, you see. But it may be different with AI, because artificial intelligence is already there in a lot of things. We just don't know, and we don't call it that way. But I think there we need to explicitly work together. And when you see most big companies in that innovation space, they're moving into health in a big way. But they're doing it often in and they're creating another silo now from the silo that we're in. So we need to bring you to come together. Maybe that's for next time, for an event around that. But just to break through the vocabulary that both of us have is already a challenge. Yeah.
Thank you.
And for example, one of my talks is two things. One is that the word disruptive and disruption is very positive in that world. For us, disruption is not something we want. That's a big epidemic. Yeah. And so it took me a while to find that out. And also talk sometimes about, are we prepared for the big one? The big one in California is an earthquake. And I said that will wipe out Silicon Valley. And then they all, oh, wow. For us, that's kind of the Spanish flu of the 21st century. So we need to bring that together, and I think that it's not weather, but then I think all leave our baggage at home and sit down and see what are the problems and how we're going to solve. Because they're very good at problem solving and actually waste far less time on what Freud called the narcissism of small differences that characterizes the health community and the academic community. Sorry, it's my psychoanalytic day today. Yes, yes.
Good. So let's keep the next three questions really short. And Peter, I would ask you to just...
yes, thank you. I just can't see.
We can do psychoanalysis later.
Yeah, I'm the coach. I need a coach.
We'll deal with that one later. Okay.
Thank you.
Please.
Hi, I'm Kevin Harris with the William D. Ruckelshaus Center. I'm faculty and a facilitator, a neutral facilitator, and the Ruckelshaus Center is co-located between University of Washington's Evans School of Public Policy and Governance, as well as WSU's Extension. So I was very heartened to hear both of our plenary speakers speak of collaboration. And I'm just wondering, as someone who works on collaborative problem solving and helping stakeholders, multi-sector stakeholders around health policy come together to solve these wicked problems, I'm just wondering, from your perspective, how deep into innovation is collaboration in your world, and how much further do you have to go in terms of process and structure?
The short answer is a challenge here, but I think it's the right answer. I think the mistake that we make is that when we talk about we need to have other sectors involved in health, then they say we set the agenda and we invite people from other sectors to our meeting in our place and then expect them to come up with solutions for our problem. And that doesn't work. So it's a bit around the same question about innovation. So I think it's really creating a common vocabulary space, agreeing on the questions and so on. Like in our school, we work a lot with the London School of Economics. They have a big program on cities, climate change and so on. And we spend a lot of time in this case just defining that agenda. And yeah.
Thank you.
Thank you.
Hi, Matt Doxey. I'm a population health analyst for UW Medicine. I wanted to thank Dr. Chen for bringing up antibiotic resistance, and I was wondering what your take was on that in regards to education and training and research in developing countries where there's competing needs and challenges. And oftentimes something like that kind of gets pushed down the chain on the priority list. And you're seeing a lot of re-emerging diseases that we thought we had under control or were on the path of controlling. They're now starting to come back with multi-drug resistance. Just curious about that.
Yeah.
Thank you.
In the UK, that's at the top of the list. It's the top of the tops, antimicrobial resistance for the UK government, with also several funds, and for example, the so-called Fleming Fund after Alexander Fleming, the discoverer of penicillin, and that aims to invest in infrastructure for laboratory surveillance, in most vulnerable countries, that don't have these capacities and really concentrating on antimicrobial resistance. My position is that it should be linked also with other investments that are needed for epidemic preparedness, for finding out what the causes of child mortality, etc. But I don't know about here, but in the UK, I tell you, it is the top of all global health concerns.
Thanks.
Great, thank you.
And it was driven by the Chief Medical Officer, Sally Davis, and Jim O'Neill, who was an economist and worked in Treasury. So it was that was a unique synergy.
Last question, short
Okay,
please.
Yes, Ami Bishop. I've been in global health for about 30 years, 25 years at PATH, and an adjunct clinical instructor here. My question is related to human rights, and in my experience over a long time, I think the general global health community has sort of an aversion to outright claiming and recognizing human rights as a fundamental need to be effective in public health programming, whether it is regarding women or trafficked children or LGBT people. There are always these groups who are left behind, who are left out of research, who are marginalized. And I wonder, in your 2.0, I was kind of looking for that, and I just wonder if you could comment further. Thank you.
Yeah, I agree with you. I think it may be a bit different between continents, but when I mentioned that the global health was in a sense was engendered by the AIDS movement, where the AIDS movement has walked on two legs in a sense, and that's what I always said when I was head of UNAIDS. It's human rights and the science and scientific evidence, and you need both. And when you talk about like the universal health coverage, that is primarily driven by a human rights concern. But I agree with you, it should probably be more explicit. But that's I mean, I would say at our school and that's a very it's a big driver, and because otherwise, if it's what is otherwise a driver for dealing with global health? It has to be based in human rights.
Great. Well, thank you, Peter. That was wonderful, and I think we really have a great kickoff for moving into our panels. I'm going to now ask everybody to thank Peter with me.
Thank you.
And now I would like to invite our first panel to come on up here. So both our moderator, Ken Stewart, and each of the members of the panel. So please come on up. And let's see. Great. Good. And we're now running a little bit behind, but I thought it was important to take advantage of our two plenary speakers and have a little time for questions. So I'm going to ask both of our panels to cut back a little bit on the discussion time that they have. And let's see, where did I lose Ken Stewart? He's getting a microphone. All right, well, good. While Ken is getting mic'd, I will introduce him. As we now move into our first, do you want a hand? Whoa. As we move into our first panel on pandemic disease preparedness and response, we have a terrific moderator for this panel, Dr. Kenneth Stewart, who is the president and founder of the Center for Infectious Disease Research, which focuses on discovery, with respect to new biomedical interventions for malaria, HIV, and tuberculosis, as well as for several neglected tropical diseases such as African sleeping sickness, Chagas, and leishmaniasis. He's also professor of global health and microbiology here with us at the University of Washington, and has played a leadership role in our pathobiology program for many years. His personal research focuses on the molecular and cell biology of pathogens that cause African sleeping sickness, leishmaniasis, and Chagas. And he has led the formation of an international genome consortium that actually laid the foundation for a number of major advances related to these diseases. He's also recognized internationally for his groundbreaking studies of RNA editing, which is a novel process unique to these pathogens that provides targets for drug development. Ken is also a leader in that wonderful local global health community that I've mentioned earlier. In addition to being a fellow of the American Association for the Advancement of Science, he's a member of the Washington Biomedical and Biotechnology Association Board and also of the WGHA Executive Roundtable. So please join me in welcoming Ken as our moderator for our first panel on pandemic disease preparedness and response.
Thank you, Judy. I didn't know I was doing all those things, actually. And I would say that I've kind of embarked on a new career, which is trying to learn immunology and apply that to the development of vaccines for malaria with the help of many, many people. So it's a very exciting time. It's been a fantastic beginning of this program. I only wish it's quite a large group here, but I wish there were more here to hear the fantastic comments that have been made. And I think, in keeping with the theme of learning from the past and preparing for the future, I think today's panel is really perfect for this. And it's really an honor to introduce the panelists, and I'll try to do that briefly, but give you a feel for this. And it's focused on pandemic disease preparedness. Pandemic disease is sort of a scary topic, and being prepared for that is a huge challenge. And our first speaker is Dr. Benice Dan, who's the Minister of Health from the Republic of Liberia. And she faced the Ebola outbreak. And, I think there was potentially a pandemic. And I think, there were huge efforts to contain that and prevent it from becoming a pandemic. And so it'll be fantastic to hear from her that experience, because it is an example of what can happen and how to respond to that, and how the international community responded to that. The next panelist is Dr. Michael Gale. He's a professor of immunology and the director of the UW Center for Innate Immunity and Infectious Diseases. In a certain sense, he's at the other end of the spectrum, but I think the spectrum, as Peter mentioned, is more of a circle than a spectrum. It's not an arc. And he is an investigator of the immune response to virus infections. And part of that notion of thinking of, what do we need to know to be able to deal with preventing pandemics, and also contending with the ability of even identifying what the threats are. The next panelist is Dr. Simon Hay. He's a professor of global health, and he's at the Institute for Health Metrics and Evaluation, IHME. He's an infectious disease epidemiologist and has an interest in, I'll call it mapping. It may be not what he would call it, but understanding the distribution of not only the diseases, but the response systems and how to be prepared to respond. And then the last speaker is Dr. Karayuk Njenta, who's at the One Health program at Kenya Medical Research Institute, which we like to call KEMRI. It always sounds chemical to me, but it's a fantastic institution. And he's also a professor of the Paul G. Allen School of Global and Animal Health at the University of Washington, and is focused on infectious diseases. And I think this illustrates a couple of things. These diseases do not have boundaries. The London School of Hygiene and Tropical Medicine, maybe it should be global medicine. I don't know, maybe they probably had that discussion. But it also, the One Health concept, I think, recognizes the plethora of factors that are influencing the very diseases that we're talking about. And I really like the notion that Peter brought up about getting out of the silos, and the silos, the conceptual silos of how we deal with these diseases, they need to be broken down, or disrupted, I'm not sure which. So with that brief introduction, I'd like to ask Dr. Dan to come up and make her presentation. Okay. There you go.
Thank you, ladies and gentlemen. Good morning to all. I'm very happy to be here this morning at my alma mater and to contribute to a topic that is very dear to my heart, pandemic preparedness and response, around a very interesting central theme, global health, next decade, next generation. We've heard from the first two speakers, Margaret Chan and Peter Piot, the same way we are challenging diseases and situations that affect human health is the same way those diseases and situations are challenging us. The West Africa Ebola epidemic exposed the deep inadequacies that exist in our collective efforts to protect the population, not only from the infection itself, but also from the human, the social, the economic, and political consequences that come along with disease outbreak. I believe today, globally, we all know the importance of preparedness and building systems that are resilient. The global health system is going through a rebuilding process globally. And that is because of the Ebola outbreak. And so today countries are focusing, and there's a very big push on implementing the international health regulations, something that most countries never took very seriously before. We have the Global Health Security Agenda and the One Health platform. All of those are to prepare for emergencies and to be able to respond adequately. The next public health event could be anything. It could range from a disease epidemic like Ebola. It could be chemical, biological, or nuclear. How prepared are we? The reminder. When Ebola struck, the three countries that were affected most had fragmented health systems, and so they collapsed in no time. Health workers who were on the front line, who went to fight the disease, most of them contracted the disease, and a good number of them died. Routine healthcare services also ceased for a while, and so more people died from diseases that could have been treated compared to the number of persons who died from the Ebola virus itself. That is a very big lesson. There have been many efforts to document lessons learned from the epidemic. It will interest you to know that the countries that were impacted most, their voices were not in the forefront from the different high-level commissions that were established to study the crisis. So that should stay in our background. If we should learn from the past, the history of HIV and other health conditions, the lesson is that the conditions are managed better by those who manage the situation and those impacted most. Now, where are we today globally? Well, recent studies shows that we are very far from being adequate to respond to emergencies globally. The World Health Organization established that in the last decade, there were about 55 different outbreaks. 42 of those were in West Africa. West Africa is also disproportionately affected by HIV, TB, malaria, and neglected tropical diseases. And all those have the potential of also causing outbreaks, especially considering the fact that there's increasing resistance to antibiotics and insecticides. And so West Africa is sitting on a time bomb and could be a threat to the globe. Well, in July last year, in Liberia, we convened a high-level ministerial meeting to look at all the different studies that were commissioned around Ebola, look at the recommendations, and see if there were things that were missing. And so there were 45 different studies that we looked at. And some of the recommendations were the same, but they include, the first one is the central to all the reports was country ownership and country leadership in the response. Now, it will interest you to note that very little in almost all those reports was mentioned on the regional efforts to enhance surveillance activities by the West African Health Organization and the World Health Organization, supported by the World Bank and the countries themselves. The second thing that was recommendation, the public health emergency of international concern should have been more timely. That means surveillance and alert systems in the countries are central to this capacity. Women and children were disproportionately affected during the crisis. If you recall, we said health services ceased for a while. And women and children are the ones who use health services most, and they are the most vulnerable. It will also interest you to note that only one of those panels did mention the impact and the sequelae of the crisis on women's and children's health. And that was the high-level panel, the UN high-level panel. So it's also worth noting in the discussions and the planning moving forward, the emergencies that come within the emergencies as it relates to women and children. Donor coordination is an ongoing area of concern in our region. And there's a need to organize activities around that. And there's a need for our collective voices to be heard. Then we had a cross-border trade and trade disruption, and that impacted our economy seriously, to the point that we could not even respond to the emergency. Now, how are we using organizations that cross across sectors, that work across borders and countries, like the ECOWAS, for example? We need to keep that in our mind. As we continue the discussions here for the next generation, I want to keep the West Africa experience in the center as we prepare the perspective for the future. Thank you.
So what we'll do is we'll have each of the panelists make a few comments, and you can remain in your chairs. We can hand the microphones around. And so, Michael, we'll have you speak next. Okay. Maybe we can each hand the microphones around.
Yeah, thanks,
Thank you.
Ken. It's wonderful to be here, and that was a very nice talk. Thank you. I think the preparedness for pandemic in the global stage is a big, complex issue that requires several levels of work by several different groups within a tight network of communication. And the Ebola outbreak is a great example of that. But it even goes, these examples go back even further to times when it was just being discovered. For example, hepatitis C was mentioned earlier. And this is a virus that we've almost got beat, but we're not there yet. Hepatitis C came out of the woodwork when the guys came home from World War II. And it wasn't understood, but these folks were being presented in the clinic as a hepatitis physicians had never seen before. And it was only classified by doing blood work as not hepatitis A, not hepatitis B. So it was called non-A, non-B hepatitis. At that time, historically, it started from a small network of physicians, mainly at the National Institutes of Health. But it built into a global research area that involved communication between physicians and scientists, technicians, healthcare workers actually in the field isolating the virus at new sites around the world. And what happened was it developed into this big global effort focused on understanding this pathogen. The early days of that outbreak were all about trying to define what the pathogen was, and we see that over and over in new outbreaks. The middle days of the outbreak were trying to really focus down on what does the agent do to the human body. And this is a fundamental aspect of all infectious disease outbreaks, to try to understand the nature of the beast. So the foundation for this boils down to what we call Koch's postulate. And these are 4 postulates that have been around since Robert Koch, a German microbiologist, built these. Around 1890, they were published in a series of papers. But to determine that a microbe causes a disease that we all might be experiencing through a pandemic outbreak, one has to have the facilities in place and the communication infrastructure from the field workers to bring to the research lab, if you will, putative isolates or clinical samples that may have the microbe present in them. That has to be isolated, postulate 1, and associated with the disease, statistically associated with the disease. That's very important because over the years there have been red herrings. For example, influenza A virus is called influenza because it was first thought that Haemophilus influenza caused the flu. So that was a red herring because they jumped ahead of the game and didn't work to fulfill Koch's postulate. The second part of Koch's postulate is to grow the organism after isolation in pure culture. Then the third part is to take that and inoculate it into a test subject, could be an animal or a human, or an appropriate cell culture model that will recapitulate disease, and then re-isolate the fourth part is to re-isolate the organism and culture it. So I sort of list these off because in the Global Health 2.0 is going to be all about maintaining these lines of communication, enhancing them, going into the digital age with them in places where the digital age hasn't arrived yet. And then the second part of that is going to be about maintaining state-of-the-art clinical and research infrastructure. And I can't put enough emphasis on that because the facilities where work would go forward to fulfill Koch's postulate, for example, if a new microbial infection happens to arise, we have to have facilities to do that. And not only here in Seattle where we have terrific facilities, but Liberia and other places around the globe where there's a need for this kind of facility. And then the final point I want to make is all about training, because we have to staff the facilities and train the medical, scientific, and technical personnel to maintain these lines of communication and basically build, if you will, the Global Health 2.0 network. So I think I'll move on, and those are things I've been thinking about the last few days and sort of came to light in our opening talks. Thanks.
Thank you, Michael. So, what we'll do is we'll have Simon now have a few comments. I can see a number of themes emerging here, and probably we'll have a nice, lively discussion after each of you complete your remarks. Good, Simon.
Thanks for the opportunity to speak today. My name's Simon Hay. I'm Director of Geospatial Sciences at IHME, the Institute for Health Metrics and Evaluation. Geospatial sciences, as we heard, is basically mapping things. And I'm a Professor of Global Health here at the University of Washington. I'm going to just open by phrasing lots of questions in the kind of things that I do, which is trying to put evidence together to look at the distribution of risks of various diseases across the world in this pandemic theme. So I had a whole set worked out on when America coughs, the rest of the world gets a cold. However, pandemics have a very good way of democratizing that phrase, and I thought it was even better in this room to say, when Peter coughs, the rest of the room starts to worry. So on that theme, it's what I'm going to try and do is just talk about some of the pandemic threats that we have and think about what evidence we can assemble in what I colloquially call peacetime, when we're not having to be in this emergency phase of a disease. And that comes to of a disease outbreak that has a potential to cause a pandemic. And that comes up to my first question, which I don't think we know the answer to yet, which is, why so many now? Why is the frequency of these things changing? And which ones will be next? All very, very important questions, but very, very hard to answer. And we have a whole ragbag of conditions, some old foes that we've heard about already, influenza and yellow fever, that still are specters of disease, and yellow fever particularly causing problems in Angola and Brazil, and in places where we would have thought they had long been under control. We have diseases that come out and are completely novel to science, so SARS and MERS, or ones that we've known about and have been isolated in small locations, Ebola, Zika, chikungunya, etc., and then decide to take a global march. So there are a whole range of problem diseases out there for which we have some knowledge. There are a whole range of diseases out there that are just waiting to make their life in human beings of some description. So how do we go about prioritizing among all the known and unknown diseases about which ones that we should worry about most? The way I like to think about that, and one of the things that I think we can do in peacetime, and one of the things that we're very well positioned to do at the Institute for Health Metrics and Evaluation, is to start putting some evidence around all the things that are common to disease outbreaks. So although there are many different diseases and there are many different pathogens that we might worry about, they all have some distinct stages which have perhaps predictable properties that we might think about. So most of the diseases that I've talked about have an animal reservoir, and there is a stochastic event which we don't understand very well for many of these diseases that pushes from the animal reservoir into the human population where it can then transmit. So having a much better idea globally about the relative risks of outbreak potential in particular locations for a whole range of pathogens is one of the things that we're very interested in trying to build the science and evidence around a bit more. Then when this pathogen breaks out into a human, that index case, the propensity of that human to infect others around is affected by a whole lot of factors that we can also get very good information on. So is that person likely to go to the formal health sector, or is that person not able to access those sorts of facilities? Well, that kind of information we can get extensively and map, and then look at the relative risks of an individual outbreak turning into a small and local epidemic. Picking up on some of the themes in terms of urbanization and population movement, we now also have very good information on where all the people are. Well, it's relative, but we have quite good information on where the people are in the planet, and also increasingly good information on how they move. So we can start to build systems where we can look at the relative propensity of a local epidemic to come and cause national level problems. And then coming back to when America coughs, or any country, you can now substitute for America, the rest of the world sneezes, we have very good information now on how people travel around in aeroplanes and how they can infect the rest of the world. So there is a whole body of science, I think, that needs to look at that and look at those risks. And it's not the primary concern of many in the American media or the UK media, where I hail from, of those diseases coming from the south. That's the biggest concern for me. It's the very, very large movements of south-south communication which tend to get lost in that dialogue about international migration. So I'm going to leave it there and hope that that's given a few bits of food for thought on themes that we might pick up.
Thank you. Kariuki, you next, and I suspect his mention of animal reservoir probably got your attention.
Thank you very much. Again, my name is Kariuki Jenga. Just for your background, I worked with CDC as the director of a program in Kenya called Global Disease Detection for 8 years before I joined Washington State University. Some of the things I'm going to say are really backgrounded, or at least informed by my years of working in CDC and dealing with a number of outbreaks in the continent, including the H5N1, Rift Valley fever, and the 2009 H1N1. And I think my first comment is, to say that I think from just dealing with the recent outbreaks, preparedness works. And I think one of the best examples is the 2009 H1N1 pandemic influenza, in part because the world had invested a lot of resources from 2006 preparing for H5N1. And it was very well informed that when we did actually end up getting the 2009 H1N1, at least in Africa, the continent was well prepared. In the countries that we had the disease come, almost in all countries, the outbreak was detected within a week or 10 days and fairly effectively contained in the areas that it was detected. I think it was a good example and a good indicator that if we prepared for some of these diseases by investing in what we know and the disease we have dealt with, we are better prepared to be able to be ready and respond to some of the unknown diseases we don't know. I think my second comment is informed by Dr. Chan's speech this morning, which was really informative. She talked in part about the recent pathogens that we have dealt with, and she talked about some of the new ones like SARS, H5N1, H7N9, and also recently MERS coronavirus. But she also did talk about some that are not new that we call re-emerging, like the Ebola outbreak, Zika, and yellow fever. And if you were for a moment to give the world a grade of responding and look at how we responded to SARS, if that is informed by the time, from the time we see the outbreak to the time we contain it, you would give us a fairly bad grade on Ebola in West Africa. And that's not a new disease. We knew enough about Ebola to be able to respond to that. In fact, it wasn't even a new strain of Ebola. But again, we did not do a good job in responding to that, and one wonders why. I think this informs to the fact that I think if we really want to be prepared for the unknowns, and I would argue that one of the surprises we're going to continue to get as we wait for outbreaks is going to be the fact that there will be many new viruses, but there'll be a lot more outbreaks of endemic disease that we know about, changing their patterns because of the changing ecology, climate change, and others. So I think our preparedness needs to be informed by investing in the systems that we have and responding much more effectively. And I think one of the things is to continue to enhance collaboration between the human and animal health sector, and not just in the research forum, but more so actually in the government systems and responding. And I think that is beginning to change a little bit, because we all know that when we get trained, whether you are doing animal medicine or you're doing human medicine, we have these silo systems that we really can communicate. It is even very difficult for a veterinarian to call a medical doctor in the same sector to tell them about a rabies case or a brucellosis case, which are endemic. I think to continue to enhance that collaboration and create a collegial environment for those people is going to help us understand and detect some of those diseases earlier before they can spill over to humans. And the second part, I think, that would enhance our preparedness is to improve our capacity on the animal side. In all the countries, even the most developed and more so in the non-developed countries, you would realize that the animal sector, as far as disease detection is concerned, is always under-resourced, significantly compared to the human sector. But that then means that we always must wait for the outbreaks and the disease to jump over to humans before we can be able to detect them effectively and respond to them. And often that is too late because the disease has festered and spread significantly. So to the extent that we really want to detect these early, we need to invest a bit more resources in surveillance in animals to be able to detect these diseases earlier. And my last comment, so that we can open this up for discussion, is on diagnostics. If you look at HIV and how much funds have been invested from the PEPFAR program, and also other diseases like Ebola and others, we have made very good advances on epidemiology, early detection, isolation, but the area that has lagged behind is diagnostics, simply because of the cost of developing diagnostics and the cost of actually having effective labs closer to where the outbreaks happen. More so because outbreaks do not happen in urban areas. We have good labs, but actually in rural, remote, hard to access areas. So I would argue that the future of being more prepared for pandemics is being more creative and thinking outside the box as far as diagnostics are concerned. I think we need to start thinking about maybe rapid diagnostic tests or other tests that don't necessarily have to require the advanced and the very difficult system to set up in remote areas of the current and modern diagnostics as we know them, whether you're talking about molecular diagnostics or serological diagnostics. They are very difficult to set up. Even when you invest in the labs, sometimes the resources are not easily available, and we know that very well. Even for diseases that are very old, like leptospirosis and others, you still can't get good diagnostics. So we need to think about how do we improve early detection and diagnosis of diseases, probably that does not always think about the old method of just relying on the lab and the tests that we do. And I think that would improve our abilities to detect earlier, confirm the outbreaks later, and maybe just rely on the labs for confirmation, but not for early diagnosis. Thank you.
All right, well, thank you, all of you. We're going to have a little experiment up here, a little surprise experiment. We're all going to try to get out of our silos. And what I'm going to do is see if you can self-organize, because I'm sure all of you have been listening to each other's comments. And so let's see who would want to respond. Maybe just stick your hand up so we can know who would want the microphone next. Bernice, I thought I saw you lean forward and ready to respond after Michael's comments. Maybe, would you want to begin? Yeah. Did you put it on? Make sure it's on. Tap it. Yeah, I think it's on.
Oh, okay.
Okay, thank you.
Well, thank you. I think what I heard from Michael in the summary is to have a strong system that can respond to emergencies. That starts from a surveillance system that is strong, that can alert, and then a system that can respond. The response system should have a laboratory that is equipped, that can do the kind of studies that are required to confirm the condition for the response to be effective. That system in itself is also expensive, and many times the resources are not there to do them, ranging from human to equipment to the infrastructure itself to be able to do them. Now, some of those things, capacities need to be developed in country. But again, some of them can also be done regionally to assist countries to be able to address conditions that are crucial to them. So I think as we look forward into the next decade, working together globally, we also need to network on issues that are regional, that can help countries to be able to respond adequately to situations that may arise. Thank you.
Okay. Let me just touch on that a little bit, because one of the earliest remarks, I think, touched on the idea of who should take responsibility or control of a situation, especially initially, and therefore take ownership of it, but also communicate with others. And maybe based on your somewhat recent experience, you could address that issue, because you've made it clear that it's those who are primarily affected should have probably the primary role, but obviously would need some or appreciate some assistance.
Okay, thank you. Well, outbreaks occur in countries. And so that's the first point of contact. The country must be able to identify an outbreak and must be able to report that outbreak. In some situations, the country might be able to respond to the outbreak, but there might be situations where the country may not be able to respond to the outbreak, like it happened with Ebola. So in that case, the country should be the one asking for help. What you normally see is an influx of people, and sometimes it's like parachuting. A whole number of NGOs running into communities to do work, and sometimes they don't even touch base with the host country leadership to do things, and so it becomes chaotic. So, and then there where the whole coordination issue comes in. So it's better for the country to take the ownership. You report your case, you tell the world how much strength you have and what you need, and they come to your aid.
Okay. Others?
Well, I think those are all good points. The main thing with the Ebola, from a bystander watching the response to Ebola, my group, we work on Ebola, but we weren't at the site where the outbreak was happening. There seemed to be a lot of interaction from many groups that appeared to be quite disorganized. And having a global pandemic response network that goes beyond the World Health Organization, that is actually a functioning body with the agenda to travel to sites and set up an organized response. I don't think the world has something like that now. If it does, perhaps we can discuss it, but a rotating body of experts who could be placed at a site and transition it into outbreak response that meets very strict criteria for containment and characterization, and ideally getting to the point of discussing or planning an intervention. So it seems to me that a body of experts like that could have been placed on site as soon as a country called for that kind of help would have made a big difference in the speed of the response, as you mentioned earlier.
Thank you. Jim, do you have a, go ahead, Simon.
I'd like to pick up on your theme of diagnostics and to say that they're not siloed, and they're something that I have to deal with in the sort of epidemiological and mapping side every day. So we're looking at trying to help understand the current Zika outbreak in certain parts of the world. And one would think that the diagnostics of yellow fever, Zika, and dengue were all well sorted. They're absolutely not, and it's the devil's own job to try and disaggregate from information that comes in at the moment in the midst of an epidemic as to whether this really is an uptick in Zika or it's more dengue that's getting classified. So diagnostics are a problem across all sectors because they primarily affect the quality of information with which we're making decisions. I'd also like to pick up on the theme of the strong response network, and I think networks to respond are great when they're empowered by good information. And bringing us back to one of the themes that Margaret brought up is that information is incredibly important, and the free use of information by as many people as possible is absolutely critical in these situations. And it's not always something that the global public health and global health community is as good as it should be at making data available. And that's one of the things that we're really trying to do, is to make as much information as possible available to as many as possible. And I'll just say with one just note perhaps one thing. Would you expect that there should be one central place where we could go to and say, this is where every health facility in the world is? Does that exist? No. Very simple audit of what we have. It just isn't there. And in every emergency situation, the first thing that people seem to do is get that basic infrastructure information. Why shouldn't we be doing that now?
Yeah. So, excellent comment. I think it illustrates something that I've noticed over time. There are many things that you can envision should be in existence, and they're not there. Sometimes it's because you can think of it faster than it can be done, but I think, it's that sort of question that I think can stimulate the creation of some of these groups. So I'd like to follow up on your comment about information, the importance of information, and just 2 points. One is we live in the information age, but not all information is of equal value. So I think that one of the issues you might comment on is the accuracy of the information that you probably have to contend with. And then I think the other thing, and maybe it touches on the artificial intelligence comment that came up earlier, are we in a position, or could you conceive of us being in a position where we could use that information in a predictive sense for some of these outbreaks that are coming?
In terms of dealing with differential quality of information that is made available to people, I mean, that's one of the, I think, the fundamental jobs of an epidemiologist. So, and there are many different ways of doing that. I think what needs to be recognized is that cannot be done in isolation. That really is another example of where you have to have brilliant collaborative networks, so you understand how that data were collected, you understand all the biases that were inherent in that process, and then once corrective and or statistical algorithms have been put together with that data to make its information more or less biased or more or less fit for purpose, that information needs to be rapidly shared back with those that can use that information to make better action. And that cycle, that virtuous cycle, is not perhaps as virtuous or as cyclical as it might be in many cases. And that's one of the things that we're trying to do with making the various repositories of global health information that are stored at the Institute for Health Metrics and Evaluation as widely gathered compliant and as widely available to as many people as possible for the data visualization tools there. And our mapping work, when it gets to enough of a maturity along a whole range of themes, will feed into that, both in pandemics and others. The other thing that the sort of the concept of big data and lots of new information types becoming available, I tend to see people silo in one way or another. We either like a new source of information or we don't. And I think that's a slightly false dichotomy. And of course what we're after is big signal, not big data. We want to know, we want big information. We want to have actionable units of information. And I think some of these sources of information are going to be very, very interesting to us. I mean, if you are a software company that has information on 1 billion users and how they move around the world, that information is highly epidemiologically insightful. One has to use it in correct ways and have all the IRBs and things associated with it, and that information needs to be made available. I think that's one domain where there could be an awful lot of additional information provided about how people, and particularly our target populations, move around the world. So I think there are opportunities for bringing in novel data sources, but in some of the more excitable audiences that I've seen in that domain, they will never replace, in my humble opinion, the classic health information systems that we deal with, but they could be a useful augmentation of it. So I don't really see it as an either-or contender, as some might, and that we don't need to disrupt perhaps decades of very well and tried and trusted surveillance, but maybe augment it with some new things as they come along.
Yeah. Great. Good.
Yeah, just to make a quick comment on the whole issue of data and prediction, risk mapping for diseases. I think we are moving towards that, but when you begin to use especially some of the historical data and even data that is being collected to inform and use that mega data to try and predict or develop risk maps, one of the things that you realize is the gap that there is emerging and fairly good data now on human health, largely driven by WHO that developed this IDSR system, part of IHR, that has really created a lot of good data. But if you go to the animal side, it's absolutely lacking. And if you wanted to begin to use that data to understand that, most of the countries don't do systematic surveillance in animals. If you go to wildlife, it's even more lacking. There's virtually nothing. There's nowhere you can go, no database you can go to begin to collect data. So I think for us to move towards talking about prediction and being better prepared to be able to map and anticipate pandemics, then we also probably need to think about better systematic collection of data on the animal side, particularly also on the wildlife.
Well, I would just carry you down to the community level also. The information generation starts also from the community. And so a system to identify and collect the information from the community level is also crucial to the whole system. Normally there are simple case definitions that community members can actually use to classify a case. And that is normally followed up when they elect a system by another team that will go back and investigate what they have provided and also classify the situation and then can pass it on to the higher level, maybe to laboratories and things like that, for further investigations to confirm what it is. So it's a whole range of systems that need to be looked at from where it starts from up to where the decisions are made.
All right, thank you. So we oddly enough, seem to be on time. And so now will be a time, I think, for audience members to ask some questions. I think there have been a lot of stimulating points made. So if those of you who'd like to ask a question, if you'd step to the microphone. Okay.
Yeah, Andy Strigachis, faculty, Global Health and Pharmacy, University of Washington. And to launch an effective response to a re-emerging outbreak or another outbreak implies we have something to respond with. And when it comes to priorities for either drugs, vaccines, other public health measures, and getting them where they're needed, what advice do you have? What are your thoughts about where we should be putting our efforts today, recognizing that outbreaks are inevitable, we may or may not have the right medicines and vaccines, but maybe we do, but how do we get them where they're needed? What should we be doing now?
Okay, the first thing is to maybe consider the specimen from the beginning, sharing specimen. That has been a very big challenge also. Sometimes there's an outbreak. Countries have the specimen. Specimen need to be available for research, but the specimen is not being shared. And once the specimen is not shared, the research and to provide, to develop the vaccines and the drugs will also lag behind. And so there's a need for a system to be able to share the specimen for research, and then the things that will follow subsequently to follow, like vaccine development, medicine development, and things like that.
So one question I have is because there's obviously a reason why the specimens are not shared. Often people concerned about economic interests. So do you envision some mechanism to deal with that conflict?
Well, maybe
Other than trust. I mean, trust is very important, obviously.
maybe collectively, if we see it as a responsibility globally to address these issues, because it could start with me, but it will end up with you, then we should have a common interest. And that common interest should supersede all the economic interests to be able to make headways.
Yeah, there are politics involved. There are heavy politics involved in getting specimen from one country to another one. And even today, we can't get specimen from countries just for research use in the United States. So that's almost beyond the scientists and clinicians spectrum and has to be brought up by public health politicians, if you will.
Right, policymakers.
Yeah.
Right.
So just a quick comment to the original question about what we do about responding. I think one of the things that I think driven largely by WHO and FAO is creation of rapid response teams in the countries. Sometimes I think the response to an outbreak, you don't necessarily have to have the control measures. You don't have to have the vaccines. You don't have to. I think responding quickly saves lives, sequesters the outbreak, and prevents spread. And I think sometimes one of the biggest problems is there is lack of those rapid response teams in a timely manner to be able to understand what you're dealing with. And I think countries are beginning to do that. And the second thing that maybe should be encouraged is creating some repositories of some of these prevention tools, the biologics like vaccines and others, and having them kept by the international organizations like WHO and FAO as repositories in very strategic locations. Because it's really always very hard to get them out of a country when you're in time of war, because everybody is worried that this outbreak would come their way, and they are very unwilling to share that particular point. But if you located them with international bodies, then they are more likely to be accessed by the countries that need them most.
Okay, thank you.
I am, of course, going to say this, but I think we also need to know in much greater detail the spatial distribution of outbreak risk for many of the diseases that we at least know about. Ebola would be a great case in point there. So we have approximately 30 outbreaks of that have been recorded and are known to the literature in about 7 countries. We know from some very simple analysis that if we look at the conditions that support those outbreak risks in those 7 countries, there are actually 20 African countries that have very significant outbreak risk, including the West African ones and the Liberian ones that we've heard about today. And we could have known in advance that this was definitely at the start of the epidemic, a plausible pathogen to be worried about in these locations. But because they're new in these environments, there's a whole range of both through all levels of the system, through those populations affected by the disease to those managing the disease at international levels, of a lack of understanding about that particular environment is permissible for that disease. And we may now have a better idea about that for Ebola virus disease, but what about Nipah? What about Hendra? What about Zika? What about et cetera, all of those other ones? Do we really have a good idea about where the global distribution and outbreak potential is? And I would contend not.
Okay, thank you. You have a question?
Hello, I'm Emily Turner. I'm a researcher with the London School's Anthropology, Politics, and Policy platform, and I have a question largely for Minister Dan. I was wondering if you could touch on any challenges you face shifting from the very short-term clinical and biomedical response to an outbreak to the longer-term repair and recovery of the health system and of communities.
That's what she's saying.
Well, thank you. During the outbreak, when we were responding to the outbreak, we had to also think on what will happen in the future, how we'll move into the future, sustaining and building systems. And so with the outbreak, we were helped to establish the incident management system, the emergency operations centers, and those are operating today. But moving in the future, you establish incident management system and EOCs when there's an emergency. So there must be a structure that continues to monitor and track diseases and bring potential diseases that have epidemic potential to your attention. So for us, we decided to establish a public health institute. We have an act that has been passed, and we will reorganize around that. So the Public Health Institute will be responsible for disease surveillance and response, especially the active disease surveillance. It will be responsible for public health research. It will be responsible for the public health reference laboratory. And then it will link to universities to train the requisite staff that is required. That is moving into the future to sustain the gains made and to build on what we have now.
Okay, thank you. Question over here.
Yes, my name is Ellie Graham. I'm a retired pediatrician on the faculty at UW, and I've had the privilege of working in Liberia and teaching since 2009. So my question is, how prepared is the University of Washington and other academic medical centers to contribute their resources immediately and respond to disease outbreaks? And by resources, I mean allowing their personnel, their faculty to go there, providing supplies, providing technical assistance, sharing research findings that might be very relevant to that particular outbreak. And I ask this because it was very apparent in the Ebola outbreak that the academic medical centers, especially in the United States, were not at all prepared to move into that situation and provide any support.
Well, I can tell you that all the stuff that you brought up is very important, and those are activities we'd love to have the money to do. So there's simply, from my point of view, there is no money in academia to support that kind of work, unless it comes from specialized institutions that want to fund academics to go to sites and conduct those activities. On the other hand, the University of Washington is well poised to contribute to an outbreak effort because of the facilities and the personnel we have on hand and the tool chest we have in infectious disease research and clinical activities. The University of Washington has a state-of-the-art biocontainment facility that was completed a couple years ago, 17,000 square feet of high containment lab space, which is almost unique to the world except for a few sites. WSU has a animal agricultural facility very similar. So the state of Washington is poised to contribute on the research and translational medicine side by use these facilities and the tools we have and the experts here. But like I said, from my point of view, we don't have the funding to send those experts on site and do field work and bring samples back. And we rely on the World Health Organization infrastructure and other bodies for that kind of activity.
Thank you, Michael. We're getting close to the time we have to stop, so maybe if we take two more very brief questions, then that'll be fine. Okay. Go ahead.
Thank you. So to Dr. Bernice Dan. So I'm Eileen from Global Health MPH program in UW. You talk about ownership of the country in disease outbreak response. So what kind of role should NGOs and other international humanitarian agencies play in emergency settings? And what kind of mechanisms are there now for more efficient cooperation? Thank you.
Country ownership. Normally you expect that the country, especially the government, should be in the driver's seat. When you have NGOs around, instead of giving the government the chance to even announce outbreaks, they want to give the information, and many times there is misinformation outside there. So that's the first thing. The government should be the one giving the information. The government should be the one coordinating the NGOs and asking you to help them where you can help them most based on your strength. So there's room for partnership. But the thing is, it is necessary that you give the government the ability to, you give the government the chance to play its role as a government. That is what is important in the whole thing. It is different from just going and doing, and sometimes the government doesn't even know you are there. Thank you.
Thank you. Okay, one last quick question.
My name is Tricia from the Athena Initiative, a global network working on gender equality and health and human rights. So my question is to all of you, and I need your reflection around community engagement and movement building. One of the reasons is because most of the time we'll see a lack of prioritizing and looking into the needs and the wants of the community before we do research or respond to any epidemic. There's also lack of investment in community participatory research, and in our response to HIV, we have seen that this has been very critical. So I'm wondering how you think we can learn from the HIV movement and response, and also what you think we need to do to enhance collaboration, partnership, and even coordination. Who can do that? How can we invest in more community interventions when it comes to epidemics? Thank you.
Thank you.
So I'm going to address that question a bit broadly, so I may not answer the question as directly as asked. But I think the broader part of that question is, how do we make sure that we involve the communities and the stakeholders in an area that are affected by the disease? And I want to give an example of the issue of just prioritizing disease and what the country should be focusing on. If you go to all these global meetings that we go to and you're thinking about disease like zoonosis, for instance, and you ask the global community, what should we be focusing on? More often than not, you're going to get a consensus that we should be worried about the big diseases, the Ebolas, the Marburgs, the Lassa fever, and all of that. But when we went and did an exercise of prioritizing zoonotic diseases in Kenya using the stakeholders, including public health officers and local people, what emerged was a completely different picture. The first of this, the top 6 diseases were completely endemic, including anthrax, trypanosomiasis, rabies, brucellosis, non-typhoidal salmonellosis, and Rift Valley fever. Diseases like Ebola were number 24. Marburg was number 26. Lassa fever was the last disease in number 36. So I think what that tells us is that sometimes we come with all this information and we want to impart that on the communities, but I think sometimes their priority is completely different. I think maybe we should allow the countries to inform some of the researches that we want to do in the countries.
Quickly.
I'm going to range a bit more widely than pandemics, particularly there, but precision public health and making health metrics available at the most finest granular level to communities is something that is very close to my heart and my institute. And I think as part of global health too, making that information available and empowering communities is the best place that we can be for allowing people to make their own decisions in their own contexts. And in exactly coming off of that statement there, having an evidence base by which to properly prioritize the diseases of interest locally is the way that we're all moving.
Okay. Well, with that, I'd like to thank the panelists. Obviously, the discussion continues. Thank you, Judy.
Well, thank you to all of our panelists and to you, Ken. You know, one of the signs of a really good conference is that people just want to keep going and you're running a little bit late. So we're definitely in that category. A couple, 3 things. We are going to take a break now, but we're going to shorten it because it's more important to have more time for us to talk as we've been doing. So rather than 20 minutes, I'm going to ask everybody to be back here at 10 past for our next panel, which is on non-communicable or chronic diseases. So 10 past 11. I want to point out that there is a table of materials right over there, materials from each of the partner organizations. I would invite people to go and explore that and take things from it. And then there are seats, we have a whole overflow room and there are people in there, but there are now seats that are opening up here, so I would invite people to come back in here. Go grab some good food and then come on back 10 past 11, please. I would like to invite people to start to move back toward seats. I know this has been a very short break, and I apologize for that, but we have a wonderful panel to get started, and we have almost all of our panelists. As soon as we have Rachel Nugent up on the podium, we will be ready to get started. All right, now we're ready. There are lots of seats up here, so please come on in. And we are now ready to move into our second panel, which focuses on arguably one of the toughest challenges that we face, focusing on chronic diseases in an environment in which we really do not have health systems prepared to address them. For this panel on prevention and care of NCDs, our moderator is Bindya Patel, who is Deputy Director for Public Health at PATH. And in that capacity, she manages a portfolio of projects in health systems, infectious diseases, maternal child health and nutrition, and, very relevant to this, NCDs. Since joining PATH in 2004, Bindya has advocated for new HIV prevention options for women with the Global Campaign for Microbicides. She's helped manage projects on tuberculosis in Tanzania, and she launched the PATH Center for Malaria Control and Elimination. Before coming to PATH, among the many other things, many other wonderful things she's done, she worked on child nutrition in the townships of Cape Town. And her commitment to women's health includes serving on the board of the National Women's Health Network for 8 years and chairing it for almost half of that time. So it is a real pleasure to welcome Bindya as moderator for our second panel on the prevention and control of, the prevention and care for NCDs. So Bindya, please.
Thanks, Judy.
Take it away.
Thank you to the Department of Global Health for having us, and congratulations on 10 years. It's really great to be here as a part of that celebration, and you all are such a valued partner to PATH, so it's great to celebrate with you. And I just love that, what do you do for a birthday celebration? You spend a day with geeky panelists. So it's like exactly our style, I think. So though we may not be known for it as much as our work in infectious diseases and work on maternal and child health, Seattle has this huge expertise in NCDs, and I'm thrilled to be here to present a panel that is complete with talented and accomplished panelists that come from very diverse backgrounds, and it's exactly that, those diverse backgrounds that are needed, that we've learned are needed to address NCDs. I absolutely agree that the word non-communicable diseases just doesn't quite match what we need to be able to go into the next decade. And there's actually a discussion in the Lancet, and people are invited to bring their ideas for how we can change the words to really match the breadth and needs that are involved in this field. But for now, we're just going to go ahead and use NCDs even still. One of the things that I just, in preparing for this panel, the thing that has really struck me is that the NCDs shares, and this is something from a recent Lancet article, though NCDs shares all of the ideological and social justice issues of HIV and causes 30 times more deaths, it still receives 17 times less funding than HIV. And I think it's really thinking about how can we bring NCDs even more to the forefront in global health, and how do we address the challenges that are coming up in the next decade. So let me jump in to really quickly introduce our esteemed panelists. Their full bios are available in your packets here, so I'm just going to touch on a couple of the things that they are doing and have done, and then really focus on the meat of the topic. So Dr. Craig Rubens is a pediatric and infectious disease specialist at Seattle Children's and a professor of global health and pediatrics here at the UW School of Medicine. He's co-founder and executive director of GAPS and is really doing some fascinating research into the connections between pregnancy and NCD risk. Rachel Nugent at the far end is the vice president for global NCDs at RTI International. And before at RTI, she was an associate professor here in the Department of Global Health and just director of the Disease Control Priorities Network at the University of Washington. A special note to the students in the audience that Rachel and Path are always looking for interns, so come chase us down at the lunch break if you're interested in working on some of these issues. Dr. Ali Moqtad, to my left, leads the survey and surveillance activities at IHME. Before joining IHME, he worked for over 2 decades at the CDC in several different roles, including in the Division of Nutrition and Physical Activity and the National Center for Chronic Disease Prevention and Promotion. And finally, I want to introduce Dr. Ala Alwan. For the past 5 years, Ala has been the WHO Regional Director of the Eastern Mediterranean. Before this, he was the Assistant Director General for NCDs and Mental Health. Previously, Ala was professor and dean at a medical school in Baghdad and also served as the Minister of Health and Minister of Education for the government of Iraq in 2003 to 2005. I want to say a special thank you to Ala for braving the complications of traveling to the United States at this time. It's a very tumultuous time in our country, and we're really happy to have you in person instead of via video Skype and beaming you in from Geneva. And luckily, it only took him 5 minutes to get through immigration yesterday. So please just ask Allah to really set the stage for us. Where are we at right now in NCDs, and what do the challenges look like? And then after that, the panelists will talk a little bit more about where we go from here.
So thank you very much, Bindia, and thank you also, Judy, for this great invitation here to this very important event. And let me also congratulate the University of Washington for the great contributions and the impressive achievements made in global health over the past 10 years. And thank you also for including NCDs or non-communicable diseases as one of the key topics in today's program. I think this event comes at a very critical time in the global campaign against the so-called non-communicable disease. There's no perfect word for this. I mean, we've been struggling with this for years. Chronic diseases has problems, and NCDs has problem. I say it's a very important time for NCDs because a major breakthrough took place in 2011 when the United Nations General Assembly met at the level of heads of state and government, and they endorsed a very important political declaration at that time, which provided really a very clear vision and a sound roadmap on the way forward for countries to address NCDs. It was a breakthrough because it resulted in a tremendous improvement or increase in awareness among policymakers. So before 2011, the priority given to non-communicable diseases was completely different from today. But as I said, also it was important because it provided a global vision for the way forward. Now, despite this, the problem we have now is that the progress in translating the vision and the roadmap into some concrete action at the country level has been inadequate and uneven. And these are the two words that the UN General Assembly meeting in 2014, which was a follow-up to the 2011 meeting, described the situation at the country level. It was the conclusion of countries that we have not done enough. And so countries and other stakeholders in the NCD area have been given now another critical opportunity to improve progress and to move forward in NCDs in another high-level meeting of the General Assembly, which will take place in 2018. So this is an opportunity for countries to do better. So we thought at the beginning of this session that we provide some sort of an overview where we are and what the United Nations political declaration has provided to the global campaign against NCDs. So let me start with a slide on the magnitude, and I'm not going to spend a lot of time on this because this is very well known to all of us. But according to the 2015 WHO's estimate on mortality, we're talking about, as you see in this slide, 39.5 million deaths from NCDs out of 56.4 million, and that is 70% of all global deaths. But talking about mortality from NCDs, there are three important issues that I think we need to remember. One is the fact that contrary to previously held impressions or belief, NCDs affects predominantly the low and middle income countries. So almost 3/4 of NCD deaths actually occur in these countries. The second point is that there are 4 major groups of NCDs, which are the cardiovascular diseases, diabetes, cancers, and chronic lung diseases, cause about 80% of mortality from NCDs. So if we want to make a difference in relation to NCDs, then we have to address these 4 groups of disease. And thirdly, as you can see from this slide, a major proportion of deaths from non-communicable disease occur prematurely. And now we're talking about dying from NCDs too young, before 60 years, which is about 9 million, and before the age of 70, which, as you can see from this slide, is 17 million. Now, the 4 key modifiable risk factors for NCDs, according to the global strategy, are the ones that you see here: the tobacco use, the unhealthy diet, physical inactivity, and the harmful use of alcohol. They are shared by the 4 groups of diseases, and that is why the global strategy in the year 2000 decided to focus on the 4 groups of diseases and the 4 risk factors. And I'm sure my colleagues will be elaborating on the risk factor trends that we see. Now let me move to the global response to NCDs. In 1988, a higher priority was given to NCD. 1998, a higher priority was given to NCDs in WHO, and a global strategy was developed. It was endorsed by all countries during the World Health Assembly in the year 2000. And the global strategy is based on the overwhelming evidence that the premature mortality from NCDs are largely preventable. And there are three key strategic directions, as you can see from this slide. One is that countries need to track NCDs and their risk factors, which is the surveillance component. Second is that we need to reduce risk factors, particularly the four major ones that I mentioned. And three, that countries need to strengthen health systems so that we can improve healthcare for people with established NCDs. Then, based on the global strategy, there was a series of milestones that started immediately following the strategy in 2000. So in 2003, we had the endorsement of the Framework Convention on Tobacco Control, and then for the global strategy on diet and physical activity, and then, as you can see here, the global strategy on the harmful use of alcohol, an action plan, and then in 2011, the landmark meeting at the UN, which is the high-level meeting. And this meeting endorsed, as I said earlier, a detailed political declaration. It was a very long document, but it was extremely comprehensive, focusing on the three areas of action: surveillance, prevention, and healthcare. But in practical terms, what the UN did in that political declaration is that gave countries a number of important commitments that they have to meet if they really want to address NCDs. So in the area of governance, these are the four areas where commitments were made in New York in 2011. In the area of governance, the key commitments were to set national targets for 2025, which are based on the global targets, the 9 global targets that were endorsed by the World Health Assembly, and also to develop a national multi-sectoral policy and a plan in each country. In the area, and these are the 9 voluntary global NCD targets, which are now being followed up in terms of achievements at the member state level. And then in the area of surveillance, these are the key components of the commitments, but mainly all countries need to invest more in non-communicable disease surveillance, which is a very weak part of the national health information systems. And here we need to remember that when we talk about NCD surveillance, we're not talking about just risk factor surveillance. Equally important are the other 2 components of NCD surveillance, which is monitoring morbidity and cause-specific mortality, and then monitoring how the health system is responding to non-communicable diseases. In the area of risk factors or prevention, these are the key best buys that have been approved by the UN and prior to this by the World Health Assembly. A best buy on the multi-sectoral or intersectoral population-based measures, and also best buys on individual-based measures which relate to health system strengthening. The criteria used for the selection of the best buys were they have to be evidence-based and cost-effective. They have to be they can be feasibly implemented, and they can be feasibly and affordably scaled up by countries. Now, in the area of healthcare, the key commitment is to strengthen health systems, and one prerequisite for improving access to healthcare is obviously to integrate the early detection and management of the common NCDs, high blood pressure, diabetes, early detection of cancer, and treatment of curable cancers into the health system, particularly in primary healthcare. Funding is obviously a key issue for all countries, but specifically for low and middle income countries. It's a major challenge. So in 2011, WHO conducted a study to define the approximate cost of implementing the best buys. And you can see here the summary of the result of this study. On a per capita basis, the annual investment ranges between less than $1 in low-income countries to $3 in upper middle-income countries. So the cost really of targeted investment is low, and the budgetary impact is from low to modest. Now, this is a framework that we are recommending to member states. It is basically a framework of the commitments in the 4 areas that I described. It has 17 commitments and 10 process indicators. And these are the process indicators that will be used to develop the report of the Secretary General of the United Nations prior to the 2018 high-level meeting in New York. And finally, I want to spend maybe the remaining part of this presentation on where countries are and what really deserves more attention on the way forward. As I said, there is consensus that progress so far is inadequate and that there is a need to scale up. So the examples that that actually confirm the fact that the progress has not been adequate are included here. If we look at tobacco control, and we usually measure the response of countries in relation to the 6 tobacco control measures, and we look at the highest achievements. How many countries are doing this? A very small number of countries, not more than 11 countries so far, meeting at least 4 of the 6 tobacco profile measures. And the same applies to the best buys related to reduction of salt intake and also reduction of trans fat. We also know that less than 1/4 of countries have an NCD surveillance system that enable them to report on the global NCD targets. Dr. Chan this morning talked about cause-specific mortality. How many countries are reporting mortality by cause? And of course, she mentioned about 60% of countries are having difficulties, but actually, if you look at the countries that are currently reporting high-quality data on causes of death, they are between 34 and 35. So that's less than 20% of countries in the region. And there are many examples that demonstrate that access to healthcare interventions are lacking in many countries. So why is this slow progress? And there are many challenges, and there are a number of reasons, and this is my last slide. One reason is that the political commitment that was made by countries in 2011 has not been translated into concrete action. And we really need to think how this gap can be effectively addressed between now and 2008, the high-level meeting. The second is the need for technical guidance on implementing the best buys, the recommended best buys. Very often we think that where recommendations are made by WHO, countries will implement them. And that is not always the case, because very often policymakers would basically agree with the recommendations, but they need to have the know-how, and they need to have some concrete technical support on how this recommendation can be implemented. And that is very much lacking. And I think this highlights also the critical importance of implementation research. This morning, in the first 2 plenary presentations, this was a focus of discussion, and this is key in translating the knowledge that we have into some action through some concrete and innovative approaches. WHO developed and launched in 2010 a prioritized agenda for research in non-communicable diseases, but this needs to be reviewed, and this needs to be updated based on the developments over the last 5 years. And the third reason for the slow progress is obviously something that we also discussed so far this morning, the weak health systems that we see in many low and middle income countries, particularly at the primary healthcare level. There are major gaps in each of the 6 building blocks of health systems in most of these countries that really need to be, which is now, of course, one of the targets of the Sustainable Development Goals. We need to always link it with the universal health coverage target of the Sustainable Development Goals. It is very difficult to make a significant achievement or progress in improving healthcare for people with NCDs without making a similar progress in the universal health coverage target. So these are things that are closely linked. The fourth reason why we are not really making a significant progress is what we call the competing interest and also the obstructing forces. And of course, the tobacco industry is a very clear example, but there are also seriously unopposed marketing practices in other areas like food that should really receive high priority. Then the fifth reason is the lack of adequate funding, and I'm sure that my colleagues here in the panel will be discussing this because this is a real and a major impediment in low and lower middle income countries. There are a number of proposals, and I'm sure Rachel specifically might like to talk about this. And finally, the need for more effective multi-sectoral action. I mean, we have a number of challenges in low and middle income countries, one of them in NCDs. But in each of these challenges, unless you have the required level of intersectoral action and active engagement of the non-health sectors, no major difference will be made. So how do we strengthen intersectoral action? How do we build capacity in health leaders so that they can move forward in engaging with other sectors? I think it should be at the center of attention. There are already some guidelines, and WHO produced some guidelines. Other agencies have proposed some guidelines to encourage intersectoral action, and there is some sort of a framework of 10 steps to move forward on this. But again, I think we need more evidence to be generated, focusing on the mutual benefits of multi-sectoral work. So my last point really is for us, or for countries to move forward, for countries to scale up against non-communicable diseases, these kinds of challenges that I have mentioned really need to be addressed, and I'm confident that this will be discussed by our colleagues in the panel here. Thank you very much for your attention.
Thank you, Alda, for providing such a comprehensive overview for the whole audience. So I'm not going to be as nice as Ken was in the last panel. I'm able to ask questions and put them on the spot as well. So I'm just going to dive in and start with our economist on the panel. Alda talked a little bit about the best buys and also sort of why the countries are making slow progress. Rachel, I'd love to hear a little bit more about more from you on what are we seeing in terms of healthcare spending? How are developing countries and donors really addressing the spending needs that we have in front of us?
Thank you, Bindia, and thank you very much to Judy and the organizers for inviting me. Dr. Alwan really teed this question up well. And I'm going to leap to my punchline. It is an area that has been, I think, most neglected or most lagging since the 2011 high-level meeting. That Dr. Alwan, he's very humble. He really was the architect of that, and a lot of progress was made there. And since then, on many of the fronts for non-communicable diseases, but not so much in financing. And I think we need to think about why. So the first question that is asked, both at the global level and at the country level, is, what's the economic impact? What do I stand to lose if we maintain the status quo? And that's a good question, and it has been answered both at the global level and for a lot of countries. If we maintain the status quo, a study that was prepared for the 2011 high-level meeting by David Bloom and colleagues at Harvard and in collaboration with the World Economic Forum, they said $47 trillion in GDP would be lost over 20 years. Now, that's a really big price tag. There's definitely sticker shock from that. But what does that really mean? What can we do with that number? Well, that's been used a lot for advocacy, and because it's gotten a lot of attention, countries too, policymakers, especially health ministries and the NCD community, such as it is in some countries, it's pretty small, but they've said, okay, we need to have our country estimate of what it's going to cost us, of what's at risk here. And so a lot of studies have been done about that. And Minister, I hate to tell you, in Peru is the biggest price tag of all, from David Bloom and colleagues, $382 billion in potentially lost GDP from NCDs. Now, this is a very well done study. Lots of these studies have different data, different methods, and countries are different. Country burdens are different, and the needs. There are other studies from other countries, and I'm not going to go into all of the numbers. Even little Costa Rica, $36 billion in potentially lost GDP. So these are price tags that get people's attention. Like that, different disease areas said, oh, we should have our price tag. And very recently, the National Cancer Institute in the US partnered with WHO to come up with a cancer price tag. And that price tag is very large as well. It's, if I can find it in my notes here, maybe I can, $1 trillion currently that's lost from the burden of cancer. And when I talk about this economic burden, what I'm referring to is both medical costs and the amount that is being spent and the potentially growing amount being spent as people age and as these diseases advance, as well as the lost economic productivity. So there are ways of measuring that, and those are included in these numbers. And even recently, late last year, Lancet published an article on the cost of physical inactivity. So everybody's getting into the game, and physical inactivity is a really important piece of this. And that price tag was $54 billion in lost economic costs. Now, these are all, again, for advocacy purposes, and I think that it's had its impact. People are pretty aware that this is important, and it's big, and it's looming, and we've got to do something about it. So then the next question is, where is the money? And just let me say a little bit about that, and then, you know, what might we do about it, because we have limited time. So we look first to countries. I mean, countries need to pay their health bills. And as we have some data, not great data, especially from low and low middle income countries that Dr. Alwan was referring to, we can see the national health accounts telling us that from 0 up to, you know, maybe 8%, 12% in some countries is being spent on NCDs. Again, these numbers are not great quality data, but countries are trying to assess this because now they have budget lines, many of them, whereas they didn't before. Now they have NCD offices in the ministries where they didn't before. So it's a very small amount, especially in the low and the low middle income countries. It's bigger, of course, than the upper middle income and high income countries. What about from donors? For those low income countries that have already such a struggle, you know, Ethiopia spends $27 per capita on health every year. You know, they have such a struggle dealing with a lot of the basic needs that are already on their plate. What do? Well, donors, IHME and its excellent review of donor assistance for health last year tells us 1.3% of donor assistance for health is going towards NCDs. And work that we're doing right now to understand what's it paying for, which conditions, which risk factors, which donors are doing what. It's telling us the multilateral institutions are doing the most. Bilateral donors aren't doing very much yet. Private sector philanthropy in some areas, such as tobacco, thanks to the Gates Foundation and the Bloomberg Philanthropies, lots being done there. HPV vaccination. So in a few areas, there's really some heartening progress and some good capacity building. But on the whole, donors are doing very little in this area. And then finally, you can say, well, where is the money coming from? I was on a panel last week in Bangkok with Tim Evans, the head of health at the World Bank, and he said, there is a lot of money being spent on NCDs. It's just being spent inefficiently. And what's he talking about? He's talking about households. People are paying out of pocket a lot for these conditions. And we, again, don't have great data, so it's a little bit hard to pin down. We know that in poor countries, people pay out of pocket for their health far more than they do in rich countries. We know that across all different health conditions. But particularly for NCDs, where it's expensive, they might not be getting good quality care because it's not being publicly provided, and there's, as of yet, not a lot of capacity. They may not know where to go, and it's often catastrophic when they do pay for it. In Ethiopia, $300 to $600 for out of pocket that people pay when they have a heart attack, if they survive. So there is a lot of money. I'm on the Lancet Commission on NCDs and Injuries of the Poorest, and this is one of the areas that we are most especially trying to pay attention to. What people are spending, how impoverishing this is. So let me finish up with, just to sum up, the economic burden is high and it's growing. The funding is, especially from donors, low, and it's not growing. The last few years, in fact, it has shrunk. Many countries are struggling, and people, individuals, and households are being left to deal with this themselves. There are things that we can do at each of those levels. We can do more efficient payment mechanisms. We can bring it into existing funding mechanisms. We can bring NCDs more deliberately into it. We can integrate. We can do better at procurement. There are lots of things that we can do. But this has been an area of neglect, and I hope in the 2018 meeting we have a lot of good discussion about how to advance it. Thank you.
Thank you. Thanks, Rachel. So shifting gears a little bit, Ali, IHME always has data that surprises me. I'd love to hear a little bit more about what are you really understanding about the risk factors that Ala mentioned. Kind of tell us a little bit more about the geographic diversity, some of the trends that you're seeing. Hopefully something that'll surprise this audience that already knows a lot.
Thank you. So it's a pleasure to be here, and thank you all for celebrating with us our 10th anniversary. And I want to take a moment and encourage you to check our web at Global Health Department, what we do, what innovation in teaching, research, translation. And this is the beginning, 10 years. So we're going to make a big difference. We're making a big difference. Keep an eye on us. So let me talk now about risk factors. We at IHME monitor risk factors, about 80 risk factors, part of our global burden of disease from 1990 to 2015. And we have about 195 countries that we report on. So let me talk about the countries first. And I want to take one specific example and talk about obesity here. So obesity, for example, the highest level of obesities are in Egypt, 35%. The lowest are in Vietnam at 1.6%. So huge disparities at the global level between these risk factors. Then when you try to look at what's happening from 1990 to 2015, 72 countries had more than double or more in their obesity rate in this period. Only 11 did not see any increase. The rest increased, but less than double. When you look at a national number, is misleading. And then when you start looking within that country, what's happening in terms of disparities. And I want to move to the United States. Here in the United States, we have about 3,100 counties. And counties are where public health is. This is where real public health occurs. Public health is local for all of us, and we keep reminding ourselves. So we have counties for female obesity. We have counties here where obesity is about 17.9, 18% in Virginia. And we have a county in Mississippi where obesity is about 60%, 59.3. So 60% of females are obese. Even within a state, Virginia, that has the lowest, 17.9, there is a county in Virginia with 54%. So within a state, you see these huge variations in one of the risk factors that's very important and is really related to many of the chronic conditions that we are trying to tackle. Even more than that, when you look at a city, so we all here live in Seattle, most of us, this is doing extremely well in the economy. We have Boeing, we have Microsoft, Amazon. Even within the city of Seattle, when you start looking at the census tract or at zip code, you see a lot of disparities. And at IHME, we have shown that there are about 16 years difference in life expectancy between two areas here in Seattle that are maybe 4 miles apart. Why it's important for us to get the number at the national level. Unless you provide a number, you cannot change something unless you know what it is. And when I was at CDC, we used to fund programs from the National Center for Chronic Disease Prevention and Health Promotion. The first question for somebody who's asking for money is, show me your burden. 2, show me what are you going to do with this money, how you're going to monitor. So again, providing that number is very important. Providing that number at the local level is very important, and that what action will happen. So I'll give you an example. If you come here in the state of Washington and say prevalence of smoking is about 18%, people in Seattle will say, that's not us. These are people on the east side of Washington. These are the smokers. If you come here within the city of Seattle and say it was in King County, was in our county, and you say, well, we have a drug problem, people on Mercer Island will say, that's not us, these people in South Seattle. But when you give them the number, they act on it. So the local number is very important. First, you empower the people to ask for, the activists within the community. We have a problem, why aren't we dealing with it, and we should deal with it. You empower the decision maker in that community to seek funding and have a strong argument for getting the funding and saying we need to deal with this problem in my own community, and the people will support them to do so. The third point, which is even more important, is when you provide this local number for communities, then they will look at each other and say, oh, what did this guy do? And how did they improve it? And how could we learn from them? And you create that debate and that discussion in order to improve health. I want to end with a couple of examples from CDC. When we were at CDC, the Behavior Risk Factor Surveillance System used to report every year at the prevalence of mammogram, just an example, mammogram, by states. We never at CDC ranked them, because this is bad, we're shaming the states. So we list them alphabetically and they rank themselves. And then automatically states look at, say, why am I looking so bad? Why is this state doing better? And then they realized in the late 80s that the state passed a law where mammogram should be reimbursed by the health insurance company, and everybody copied that. I'll give you even a more example from CDC. We have to publish at CDC showing that a state that had a law that a policeman can stop you if you're not wearing a seatbelt has a higher prevalence of people wearing seatbelt to pass the law across the state. The last thing I want to add, at IHME we're doing forecasting to 2040. And we would forecast these risk factors even at the subnational level to 2040. We have about 20 countries now that we're doing subnational. And the idea for forecasting is not to show where you're going to be in 2040, given your current past, but what-if scenarios. And we want country and policymakers to look at what they are right now and see in 2040, if I increase my effort, what's the cost of that effort to reduce smoking by 5% in addition to my normal past? What will happen to the burden of disease? And we want that discussion. And we want to change these risk factors, and we want to encourage people to work together in order to change these risk factors in their community.
Thank you. Thank you, Ellie. I learned something every time. So, Craig, I want us to go a little even further upstream. So, you are working on reducing complications of pregnancy to improving maternal and child health, many of which have direct implications to the risk of NCDs and early adult death. Can you tell us a little bit more about the research that you're working on and what this means that we need to be considering about possible interventions in the future?
Sure, and thanks. And I want to say happy birthday to everybody. GAPS is now 10 years old too, so we feel like we're part of the celebration, and we started organically kind of at Seattle Children's Hospital to really tackle the problems of preterm birth and stillbirth that have now emerged as the #1 causes of death under the age of 5 around the globe, including in the developed world. As part of trying to accelerate science and to get more research and development and more investment, one of the things that we found ourselves having to do is to learn more about why there wasn't more investment and why there wasn't more interest. And that took us into a realm which, as a pediatric infectious disease doc, I'm not exactly an NCD expert, but certainly the things I saw as a pediatrician, and certainly based on what we are learning from a lot of research that's going on locally and around the globe, is that what happens in early life is inextricably linked to your health and risk of early mortality in later life. And we actually helped a couple of scientific communities get that into the UNGA declaration statement that happened in 2011. And the reason that we were able to do that is the evidence was there that we should really start thinking about earlier and earlier stages of life that could actually help us in terms of prevention. So I'll give you a few examples, but the punchline here is that connection and the challenge that I see in the scientific community of all kinds, not just basic science or implementation science or social sciences, is that connection between what's happening in early life and what's happening in later life. So why is that important, and why should we elevate the visibility of maternal newborn child health? Well, there is more and more data now coming out from both animal studies and now in human health studies in developed countries and low and middle income countries that if we take preterm, for example, and there are 15 million preterm births at least every year. 1 million of those die every year. And if you look at those that actually survive, the data now is showing that there are significant risks, not only for early neurologic effects, risk of infection, and those kind of complications, but they are also at risk for metabolic syndromes, cardiovascular disease, cancer, like AML, acute myeloid leukemia, as well as early mortality. And as we get more sophisticated at being able to track this through a lot of the things that are needed that have been already brought out, I think we're going to see that the link between what happens even in preconception health is going to be absolutely critical for what we can ultimately do in terms of identifying patients at risk or people at risk, modifying that risk, whether it's lifestyle changes or other opportunities for prevention. So let me give you a couple of examples, and some of this is pretty recent data. Some of it is small studies, some of them are better studies, some of them are coming from low and middle income countries, so it's not just about the US or the developed world. So one of the things that's really interesting, and Oliver just brought up obesity. Well, it's turning out that if you are obese going into pregnancy, you are already creating a significant risk factor for what's going to happen during your pregnancy. And the basic science is showing that that even influences how not only genes are altered for ultimate programming in terms of how they'll be expressed later in life in response to environments, but you're also putting your fetus at risk for preterm birth, for stillbirth, and some of the early childhood diseases that we often take care of as pediatricians and health providers. If both parents are obese as they go into conception, the risk for the child having socialization problems early in life, for having motor, both fine and large gross motor development is impacted, and the risk for cancer and diabetes goes way up as well. Now, this is pretty early data, and I wouldn't say it's absolute, but it's pretty suggestive, especially if you look at the animal data. A woman who has problems with hypertension during pregnancy or gestational diabetes, the onset of diabetes during pregnancy, has not only the risk of developing earlier onset of adult onset diabetes herself, but she also puts her infant at risk for early onset diabetes as well, or cardiovascular disease if it's in the case of hypertension. And in fact, up to 40% of women who have high blood pressure during pregnancy go on to have an increased risk of chronic hypertension later in life, in addition to whatever that impact and risk is to her fetus, whether born term or not. Those are some examples of what can happen sort of during that really important window of pregnancy and fetal development. Well, what happens when the baby's born? Well, we're starting to get more insight, especially from studies in places like India and Brazil, middle-income countries that are trying to address one of the significant problems they have, which are babies that are born too small, even at full term. And what we're learning there is that accelerated nutritional repletion, where you really give a lot of calories to try and do catch-up growth, can actually set the stage in the first 2 years of life for problems with obesity and earlier onset diabetes, as well as cardiovascular disease. So it's not simple. I think that's the big message here. We've got basically two individuals that are influenced by a third, the father, so paternal health is really important here too. But I think that we really need to step back and think about the opportunities that we may have, and maybe we'll talk about this in a couple of minutes, about the opportunities we may have at intervening earlier, even earlier than what we have heard about already, that may actually significantly improve our chances of impacting NCDs around the globe. Thanks.
Great. Thanks, Greg. So I want to make sure that we make it to lunch in 20 minutes, and I want to make sure that we have some time for audience questions. So you all be thinking about this, and I'm going to have these panelists do a lightning round session right now. We're going to start here, so get ready. So my question is, 10 years from now, all of these groups that are celebrating birthdays are going to be celebrating the next 10 years, 10, 20, 40, 50-year anniversaries. So what do we really need in the next 10 years, either in terms of a new technology, a new intervention, or bringing something that exists actually to scale? What do you think that you hope that we'll be celebrating 10 years from now to help with both the prevention or care around NCDs? So I'm going to start with Ali. We're going to do this lightning round, and then we're going to move to audience questions. Go ahead.
So I'm going to set the stage for the three coming after me. And I'm going to be very brief. For us, we need to focus on prevention. Yes, the medical interventions are going to help us, but we need to invest in prevention. And we need to address risk factors. Keeping in mind that we need to look at the environment. I'm not talking about pollution, but if I decide to eat right and exercise, the environment around me supports me to do so, and take into account the social and economic equity within our population. But also what I would like for us in the prevention of chronic diseases is to focus on what we call low-hanging fruit. Low-hanging fruit may be a bad word, but if I come to a Minister of Health right now and say tackle obesity or smoking or blood pressure, it takes a long time. But if that minister puts a program today for detection of undiagnosed blood pressure, uncontrolled blood pressure, undiagnosed diabetes, borderline diabetes, and then the prevention will work better here. If somebody is about to become diabetic, is more likely to change the diet. So we have in public health, in our preventive effort, to focus on early detection and making sure people change their behavior. And I hope I set the stage for the rest.
Thank you very much. We have two global targets now. We have the 2025, which is the World Health Assembly set of targets, the 9 targets I presented, and we have the 2030 SDG targets, and specifically on NCDs, but also on universal health coverage. So we know what needs to happen in 10 years' time in relation to these specific targets, reducing mortality, premature mortality between 30 and 70 by 30% according to the SDG target, and by 25% according to the World Health Assembly target. So this is something that is long-term, in 9 years or maybe 14 years from now. But I think it's important also to try and identify what needs to happen over the next 2 to 3 years. And this is, are countries going to implement the actions needed to prevent NCDs? There's absolutely no doubt. The evidence is there, and the roadmap is there. And if we implement these interventions, then we will make a significant difference in reducing the magnitude of NCDs and also risk factors. So I think one key issue now that we need to focus on over the coming 3 years is to see if countries are meeting the 10 indicators that are the process indicators which will be used to assess where each country is in 2018. So to answer your question, I think there are short-term expectations, and particularly in relation to countries setting targets for 2030 or 2025, countries having a multi-sectoral program for NCDs, countries strengthening their national surveillance system, countries implementing the best buys. Are they going ahead in this? Are they making achievements? And then long-term targets, which are very clear to us: 25% reduction in mortality, 30% reduction in the intake of salt, and so on.
Thanks.
Thanks. I don't think they want to hear me talk out of 2 microphones. That may be way too much. So I think there's a couple of things that are really important, and they follow along very nicely with what has already been said. One is, I think, that we need to think about how we link those underserved health science needs that really could get us some short-term wins. And even at a programmatic level, improving how women think about getting themselves prepared for pregnancy and pregnancy health, how fathers play a role in that is going to be very important, as well as we try and improve that, along with the investments in maternal, newborn, child health that are now being made across the globe with the Every Woman, Every Child efforts and so on. I think the other is we're poised for really a transformational set of events that could happen over the next 10 years, some of which is going on right here in the Pacific Northwest. And that is identifying those individuals at risk for NCDs, the biomarkers, the diagnostics, the environmental conditions, the dietary needs, those things that could be put together in packages that could really help us identify on a personalized medicine scale, even in low and middle income countries, those individuals that are at very high risk of having early onset and early childhood complications that set the stage for risk. And then that leads to prevention modalities that ultimately could really have an impact long-term on NCDs around the globe.
Well, I was excited about this question because I hoped that one of the panelists, not me, would be able to say, here's the magic bullet, and here's what this new technology is going to look like, and here's where we're going to get it. Because I don't know that, and I guess there probably isn't a magic bullet, because I think we're all on the same page. A lot of it has to do with prevention, and the earlier the better, getting that pre-diabetes and pre-hypertension. It has to do with the transformation that Craig just talked about, changing social norms. We want it to be normal around the world for governments to be able to put in place tobacco control policies and not to have to go to the courts to fight the tobacco industry for the government to be able to do that. We want it to be normal for kids to have healthy diets that are taking account of these early stage risks of obesity and chronic diseases, and to have people who are putting in place programs and policies to know what those healthy diets need to be. We want to look at the Philippines of the world who increased tobacco tax 80%, and now the revenue from that is so much more than they expected. They're able to get closer to fully funding UHC. We want to look at the Rwandas of the world who have community health workers that are out there counseling people on mental health. At the village level, we want to look at Mexico next door that has very boldly, with not as much evidence as we would like, put in place a sugar-sweetened beverage tax that appears to be changing people's consumption habits, and we hope will improve their health. And they're evaluating it carefully so that the rest of the world will have that evidence. So those are the things that we need to do. We need to see the bold, we need to see the political will, we need to see the targeting, and we need to see sometimes early action before all of that science is in place, because we can't afford to let this get further ahead of us. Thank you.
Great, thank you. So now I'm going to turn it over to the audience. So please, probably we could take 3, 4, 5 questions, and I'll start over here, please.
Okay, well,
and please
thank you.
introduce yourself, and if you have a specific person that you would like to answer,
Okay,
please direct
so
it at.
I guess this is for everybody. My name is Patty Garcia, and I'm the Minister of Health from Peru. And actually, I used to be very naive. First of all, thank you so much for the invitation, and thank you for the discussion of these quite important topics. I used to be very naive. I came from the academia, I work in research, and now I'm in the government. So we used to say, oh, these governments, oh, these ministers of health that don't want to do things, okay? So I used to say that, so I'm now in this other position. So, and that's why I want to be challenging to you guys, okay? Because in the case of non-communicable diseases, this issue about even when government really knows, I know the data, I have seen the data about Peru, this is one of the things that I know that I need to do, and we're even working on an observatory, so start to get a good collection of data also, okay? So one of the things that is quite important, and I don't think we have been talking enough, is about these obstructive forces that you mentioned. And I want to give you the example, okay? As soon as I got to Peru as the minister, I decided to work on this policy for the labeling of processed foods in Peru, plus marketing of processed foods to kids. And it has been 5 months of fighting, okay, of this lobby of the industry, okay, through the Congress against this type of policy. I'm almost there. I had to talk with every single person, and it has been really, really crazy. But even when I had the policy, we will need to wait at least for 1 year for the implementation, because there are trade agreements around the world that really protect whatever policy you have, even in health, that has to do or has some type of impact in industry or businesses, okay? So I'm telling you from the point of view of a government that really cares about, I know about the data, how difficult this is. And part of my discussion has been like, hey, don't you know that you're not gonna have any market if people die or are bedridden? Okay, what about if we get an equilibrium between a little bit of junk food and not that much? Or, let's try to do a different thing. So I'm making this point because I think and I would like your opinion also, how in this new vision of global health, next decade, next generation, we start to think about involving the industry and the private sector on this type of discussion. And so in the case of NCDs, I think it is a key issue. And I would like to hear your comments.
Thank you.
I think this is a great point, and thank you, Minister, for raising this. I was Minister of Health at one stage, and I was confronted with these extremely difficult issues, particularly in terms of prioritization. So where do I go, and what is feasible to do? Because feasibility, and that is why one of the key criteria for selecting a cost-effective intervention for NCDs is feasibility, affordability. Is it doable? Has it been done before? And that is one, I think, criteria. Has it been done before, and where, and what kind of international experience do we have in this? So the example you gave is an example that we see in most countries of the world. I remember, and tobacco, the tobacco issue, I think, and the tobacco control measures are great examples where we have really extremely difficult situations and resistance from these competing interests. And one issue that has been extremely useful, and it is related to the kind of research that we have to engage with, is the kind of research that is useful for us in terms of advocacy, convincing first policymakers in non-health sectors and the highest level of government, but also convincing the legislature, the policymakers. We have a number of examples where things were definitely not moving because of the opposing forces, and then when some concrete examples were given where success has been achieved, then things moved forward. So that is one point. The second point is to agree 100% with you that we cannot move forward without civil society and without the industry. There are a number of examples where voluntary actions by the industry has been positive. But there are also examples where voluntary action by the industry in certain areas has not been equally positive. But I think the responsibility and the accountability rests not only on governments, but also the two other key players is the industry and civil society.
Thank you.
So thank you. My name is Jim Logerfo. I want to thank the panel for a terrific discussion. I'm going to want to be grounded in one problem and ask your thoughts on this. A specific problem be a simple issue like high blood pressure, the single largest clinical issue that causes premature death and disability in the world. Ministries tend to avoid this because they say we can't afford to deal with it. We have a few observations. Rachel commented that most expenditures are currently out of pocket in the private sector, and this is especially true in the lower resource countries. Secondly, there's a concern about the quality of care in those. And third, we know that the drugs needed to treat this are extremely cheap and are more available in the private sector than in the ministries themselves because of the corruption and all the problems with the drug supply. So I would like to see something like World Health say to the ministries as a #1 priority, admit you cannot do this yourselves. Admit that you have to engage the private sector and then simply do a few things. #1, Mass public campaign, know your number, just like we did with cholesterol and all those things in this country in the 60s and 70s. Second issue, let people know drugs, let them know self-management, that's fine, but that won't help the ones who have blood pressures over 160. The third issue would be simply to say then, there are 2 drugs that are available that are very cheap, they require no physical examination, and they require no laboratory test. Name the 2 drugs, which we know are very cheap, such as low-dose amlodipine and low-dose thiazide. Let people know that they need to take drugs daily, and then lead the decisions up to the key decision makers, the patients and the families themselves, either to create demand on the ministries or to go to the private sector. So those are some challenges that I would see, and if we wait in places like the countries I work in for the ministries to take this on, to deal with it through the regular primary care system they have, we will be 2 generations from now having the same discussion. Thank you.
Thank you. Do you want to respond?
No, I think that's another important issue and a great challenge is where do you spend the very scarce resources that you have in a low-income country? And obviously, a straightforward response to this is prevention. But at the same time, we have to be realistic. And to be realistic, we need also to address the healthcare component of NCD prevention and control. I mean, Africa has the highest rates of high blood pressure. And even if we imagine that the detection rate for hypertension is only 30% in a specific population, we're talking about millions of people with high blood pressure that need treatment. So to be realistic, we need to see how we can provide the best kind of treatment that we can use, and using, of course, exactly like what you said. In the area of NCDs, we have problems in relation to the access to essential medicines, the medicines that you have mentioned. But there are also some definite approaches that any government in a low-income country can take to improve the situation, not to solve the whole problem, by addressing irrational prescribing, by improving your procurement policies, by improving your distribution, storage policies, and also by mobilizing domestic funding for treatment of common conditions, and there are also some very successful examples in this. So I think the idea that the main point that I want to make is that in every single country, including low-income countries, there is a lot that can be done with the cost-effective interventions that we mentioned, including in healthcare.
Great, thank you. Could I take 2 more questions? I'll just do both questions from here, and then I think we're going to let the panelists respond and then break. Go ahead.
I'm Ben Anderson. I'm a breast cancer surgeon here at the University of Washington with an interest in breast cancer globally. I direct the Breast Health Global Initiative based at the Hutch. My question, it is unarguable that the prevention strategies, risk factor strategies should be addressed. But that also is something that's looking out 20 to 30 years and does not address the most immediate needs. I would propose that what really ties together NCDs is the need for longitudinal care, a healthcare system where patients come back repeatedly. And that's really a gap in low and lower middle income countries. Peru is really an exception in the data collection that they do on their patients. They can follow patients, and they have electronic registries that allow them to see what's happening in their population. But how to build healthcare systems using affordable strategies, I haven't seen that recognized. Dr. Alwan, you made a brief comment about strengthening healthcare systems, but I don't think WHO ever really got into that. They said, oh yes, that must be done by somebody. And I think there's more that can be done. I'm curious on, don't you see ways that we could do more at the clinician level, building these systems that are effective?
Great, thank you. And I'll take one more question now.
So my question was actually very similar, which is that as a public health professional working in the healthcare delivery system, I see a huge disconnect between our public health strategy and the folks that are, acute care settings that are seeing many of these patients on a daily basis. And so are there good examples of where there's been a strong partnership to allow us to effectively tackle a lot of what was just described?
Great. So, Rachel, do you want to or does anybody else want to respond?
I want to respond.
Oh, okay, go ahead.
So your question is very correct. I mean, a Minister of Health has to struggle between what is immediate and what's important. And the immediate is I have people who need treatment and medication, was it blood pressure or chemotherapy for cancer or surgery, and I have to secure funding to treat the sick population. But that should not be at the expenses of what's important and setting up prevention on the long term. And that balance we need to create between prevention and treating people who are sick in our community. And each Minister of Health should have a plan, and then what money should go into prevention. And yes, there are low-hanging fruit, and yes, there are 2-3-year objective, and yes, there are 10-15 years ahead of time. Unless we make that and we empower the Minister of Health to seek money for prevention for the long term, we're going to fail, and we will have the same discussion 20 years from now, talking about treating sick people and then preventing.
Go ahead, Rachel.
Just very briefly, again, great question. To give you one example, in Ethiopia, they have incorporated NCD prevention and management into their essential package, and they are already implementing. It's not at scale yet, but they have at 36 healthcare centers and 12 hospitals implementation of their diabetes and hypertension initiative, which goes along with putting all of the right prevention policies in place, but they also are incorporating treatment. Again, how they're going to pay for it as they scale it up is still a question, but they're very focused on it, and they're determined to do that, and those are the essential initial elements.
I also think there's some low-hanging fruit here in terms of tying in with the maternal child health community, in that there's now great effort to bring women to facilities for labor and delivery care, for increasing antenatal care services around the globe to improve pregnancy outcomes and child survival. So I think that the connection that could get at your question wherever you went, concerning the connection and the longitudinal care aspect, there could be some great partnership and some big wins there. Because right now what happens is we start to strengthen those early life events in the health system, and then all of a sudden it kind of just falls off, and there's nothing for several years until the person either has an event or is in late adolescence and they start to get into an adult health system. So I think that there is some opportunity there that could be hopefully captured and capitalized on together.
Just a response on health system strengthening, and without going back to what WHO is doing, I just want to reiterate what I said before, that it would be difficult to make a significant difference in improving healthcare for people with common NCDs if we do not address the universal health coverage issue. And so we have two targets under SDG 3, which should be the focus of attention if we really want to improve healthcare for people with NCDs. One is the UHC in its 3 dimensions, which is the financial risk protection, the expanding coverage to the whole population, and thirdly, to identify some sort of a high priority package of essential interventions for not only for NCDs, but for other priorities in relation to health system strengthening. And I want to mention, since we are now having this meeting in the University of Washington, I want to mention the excellent work that is being done by the DCP3 now in trying to develop an essential package of interventions as well as a high priority package. This is one of the key components of universal health coverage, and I think this will have a very important impact on improving healthcare for people with NCDs by focusing on what is actually cost-effective, what is affordable, and what is feasible to implement.
Thank you so much for everyone's questions. Sorry we don't have time for more, but please find them at the lunch break. Excuse me. And hand it back over to Judy.
Well, first of all, this was a wonderful morning. We're going to break now for lunch. There will be lunch served out here. There are also food vendors 2 floors down in what's called the Husky Den. So please enjoy your lunches. We're going to start again promptly at 1:20 with our next panel, which is on global environmental change and human health. Enjoy. Happy birthday.
Rachel, wow, that's amazing data.
Good afternoon, everybody. If we got 2 minutes or so until we start, so if you can start moving back to your seats. Thank you. Be bold. Be bold. What's that?
We weren't going to get renewed, and we would never get. I mean, you know, she just had a sort of like dropping 20%. It's like
it's a step function for those things. Wow.
One, two, three. James. Okay. Good afternoon. It's almost a little bit quieter. Good afternoon, everybody. Hi. Welcome back, everybody, to the afternoon. It is so great to see the room still so full, and it seems like everybody had a great lunch, and we made everybody out through lunch, everybody back in through lunch, so congratulations. I'm Jared Baton, Vice Chair of the Department of Global Health here at the university, and I'm going to help us move through the afternoon on time. I have a couple announcements to start. First of all, everybody's glossy brochures from the partner organizations that were up here at the front at the beginning are now out front at the registration table for the afternoon, and they are excellent, so I encourage people to pick them up. I've also been told your little card that came in your packet this morning has the Twitter and Facebook information on it. We are trending somewhere in Twitter land, so you should tweet like mad this afternoon. Okay. And now we're here for our third panel of the day, and this is This is a great crew, and it's going to be a great panel. The topic is is impact of global environmental change on human health. Our moderator is Lisa Cohen, who is the founding executive director of WGHA, the Washington Global Health Alliance, which we heard so much about this morning, how it brings all of us together to do better work in this state. I don't have a long introduction for her, but I do want to say that the WGHA website says that she has moderated hundreds of panels over the past 10 years. So everybody watch this. It's going to be amazing.
That's
Over to
it.
you. Thank
I'm
you.
done. A mic drop. That's the end of it. So thank you, Jared. No pressure at all. Welcome to the afternoon, everyone. And I hope you feel, as I do, watching and listening to people today, just such an immense sense of pride and sense of community for not only our terrific partners here in Washington State, but also around the world, and the impact that the University of Washington and Washington State University have had in the far reaches of the world. And I got to hear the health ministers, Minister Don and Minister Garcia, talk last night, and I was saying to Marianne Mercer afterward, faculty member here, what a sense of just tremendous legacy to have trained remarkable leaders like this, and you've got this whole diaspora around the world. And so, and Judy, I want to thank you and the Department of Global Health for including the entire community. And that's the way you roll, that's the way the UW does, and that's the way this community rolls. So, so congratulations to you on your 10th anniversary, and to all of us, I guess, for that matter, so for multiple anniversaries. So when the steering committee was talking about what topics to do for these panels, this was an obvious one, but it's still a relatively new one to include, topic to include when we're talking about global health. And I think as we've heard an increasing level of need as the panels have been talked about today, about how we have to think about these things and these issues in a sense of a totalitarian approach, right? I mean, it can't be as siloed as we used to be. We don't have that luxury. We don't have that time, and we don't have the financing for that, right? So as we think about climate change and the tremendous impact on human health, and you're going to hear about that a lot more from our panelists here. I also want to also raise the issue, there are different ways of framing this discussion. You can talk about the climate change impact on human health. There's the planetary health effort that talks about the interdependence of human and natural systems. And I think that's, as we talk about it, as we frame our discussion today, I think it's important to think about that. Dr. Garcia, Minister Garcia, was saying last night that she almost couldn't make it here today because of the huge challenges they're facing that are direct impacts of climate change in Peru right now, because it's flooding and landslides and fires, and the whole list went on. And she literally had to say to the president, "Is it okay that I come?" And he said, "You can be gone for a day, and then I need you back here." So you'll hear you can hear when she's on the panel later on this afternoon, hear more about that in particular. So to frame, well, first I'm going to do brief introductions here of everyone. You've all got their bios in your programs, and then you also, if you went on, looked at any of their organizational websites, you could read pages and be here for days. But I'm just going to give you a brief overview of the terrific people we're going to hear from here today. First of all, just to my left is Jeremy Hess, and he's an associate professor of emergency medicine and associate professor of environmental and occupational health sciences. He's got an MD and an MPH, and is a principal investigator for NIH-funded grants supporting work in India on epidemiology of extreme heat and strategies for developing, implementing, and evaluating heat early warning systems. He's a member of the Center for Health and Global Environment here at the UW. He's a consultant for the Climate and Health Program at CDC, and where he also works as a medical advisor on the health effects of climate change and evidence-based interventions to enhance preparedness and promote climate change adaptation at the state and federal levels. So delighted to have you here, Jeremy. Next to Jeremy is Lisa Gromlich, who's the inaugural dean of the College of the Environment here at the UW. As dean, she leads this college with an unparalleled depth and breadth in environmental systems, from the forests to the seas, from the depths of the earth to the edges of the solar system. So it's just a very small body of work. As a scholar, I love this. She pioneered tree ring data to understand long-term trends in climate change and focusing on the mountains of Western North America. And she's a fellow of the American Association of the Advancement of Science as well. Next to her is James Pfeiffer, who is the executive director of Health Alliance International. It's your 30th anniversary this year. So, and he's a, yes, that's worth. And Steve Bloyd's here, and a number of folks who've been so involved there. So, always shy. Steve is very shy. So James is the executive director of HAI, and he's a professor of global health, anthropology, and an adjunct professor in health services here at the UW. He's a medical anthropologist, a public health practitioner with interests in health system strengthening. You'll hear a lot about that from him today. Also social justice and health and the roles of NGOs in global health, and the influence of Pentecostal churches in response to HIV and AIDS. So a really fascinating background. And then next to him is Guy Palmer, Senior Director of Global Health at Washington State University. He was the founding director of WSU's Paul G. Allen School for Global Animal Health. And he provides key strategies and vision to help direct the university's increasing interest in both human and animal health regionally. He's got some really fascinating research out right now about how healthy livestock can influence girls' education. And so it's a terrific piece of work, and check it out if you haven't seen it. So for his research at that interface of animal disease and human health, he was elected to membership in the National Academy of Sciences, and he's a current member of the Global Health Group. He serves as a member of the founding board of directors of the Washington State Academy of Sciences and of the executive committee of the Washington Vaccine Alliance, so also a pretty broad body of work. So Guy's going to start us out with a brief overview, and then we'll get into a discussion, and then we're going to leave quite a bit of time for audience questions, and so be thinking about your questions as we move along. So Guy.
Thank you, Lisa. Can you hear me in the back? Okay. And I just want to reiterate my thanks to Judy and for all of the staff at University of Washington Department of Global Health for helping make this happen and being so inclusive. We've always said that UW Global Health has been one of our biggest advocates since day one and have been great partners for it, and we're really grateful for that. I want to kind of frame just in general the issue of focusing on the environment, and initially I want to do it without mentioning climate change. Even if we erroneously were to assume that the climate was stable, that the environment is changing. It's always been changing. Population growth alone results in major demographic changes. We've seen this now with massive urbanization that's occurring in the world. We see it technologically driving change in terms of what we do. And this actually by itself, again, without invoking any kind of, with assuming erroneously, again, a stable climate, that we can see effects on disease. If we look at, for example, southeastern Australia, where the Hendra virus outbreaks have occurred, where there is fragmentation of habitat, which supported bat populations, changed bat migration patterns, brought them into context with people, which then allows a spillover event into humans. So we can see those kind of examples. If we look, we've mentioned this morning, Margaret Chan mentioned the very important role of antimicrobial resistance. If we look at the rapid urbanization which is occurring in the world and the occurrence of urban slums with low sanitation and high burdens of febrile diseases, that again can drive the need for antimicrobials instead of implementation of vaccines, and therefore the development of resistance, which then spreads very quickly in a low sanitation environment. So even without looking at climate, environments alone have a huge impact on human health. actually having climate and human response changes is not new. This is actually a photo of what's left over from the 500 years that Scandinavians lived in Greenland. This is from the Western settlement. Still remnants of it exist today. And they lived there for 500 years and then were driven out. And we were talking earlier about some isotopic work done that originally they lived off livestock because they were there during the warm period, and then increasingly went to marine diets, and then eventually left the area when it became unsuitable. They moved there during the medieval warm period, then during the Little Ice Age were progressively driven out and migrated back to Scandinavia. So the idea of migrations and movements in response to climate change is not new. What may be new now is we're probably closer to what's called the carrying capacity of the planet than we've ever been. Assuredly, we're closer to the end. Where exactly that threshold is on a global scale is very difficult to say. But regionally, I think we can already say when we've exceeded carrying capacity, because you'll see that in terms of massive migrations, which, as we mentioned this morning, massive human migrations are fundamentally a global health issue. So we're seeing that even today. So a couple of examples of this. This is actually something we don't generally think of when we're thinking of global health, but this is a map of high-quality soils in the world. And basically, they look at resilience and quality. That is the ability of a soil to regenerate itself. We don't think of that as a determinant necessarily of migration and human health, but in fact, it underlies a lot of it. Where you see the blue and green on that map are really the high-quality, highly resilient soils. Not surprisingly, you can map a lot of prosperity and demographics to that part of the world. In other parts of the world, in fact, areas where you see a great deal of out-migration in response to change, you see low-quality soils. If you overlay that now with where human populations are, this is again showing population density, you kind of see how those can naturally overlay onto good quality soils. So the idea that our planet and our land has a carrying capacity is actually integral to how we now look at addressing climate change. So migration in response to changes in climate has always been a constant in the human experience. And this is from migration into North America, originally by indigenous people coming across the Bering Strait. It had to do with the European migration into North America. But now as we come into to much closer to our carrying capacity, we now see the impacts of, again, another wave of mass migrations and how those become a global health problem. So even assuming that we've had a stable climate, you would expect to see some of these problems. What we're now facing is a rapidly changing climate and how that will then affect the demographics, mass migrations, emerging diseases, and I think those are the things that our panel wants to address. So thank you, and I'll look forward to our discussion.
Great. Thanks, Guy. So Jeremy, Guy talked about that carrying capacity of the land, and can you talk about a little bit more about that current rate of acceleration and how that's impacting our environmental systems?
Certainly. So the rate of acceleration is a little difficult to perceive because a lot of these systems that we're manipulating are quite complex, and they exhibit the dynamics that are hallmarks of complex systems, thresholds, delays, and other things. We know that we've, as a result of our emphasis, reliance on fossil fuel combustion, on our manipulation of the nitrogen cycle, we're seeing dramatic shifts in a lot of these systems, and we're seeing changes that appear to be accelerating. They are exponential. The exponent is relatively small, so from far away the curve looks linear, but the closer you get, you see more and more that it's bending upward. And we're seeing a dramatic increase in both temperature on average. We're seeing an increase in extreme events, as mentioned, in those impacting Peru, but certainly they're happening all over the world. And we're also seeing increasingly impacts on other systems, natural and managed systems, productive systems, agricultural systems. some of those shifts have been in the making for years, and I wager that at our next celebration 10 years hence, we will be remarking on having crossed a number of different thresholds, and that the sea level rise and warming and shift in extreme weather events will be even more apparent than it is currently.
So let's get into some of the specific impacts as we to dig into some of those a little bit. So Lisa, would you talk a little bit about that impact on food systems? Yes, I think if you two share this mic, and James and Guy, if you share the other mic there. So let's talk about the impact on food systems.
Well, I'd be very happy to do that, and initially just want to say, first of all, how happy I am to be here. Judy Wasserheit and her colleagues have embraced me as someone that gets to interact with a number of you here working on issues of global health, and I find it incredibly inspiring. And in particularly am often buoyed by a lot of good news that comes out of your community, and it comes out of your community because of your dedication of bringing your very best science into practice and into interventions. And there's a lot of good news about trends in global health. And so I get to be the one that says climate change very likely is going to interrupt that progress that we are making towards global health. And I want to say a few things that I see as emergent from a state of knowledge which is absolutely imperfect. Some of the reasons it's imperfect is you have people like me and my natural science colleagues that when we talk about food systems, we're really good at putting small plants in growth chambers and torturing them with higher temperatures and then trying to extrapolate that up to, and therefore maize will do such and such in terms of performance in a doubled CO2 world. So put that aside for a moment. We can tell you a whole lot about that. It's probably not really relevant. What's really relevant is how those crop systems interact with food security, food access, food utilization, and food stability. And so I'm going to try and intersect those big concepts as somebody that is a climate scientist. As I see this literature, climate change absolutely exacerbates food security issues, and the impacts are worst in the countries that are already suffering from high levels of hunger and will likely worsen over time. So we can think of climate change as a factor that is making something that is challenging already exacerbated. And in particular, one of the things that I've been thinking a lot about is food inequalities. And because with climate change, we see regions that are more or less impacted, regions with more or less better and more productive and resilient soils. So due to this physical template that the climate system is interacting with, and then of course due to economic inequalities, I think what climate change is going to do is sort of pull yet further apart the kind of inequalities we're seeing in the world. That's point number one, exacerbation. Number two, we know for a number of good physical reasons that climate change will absolutely change and increase the frequency of extreme events. And this brings with it all sorts of risks associated with uncertainties, increased uncertainties in the food system. So people that are already vulnerable to extreme weather now will of course become more vulnerable in the future and less resilient in the face of climate shocks. We can think of climate as being shocks to the system. Point number two. My final point is that even if we all went out and bought a hybrid car and really did replace all of our light bulbs with LED lights and got serious about slowing down our carbon pollution, we are committed to a trajectory of climate change for the next 20 to 30 years. potentially longer, depending upon decisions that we are making right now. And so this is going to simply be, for the next decade and the next decade and the next decade, a panel in your program. And we will see it seems apparent that we will be dealing with the consequences of this potentially at an even more rapid rate than we might have thought of a couple of years ago.
Okay, so.
Now that was fun, wasn't it?
No, it's right. We need to deal in reality, right? So I want to, while we're on the subject of food security and food systems, just want to ask Guy to weigh in here because you work a lot with pastoralists and farming communities and the ag research with WSU. So can you add to what Lisa was talking about?
Well, I think what Lisa's said is, holds true, and especially, I'm going to sound like a soil scientist here, which I am not, but I have.
He plays one on TV.
Play one on TV. I have a good friend who's a soil scientist, but that this will affect the most vulnerable actually does map to things such as soils. The U.S. is and southern Canada is actually blessed with about 50% of the high quality soils in the world, with 5% of the land mass. A friend of mine who's English said, that's just like America. Tried to explain that really wasn't intentional, it just worked out that way. Wanted the best of everything. But I think that it will impact food systems, and it's obviously going to impact those at the margins. And I think what's important is both looking at prevention, which there are things that can be done, mitigation in order to improve resiliency of soils, in order to do crop production, livestock production in the most sustainable ways possible. Still, that said, I think its impact is going to be around human migration. And I think that's where we're going to see the most dramatic, whether it's to an urban setting, where again you'll have food shortages, you have other crises, where those people who previously lived in rural areas are now in urban areas. We have problems of rapidly growing slums, effects on things like antimicrobial resistance, but also just the human migration across countries and the conflict that brings, which I think in the last 2 years, 3 years, we have seen with all too great of clarity. So much of that comes back to food systems and the basic equality and productivity of agricultural systems.
Okay. So that's perfect segue to James. Let's talk about population movement, and I know this is something you've really looked at. So give us some context for what you're seeing.
So, and just a little brief preface to that is, just want to explain a little bit about Health Alliance and why I'm up here. So our niche is health system strengthening. So the projects that we are involved in now are mostly in Mozambique, Ivory Coast, small project in Liberia, also in East Timor. And we work very closely with national ministries of health to strengthen healthcare delivery. And there is a real, you learn a lot when you're down on the ground in a health system in a developing country trying to get this kind of work done. And so I come to these questions from that health systems perspective, and really I learned so much from Minister Don's talk last night and today about the importance of national, public national health systems. So, and just one other quick shout out here. We got a little applause for HAI. Full disclosure, I told my students in my class that if they come to this lecture and clap for me, they get extra credit.
Everybody gets a 4.0.
Right, everyone gets a 4.0, so good work, people.
Some over there.
But I wanted to give a shout out to Steve Gloyd, who is the founder of HAI 30 years ago and just stepped down, and I took over the reins a couple of years ago. Steve is also the founder of the International Health Program, which preceded the Department of Global Health.
Can we just give, Steve's in the back there. You deserve it.
And Minister Don trained here in the University of Washington in that International Health Program, even before we became a full-fledged global health. So just wanted to give a shout out to Steve on that. So the population movement issue is enormous, as has been mentioned here. We're already, these things are already happening. They're not going to happen 10 years down the line. They're already happening, especially in the Sahel region of Africa, Burkina Faso, Niger, Mali, many of the countries that are
experiencing desertification, and we're seeing that population movement in humanitarian catastrophic ways going toward Europe, with the troubles that people are having across the Mediterranean. But within places like Ivory Coast and others, how do we manage huge numbers of people moving between regions because of these food pressures, especially? And what we're learning is that you got to have health systems, and they need to be built out. And our health systems are still too weak, throughout Africa especially. We don't have the kind of coverage we need, the geographic coverage. We don't have the kind of health personnel we need to really manage these kind of population movements. And there's a few examples, I think, of the way in which health systems are going to be so critical as we move forward that Minister Dawn mentioned yesterday. She talked about how they were able to tackle a cholera outbreak in northern Liberia, I believe it was last year, because they had a health system with trained people ready to do that, and how they were able to prevent malnutrition from occurring in a refugee population that was coming out of Cote d'Ivoire when Cote d'Ivoire was having a civil conflict. Because they had a health system ready to tackle it, they actually prevented any kind of malnutrition, serious malnutrition, undernutrition occurring in those refugee communities along their border. And as she has mentioned over and over again, one of the reasons why the Ebola outbreak was as severe as it was in those 3 countries is those 3 countries have the most fragmented health systems in Africa. And so the Ebola outbreak might be a red flag for us for emerging infections. We need to have good, solid, well-equipped health systems with infrastructure, with workforce that are there and trained and ready to take it on. And we have a long way to go to get there. So hopefully I'll be able to talk a little bit more about that. I want to kind of leave it at there. But the critical importance of, when I talk about health systems, public sector, primary health care, which packages comprehensive services in a bundle. People don't come just for malaria, just for TB, just for antenatal care. Sometimes they come for all those things together. And we have a good format. We have evidence to know that this works, and we just need the political will to build these systems out with the in-country leadership that Bernice Dawn has
which
really
is
highlighted.
exactly, Minister Dawn has been crystal clear on today, which is critical. Jeremy, let's talk a little bit more about the types of impact that James began to allude to, and grab the mic there. But what types of health impact do you anticipate?
Well, there's a whole range, and in the climate and health field, we tend to divide them into direct and indirect impacts, though that's a bit of an artificial distinction, frankly. The direct impacts we think about having to do with, at some level, the transfer of kinetic energy. I mean, you're increasing the temperature of the atmosphere. It's actually a true transfer of substantial amounts of energy into the atmosphere, and some of that comes back to us in the form of increased winds and hurricanes, and all of these are the things that can cause injuries, can cause tissue injury through extreme heat exposure, can cause other injury through trauma. The energy that's transferred into these systems and disrupts them then causes other types of injury, particularly on the most vulnerable, as we've heard about. And so we live in a relatively narrow, historically narrow temperature and climate window where many systems have developed and are optimized. And as we move outside of that window, those systems are no longer as productive as they were. With population pressures, we see challenges around food security, water security. We see population migration. We see conflict. We see what we don't really fully understand, but we see direct increases proportional to temperature in interpersonal violence at an individual level, and we also see increases in collective violence. We see shifts in ecosystems that impact vector-borne and zoonotic diseases. These are complex, and certainly temperature and precipitation changes are not all that's affecting those things, but they're part of the picture. So in certain places, we're expecting to see emerging or re-emerging diseases that we didn't have before. We're certainly expecting to see amplification of diarrheal disease and waterborne and foodborne diarrheal disease. Yeah. We're expecting to see undernutrition. And in many ways, there's not any particular health issue that we work on collectively that at some level may not be affected. How it will be affected and what the constellation of impacts in that particular area will be is quite variable. And in some places, health will actually probably improve as a result of climate change. There will be opportunities for improved agricultural productivity and other things. But on balance, it appears it will be a net negative and perhaps a substantially net negative set of impacts.
So, and let's be clear about who's going to be most impacted here, right? So I think any of you can weigh in. I know, James, but go ahead. Let's just be really clear. I think it's not going to be a surprise to anybody in the room.
But it goes without saying, but we'll say it anyway, when we were organizing the panel, that global warming is already having a differential impact. It's impacting the global south. It impacts communities of color mostly. So it is, from the get-go, a social justice issue, an environmental justice issue. And to keep that front and center, as I think you were alluding to. And I would even say, working in Africa mostly, and we hear a lot about America first, I would say maybe Africa first when it comes to climate change. We need to be preparing and jumping in, because it is already hitting. It's already going to increase mortality. It's already having a human impact. And we're behind the game. That's a lot of good things going on, but we're behind the game. And it's important that we recognize from the get-go that inequality lies at the center of what we're looking at right now. And the impacts are going to be severely different in different parts of the world.
Can I?
Yeah, please.
And I want to dovetail with that to highlight that, so the environmental impacts are distributed toward the poles, in fact. So the exposures are shifting most dramatically at the poles, but certainly in the equatorial region, in the temperate zones, they're dramatic as well. It's the vulnerability that drives a lot of that. And to add to the inequity, most of those regions have very low historical greenhouse gas emissions. So there's a real inequity in the vulnerability to these threats, and then there's a huge inequity in climate debt and the responsibility for the problem that I think we acknowledge, but conveniently forget, or we pay some lip service to, but we don't put our money where our mouths are when it comes to that issue.
So let's move to a little bit about what we should be doing and where investment should be. And I want to say that with the caveat that I'm so conscious, as we've all been talking about in previous panels, and this one, where the investments should be and what needs to be done, and that's and I've been thinking about it from Minister Don's perspective, potentially, and Minister Garcia, that okay, you need to invest here, and you need to spend money here, and you need to do this, and WHO, you need to be doing it here, and it's a little overwhelming, I would imagine. I can't imagine being a minister in one of these countries with a limited budget and competing priorities, as well as with WHO, with declining investments, and so the pressures are just tremendous. But we need to talk about what should we be doing going forward, and so. So let's talk about developing evidence and how we go about that and making the case for what needs to happen here. And Lisa, why don't you give us some thoughts from your perspective, and we'll move to everybody weigh in there.
Well, I'm going to feel slightly pedestrian here because I have some thoughts that come out of our experience here in the Pacific Northwest, and I'm aware that I'm speaking to a very globally engaged crowd. But I think they're useful nevertheless. So when we think about some of the extreme events that we know are going to occur, we think about them as emergencies that need to be responded to, and I urge us to think in addition as extreme events as what I'm calling dress rehearsals for the future. So I'll use a very local case as an example. Believe it or not, for those of you from out of town, in 2015, instead of having to kick around the snow that we have on the sidewalks right now, our big problem was that it wasn't snowing in the mountains. We ended the winter with a 9% of normal snowpack. And that's a big deal for us. The snow and the mountains are essentially our natural water towers that allow us to have irrigation water for the rich productive lands in the east of the mountains. They create the perfect stream temperatures for our big salmon runs. And because we have been thinking and planning around what it's going to look like here in 2060 or 2070, we were ready. You know, we had ideas about how to manage water that we could put in place and learn from. But luckily, we were also paying attention to some unexpected implications of that dress rehearsal, if you will. And it actually had some big health impacts. It turns out all that fresh water that normally the rain events sort of cascaded out of the mountains and into the mouth of Columbia, and we had plumes of fresh water that were much less than normal on our coastal communities, allowing the ocean waters to come closer to the coast, bringing with them the toxic algal blooms, the sort of red tides. So in 2015, because of climate change, because of less snow flushing these algae out to sea, we ended up with a failure of our razor clam industry, about a $9 million industry here. It's not just the fancy Seattle restaurants. These are first foods for our tribal nations. And so we had an unexpected impact of this extreme event. So when I think about what we should be doing as these extreme events hit us, of course we're going to mobilize to directly address those who are impacted. But I also think we've got to pause and look around and say, what are we learning from this event, which is relatively rare here in 2017, 2018, in the next few years, but is the new normal for a couple of decades out. And investing in that part of the response would be a key lesson learned, I feel like we have learned here in the Northwest.
Guy, can you talk a little bit about the investments and how we should be thinking about, you've talked about a broader global health definition and workforce impact as well. So,
yeah, I think when and I think we may segue a little bit into the next section, next session, when it's about education and training for the next generation. But I don't think you'll see anywhere in the world a department that's called the Department of Crop Production and Global Health, or the Department of Soil Science and Global Health. And I think that's one of the things we need to be looking at is how to engage much more broadly, especially within the universities, because we do have some of the expertise that we really need to redefine global health in a much broader context. I know people are aware of that. The College of Environment here has been very involved, a lot of other colleges, but we have a lot of work to do in that area. And I think this is important because there is a tendency with the rapidly changing climate, the increase in temperatures, which are essentially cast in stone for at least a couple of decades, as Lisa has mentioned, is you can be a little bit paralyzed in front of something like this, like, well, we're screwed. And if that's the conclusion, that's kind of the end of the story, and everyone can get off the podium at that point. But I think there's actually things that can be done, because we're really talking about working around the edges of things. So smaller increases in maintaining fresh water supplies, or using less of them in agricultural production systems, crops that are more resilient, can tolerate a little higher salinity. It's not that we are impassive in front of these changes. So there are places that investments can be made across of these, and they're in policy and they're in technology integrated across those, because we're really talking about things at the margins. Recently was a map put out that modeled the change in Aedes aegypti, which obviously has been in the news because of Zika and other spreading viruses. And the critics said, well, with the climate change scenarios, it's not moving very much. Well, if you're into population immunity, not very much is actually really important because it moves into a vulnerable population. I think that's a lesson, though, in that we can actually work around the margins of the problem. We don't have to say, we've got two decades and we better reverse this entire increase in temperature or we're totally out of luck. We need to actually look at mitigation efforts that will protect those vulnerable communities and vulnerable regions, best arm them with the resiliency that they need to actually deal with the changes that are coming.
So, Jeremy, could you talk a little bit about how we can do some of that forecasting, some scenario-based projections to talk about what we should be addressing around the edges?
Sure. So we have reasonable predictive ability, particularly at short scales and longer scales. The intermediate scales we are not as good at, but we have a very clear sense of what the hotspots are, both domestically here in the United States and globally. And the challenge is less knowing what problems to anticipate and when they're likely to really become unignorable, and more getting people to pay attention to them amongst, in the setting of the cacophony of other issues that are confronting these systems, and acting proactively to address them. And in a lot of ways, the United States is a pretty good example of that problem. For instance, if you look at Florida, and Florida is really ground zero in a lot of ways for emergence of many of these different issues, less the nutritional and agricultural issues, but certainly sea level rise, temperature rise, vector-borne zoonotic disease increases. We've now got dengue reestablished there, we've got chikungunya there, we've got Zika there. One of the people in our group here in the Center for Health and the Global Environment did some mapping and prediction studies that identified Florida as the location where Zika would emerge, and yet we don't have the proactive management that we need and the productive discussion around the emergence of these risks that we need to manage them more effectively. On a related note, I think I want to highlight that for environmental health, we've actually made a lot of gains in recent decades around management of toxicological exposures and air quality and other things. Well, there's a lot to celebrate in environmental health. Climate change presents a real challenge for environmental health. It's in our house, as in the family of specialties in public health, but it's not something that you can manage effectively through regulation. We're past that point. We have to manage through adaptation, and adaptation is done very differently. A heat early warning system, you need really different evidence about how to construct and implement a heat early warning system and what works well in one community versus another, compared with reduction in greenhouse gas emissions and air pollution. And so we need a different framing for how we build evidence in environmental health and how we think about these impacts.
And I'm thinking about, too, what Ali Moqdad was talking about earlier. I mean, how different communities are going to respond and the different populations, Guy and James, who you work with, I mean, are going to receive and act on these in different ways. Maybe you could talk about that, what you see, how different ways that people are thinking about this in some of the environments you're working in. And while you're thinking about how to answer that, I want to invite people to start coming up to the mics so that we can begin taking your questions as well. So,
thanks. I wanted to address the investment issue as well, and I think in terms of public sector health systems, especially in Africa, there is that question of disinvestment.
Yes.
And we hear a lot about austerity in Europe and the way public programs and governments are being cut to repay debt. Well, these kind of programs have been going on in Africa for many years under the guise of something called structural adjustment, especially heavily indebted poor countries like Liberia, like Mozambique. And this has been one of the single biggest challenges we've faced in supporting health systems is their budget envelope is limited because they have to pay back their debt in these structural adjustment programs. And so when we talk about what do we invest in to prepare for climate change, I think we need to invest in advocacy to begin to get policymakers to understand that those kinds of austerity policies are really impinging and preventing us from building out the systems that really are so vital that we would need even without climate change, but climate change makes it even more urgent. And I know that in Liberia, for example, they still have a budget cap on how many health workers they can hire. And that's imposed externally by people from the West, not by the Liberians. And I think we need to really address that and be very vocal about that if we're serious about getting health systems and serious about the social justice aspect of this. The other thing I think that is really important to remember is the danger of the wealthy countries in the West. Our response, thinking about these problems in Florida, that our response, rather than helping developing countries, is going to be build a wall, an epidemiological wall, a surveillance wall, to protect us from these scary emerging infections. And we need to push back against that impulse and realize it's in our interest to help Liberia build its health system so Ebola doesn't become a more global problem. So I think you also mentioned, sorry, I'm going on a little bit here, but your second question about what are people thinking about it. And I can tell you, especially along the coast in Mozambique, where we do a lot of work, we work in a city called Beira that's already below sea level. And so many of our health partners are going, oh my God, what is going to happen? We already flood every year, and every year they have a cholera outbreak, every single year. And we know this is going to get worse and worse and worse. And so they're very concerned about it. And then you're just back again to what can you build in the public sector to help governments and local institutions cope with what's coming.
Guy, did you want to add anything?
I think the only thing I would reiterate is what my colleague Jenga and the minister brought up this morning, is the importance of engaging communities from moment one in any kind of adaptation issues, because obviously they know the issues. You don't have to spend a lot of time explaining drought to people who suffer from it. They're aware of what works, what doesn't work, what would be helpful. So I think just to reiterate, although we were talking primarily about other health issues this morning, I think the same concept of early engagement of the communities, letting the national ministries take the lead because they understand these issues, they want to mobilize these issues. So I think that with an issue like this that is equally imperative to any other global health issue is that the communities are engaged and the national ministries are engaged from moment one.
Great. Okay, so speaking of Jenga, why don't you ask the first question?
Thank you. Great, very informative panel, and thank you so much. My question is, listening to the panel, I get the impression that, rightly so, that at least we are stuck with climate change for the next 2 decades. But I wanted to hear what we should be doing now to slow down the climate change even after the 2 decades. And maybe I missed that, but I didn't hear enough of that to know what globally we should be doing to slow that. Are there targets we should be working on? Are there things we should be working on to slow that so that we can at least expect that our children, even though those of us who are my age and older may not be around to see the benefits, but at least we can expect that. And maybe alongside that, can you confirm that all climate change is man-made, or is it some of it just natural and we have nothing to do with it?
Oh. Lisa,
I've
right
got
in
the
your
rest of the
wheelhouse.
afternoon, don't
Yes,
I?
exactly.
I'll take your second question first. It was mentioned that I'm a tree ring scientist. And it's because about 30 years ago, I asked that same question as to how do we understand these current trends with respect to natural variability, and went to these past records of climate variability to be able to parse that out, because I knew that we would be, I anticipated that I'd be standing here at some point telling people that they should do things about climate change, and that for us to legitimately make that request of society, we needed to be able to definitively say that the warming that we are seeing is due to human activity. And we can talk afterwards. It absolutely is. There will always be some natural variability that, quite honestly, thankfully gives us, some respite from some of these monotonic trends. But the thumbprint of humans is quite real. So as we talk about what we should do about it, for many years I had what I sort of think of as my little happy face response, and would echo what you see on a lot of websites, that, you too can help stop warming, and there would be the 10 things you can do. And it's about transportation options and home heating and cooling and eating less meat and eating lower on the food chain, etc. And now luckily I don't have my name tag on. I am no longer speaking as the Dean of the College of the Environment. I'm speaking as Lisa Gromlich. I started to feel really stupid saying that. Because in fact, all that is doing is slightly bending the curve that is going forever upwards. And so what we actually need to do is to get serious about deep decarbonization of the economy locally, nationally, and globally. And that is the hard conversation that's getting harder every day that we need to insist upon as citizens. And I'm saying that as a citizen here. Thank you for your question.
And did that answer both of your parts of your question, Jane? Okay, great. Yes, yes, please.
I'd like to add two things quickly. The first is that aggressive reduction in greenhouse gas emissions. Greenhouse gases come from a variety of sources, but reduction efforts almost always improve health for other reasons. We call those co-benefits to health of climate change mitigation. And importantly, those co-benefits accrue almost immediately. If you decommission a coal-fired power plant, you see improvement in respiratory health around that plant and more distantly, almost immediately. And those co-benefits mature over a matter of a few years. Whereas the avoided impacts obviously are decades off from a climate change standpoint. So it's an important dynamic to highlight, that investing in climate change mitigation is good for health. And it is good for health for the most vulnerable because they typically are more exposed to those things. The other thing I want to point out is a little bit uncomfortable for me to say in a group of global health scientists and practitioners, but we should look at our own house and think about the emissions that we perpetrate. Flying produces a tremendous amount of greenhouse gas emissions. It's bad for health for lots of other reasons as well, but and I understand personally it's very difficult to do our work, and it's difficult to be a scholar and advance over time if you don't build your reputation and you don't engage with the communities that you are invested in, and usually that means flying and traveling in other ways. But I think it's important to consider whether all of that travel is always essential.
For those of you in the Million Mile Club, yeah. I'm not going to make eye contact with anyone in the front row. Yes, your question.
Hi, my name's Juliana Rigg-Hillard. I'm a stay-at-home mom of 2 small children, and I fit in global health consultant stuff at night. I'm a political science by training, and I'm really interested in how you translate this information into policy and advocacy. And I've sort of heard some answers about that just now as I was walking up. And I was going to ask, as Washingtonians, what we can do, like 1 or 2 things. Call our senators, do something, or is there a thing that we can do to help translate this into action, or just fly less? Or I'm just hoping for some to-dos rather than just learning. So, thank you. I don't know if you have anything else.
No, I'm really glad you asked that question, and I was going to. I'm glad you asked it. So, James, you've got an idea, and then we'll.
First off, at HEI, anybody who knows HEI knows that we have a rule that everyone rides a bike, and you get discounted 10% of your salary if you don't. So we're very militant about that. But I also wanted to take advantage, just kind of to hit that advocacy activism button again, that it'd be good to be training people. We have great students here in the Department of Global Health, and on March 1st, they're sponsoring an event called Surviving Catastrophe, Public Health and Solidarity in an Era of Climate Change. So I think it's a good opportunity for students to kind of have that discussion and move that kind of agenda forward. And I'm also reminded when I think about what can we do, the Dakota Access Pipeline apparently is back on on slate, and I just know how proud I was of so many people who went out there to try to stop it, and I think we need to continue that kind of activism, especially in the current climate, is that has an impact, it's high visibility. So,
Are there,
my students.
So I would like to dig into that a little bit, and Mark, I'm almost tempted to kind of ask you for, Mark's here from the State Department, works on the Global Health Security Agenda effort. But what can we say, because we tend to talk to ourselves, and we have our own ways of talking, and we agree with everything that each other says. So, or many things that each other says. So can you imagine some different ways of casting this to speak to an administration and a different way of political thinking? So I'm just toss it out there. Has anybody thought about it? I'm sure you've all thought about it, but does anybody have any great ideas?
I think James handed me the microphone just because he's trying to get it out of his hands in response to a question like that, which is probably a good move. It's a great question about what you can do, and I think there are things that can be done, and I'm going to focus on within the state of Washington things we can do. Water resources, as were mentioned, are extremely important to this state, and how we preserve and we take care of our water resources. Especially if we no longer have the snowpacks that we've become accustomed to for our natural reservoirs. But part of that is to look at our state as a whole. There is a tendency, people in Seattle talk about the east side, they're talking about the east side of Lake Washington. When we talk about the east side, we're talking about the east side of the Cascades. And it's to see the state as a whole, and to be invested in the agricultural communities, to be invested in the agricultural communities because they use a tremendous amount of water, and how they take care of those water resources and how they respond to both legislative initiatives but also marketing initiatives. I think it's very important to be involved with that. One thing the state of Washington can do very well, and it has done in many different areas, and I think they can do it in this area, is take a leadership role. And by engaging across the spectrum of things that do put carbon into the atmosphere, and also looking at our adaptation strategies, I think Washington State has a potential to be a leadership. And I think as our global health, the tremendous spectrum of global health engaged parties here in the state of Washington have, it would be an ideal opportunity for them to take that leadership role.
Does anyone else want to add anything? Mark, I saw you got up. Did you want to offer any? So introduce yourself to the
Hi, Mark Farino. I work at the U.S. State Department, and I just happened to be out here, so dropped by the conference. I only had two choices. One is to run away when you mentioned my name, which wouldn't have been seemly. So the other is to try to bring some thoughts to what you were talking about. And I thank the Minister for raising Global Health Security Agenda this morning. That's something that I work on at the State Department and with the wider U.S. interagency. For those of you who don't know, it has grown. It was launched on February 14, 2013. 14, excuse me. So we're coming up on the third anniversary on Valentine's Day, which is appropriate. And it was a few dozen countries and Director General Chan and the FAO and OIE that were involved in launching that. It's now grown to 55 countries. And within the construct of GHSA, we have the U.S. and other countries who've made concrete commitments to assist countries in building capacity to prevent, detect, and respond to infectious disease threats. Liberia, of course, is one of the countries that we're working closely with. And one of the main points of bringing the Global Health Security Agenda together in 2014 was to raise high-level leader attention to this issue and to bring health and security together. So it's multi-sectoral. We haven't talked about that much today, but I think it's one of the great strengths of GHSA that it brings the security sector into these discussions, because if you just have the health sector talking about how to prevent and detect and respond to infectious disease threats, you're not really going to get to a complete solution. The other big strength of GHSA is the One Health approach. And I think having FAO and OIE and the wider non-governmental community involved in GHSA since its launch has been very helpful in that respect. And so we work a lot on trying to get animal health and food security issues at the table when we have the ministers there. annually, and we try to get those discussions going so that it's not just, of course we respect WHO's primary role in global health, but this can't be done just with the human health side, with 70% or so of diseases coming from the animal sector. So we know that. But the environment has always been kind of the orphan stepchild, and I was out here with Ambassador Jenkins last year, and we had some great meetings at U of Washington, UW, and including with the environmental health folks, and pointed out at the time that while One Health includes the environment, in the GHSA context, it hasn't really come to fruition yet. And so I'm encouraged to hear what we're talking about today. And I think we're at a critical juncture where we're working very closely with WHO now to do joint external evaluations in each country to assess the capacity and find out where the gaps are, and then to find ways to fill those gaps, not only through government contributions and foundations, but also through other non-governmental stakeholder activity. So it's a really critical time for the academic community, for NGOs, for implementers who work on the ground, who have these local and global networks, to really come to the table with the global health security agenda and address these issues and figure out how to integrate this into our approaches to building capacity. I think it's vitally important. I think people recognize it, but there's so much emphasis on the human health and then as an adjunct, the animal health, that sometimes getting the environment in there is just not something that people have focused on. So great to hear this discussion today, and certainly if anybody's interested in GHSA or how to get involved, come see me in this corner later.
Yeah,
Thank you.
Thanks a lot, Mark. And it's interesting, the GHSA work with having these sort of non-traditional stakeholders together working. And if you talk to people in the Defense Department, they're very cognizant of the impact of climate change and are way actually ahead of other sectors in thinking about this in some ways. Yes?
Hi, I'm Bob Hackman, pathologist at Fred Hutch and UW. And a lot of your comments over the last 5 minutes have really addressed this question. But it is, in a nutshell, how do we effectively communicate with people, increasing numbers of people evidently, who hear the word theory and they decide that you don't have any answers, that you just have a theory, and they turn away. We're trained well to communicate with one another, as you've pointed out, but there's a big gap in our preparation, I think, to communicate with the general public. Are there any suggestions about how to do that better?
Lisa or Jeremy, have you had some experience in thinking about that?
This has been something of accelerating interest as we have felt this gap of all those things that kind of precision of language and dispassionate way that we have been trained to interact as scientists. All of a sudden we're being told that isn't so effective. I don't mean to put you off by just saying Google it, except that right now there is some wonderful discussion about how we retain that core values of sort of robust understanding and at the same time develop a common understanding of shared values, particularly with individuals for whom science is suspect at this point. And it involves humility on our part. It involves a really kind of different style of communication. And it's not something that is necessarily easy to do. And one of the things that we're doing in the College of the Environment is just training, particularly our younger people who aren't old dogs trying to learn new tricks. Really getting that sort of science communication is not just not having jargon on your PowerPoints. It's a much more human process, and I urge you to pay attention to it, and to the degree to which you and your colleagues and your research group can and just really practice it initially among yourselves. It's not things that we necessarily are comfortable with initially, but it's a great question, and as a more senior person in the field, taking risks and putting yourself out there and just doing it and starting to do that practice of communicating with people who are hard to communicate with at this point.
That's an encouraging answer. Thank
Yeah.
you.
So Ambassador, Minister Garcia last night, when Judy asked her, what would you do differently? What should we be doing differently or adding to what we offer here in training? And she said communications in terms of government and advocacy was so critical. I think if we just market it as alternative facts and just brand it, own it, and then maybe it will be adopted. But
So I would encourage you also to do some browsing, but I would point your browser to George Mason University, and there's a Center for Climate Change Communication there. Ed Maybach has done a lot of work about framing climate change and its impacts from a health perspective. And health can be a bit of a Trojan horse for discussing these things because everyone is invested in their own health and the health of their communities, and it's generally a nonpartisan issue. And so it's a nice frame. They also suggest to have a relatively positive frame for your communications. I don't actually personally always agree with that. I think that there are some risks that we have to confront that are very difficult, and we will have to consider managed retreat in some settings. We're going to have to consider taking money away from other major priorities to shore up infrastructure in some locations. I think we're going to have a very difficult time with some of these things, but I think a forthright approach and being open to even the emotions that come out about it. This is a very upsetting thing for people, and to be able to experience that and understand where people are coming from in an empathic way, I think is fundamental.
Okay, so thank you very much for the question. So we have very little time left, and I have like the two biggest deal people here. So I'm not quite sure where to go, but Steve, you've been waiting for a while, so you get to go. And then, and so why don't you each? Yeah, no, I'm not. There's no way I'm cutting you off, Judy. So Steve, you go. You go first.
It's okay.
Thank you.
You're
Steve
welcome.
Lloyd, University of Washington, Department of Global Health, and HAI. I'd like to sort of challenge this last question that has been discussed around, well, what do universities do in our role of communication, and to ask if that's enough. And the reason that I'm asking this is because I was struck by the fact that two of you, Jeremy and James, discussed the issue of debt. I thought it was interesting. Jeremy talked about climate debt, the idea that we as the North owe this debt to the South, but nobody's talking about paying it, right? And James talked about the international financial debt, which was from the South to the North, and of course the South is continuing to pay the North at an enormous amount more than the original debt that was taken out, which is very much related to the kinds of things that the Minister of Health, Minister Don, was talking about, and is a huge constraint to health systems development. So the interesting thing about this to me, which is what struck me, is that the climate debt we knew about in 1988 at least, and actually in the 70s, I think, but in 1988 Time magazine had the Earth as the planet of the year when we were concerned about climate change. So this has been going on for a while. And the financial debt that we're talking about has also been going on since the mid-80s. So we're talking, 30 years. And we've done a lot of research on that since then. And what has happened? Not much, I would say. In climate, I think things are perhaps worse, in terms of financial debt. I don't know. So the question that I ask is, what do universities do? Do we generate more knowledge? Do we communicate better? Or do we actually do something fundamentally different, which is to take our social citizenship role and to move beyond where we are in terms of trying to be simply objective scientists to get more information? Now that's hard because we're NIH funded and blah, blah, blah. But I would just wonder if we could learn from, for instance, what happened when, as Peter knows very well, when we had a global apartheid around AIDS treatment, that Harvard University came out with a consensus statement that actually had a huge impact in the world's view of whether it was correct and ethical to treat AIDS the way it was being treated, or whether we should actually go towards universal treatment, which we did, thank God. And the role of a university, it seems to me, is always something constrained by many people who say, gee, we have to be objective, we have to just create science, and then somebody else will take it to the next level. And I'm just wondering whether in 2017, particularly after 30 years of dealing with some of these really intractable issues, whether we ought to step up to the plate to do something more like Harvard did with HIV treatment, or like we might do with either climate change or debt or some of these other issues. So I'm asking any or all of you, what role do we have beyond communication to really address these fundamentally social, political, economic issues?
So I have one of my favorite PowerPoint slides is a loading dock that's white against a white building that's particularly effectively sort of sterile, and talk about sort of some of our communication strategies tend to be this loading dock approach of, and I say this to a community that you guys are so much better than we are in terms of actually thinking through translational and implementation science, but it's still somewhat of the loading dock analogy. So personally, when I think about this, it is just turning our backs completely away from the loading dock strategy and thinking about how it is that we very intentionally create the institutional linkages so that in a very dynamic way, the information that we are using gets into the hands of those elements of civic society that can actually effectively push policy levers in a way that is more effective than all of us signing on to the 1 million petitions we've been asked to sign on in the last couple of weeks. And doing that in a way that is incredibly sophisticated and strategic, which means that we also have to be willing as a community of scholars to actually at times take a couple years off, potentially change career trajectories to actually go into public leadership. And, it's not like I'm horribly original here. It was a couple days ago in the New York Times. I was talking about scientists, running for public office. It's getting out of our comfort zone in all sorts of ways. But I will personally defend the necessity for there to be a role for universities in being robust, reliable creators of knowledge that can be labeled as truth to the degree to which truth can ever be labeled. So I hope that wasn't too swarmy of an answer, but the partnerships are key. And once again, I say this to a community that I think is so adept. I mean, you guys, every one of your acronyms has the P word in it. So, you guys are so well poised to actually take that to the next level, and the environmental science community will be right there with you.
Okay, yep, we'll do quick ones because I know, yes.
Thank you for that question,
It's
Dr.
not-
Gould.
Yes, yes, was that, yes.
Just a real quick comment. We heard from 2 ministers of health yesterday who trained here, Minister Garcia and Minister Don, and both of them, I think, really drove home the point that they have jumped into incredibly politicized situations. They're confronting industry, they're confronting all kinds of currents, they're confronting international funders, creditors, relating to the debt issue. That's the reality of doing global health. And so I would say, in the spirit that Steve's mentioning, that we need to be training people to be ready for that. That involves advocacy, maybe even activism. The AIDS movement does provide a great template for that. Can we have a health systems movement that we can support the ministers of health that we're training here? And what they said is they got a great training here, but wouldn't it be great if they had gotten even more around what it's like to do this in the real world, and that we should not be afraid to engage that.
I'll try to be very brief, but I do think it's important to highlight a couple things. The first is that the Intergovernmental Panel on Climate Change has highlighted the role of learning in climate change, in the response to climate change. It's very clearly elaborated in the, if you Google again, the SREX, the Special Report on Managing Disaster Risk. And there are different kinds of learning. There's first loop learning, second loop learning, and third loop learning. And first loop learning is essentially reflexive. If you're driving a car, you encounter a hazard, you hit the brakes. Second loop learning is somebody puts a stop sign where hazards tend to pop up. Third loop learning is thinking about that whole system and what's the best way to get people around. And if necessary, promoting fundamentally transformative change in the way that you achieve the objective of the system. And I think our role in the university is to promote third loop learning as much as possible. And I think in the case of climate change, one thing we haven't talked about, but I wager it will come up at the 10-year anniversary next time around, is that we've got some tools in the pipeline around the control of nature, gene amplification and gene drives and geoengineering and other things that I think may well be deployed in response primarily to changes in natural systems from climate change. And it is our role, indeed our duty in a university setting, to be open to studying those as possibilities and tools we may want to use, or things that we may want to stay very clear of, and identifying the risk associated with those things to the people that we care about.
Great. Judy.
So Guy, you led off with a beautiful point about this planet's carrying capacity. I want to come full circle on that because the one thing that nobody talked about, didn't get mentioned at all when we had multiple questions about what we can do, is family planning. Mm-hmm. And in fact, I think for policy and programs, helping people think about the linkages between that health-related piece and global environmental change is something that we might do. So I'd be interested in your thoughts about that very quickly, and why it didn't come up.
Guy, do you want to start on that?
I'm not sure why it didn't come up in the discussion. I think it's obviously, as I had said in my opening remarks, even if you assumed a completely stable climate, population alone drives many of the environmental changes and has ecosystem costs to it. So obviously, understanding and reducing population growth is an integral part of this. But also understanding from a community level what things lead to improved family planning and improved decision-making at the household level, women's decision-making, understanding those at the community level. Obviously, I'm speaking to you. I'm not telling you anything you don't know, Judy. But these things are, incredibly important to know what those decisions are, and we all know very well that the importance of education for young girls is just fundamental to this. And so I think everyone in here would embrace the role that education of girls and them beginning to make reproductive choices and other choices over their life becomes integrally involved with global health and also these changes we're talking about.
I think sometimes we connect the dots and we assume everybody connects the dots. But when we talk about communication, I think a lot of policymakers, program managers, and the public don't necessarily connect those dots. And so there is a whole domain in which we can move both for advocacy and for programs in that area.
Great. All right. Yep. 10 seconds.
10 seconds.
Yes.
Yeah,
Well, 15. Okay.
I'm a little bit of an outlier on this issue. I think we have to be very careful. Population has a very checkered past, and in much of the developing world, it's been has a history of being coercive and blaming developing country populations for growing too fast, and they're the problem. And the carrying capacity issue we're talking about is really driven by us, our population. Not that we shouldn't be providing family planning. I just, as an educational factor, global population and population control has a very problematic history politically in developing countries, and I think we have to approach it very carefully. while also providing birth control as opposed to population control, things that empower women. But population control does have a bit of a checkered history of the West trying to control local population growth. So I just wanted to kind of put that out there, although I support, obviously, the provision of family planning.
So can we thank our panel? Thank you so very, very much, everybody.
Wow, that was amazing. I knew it would be great. Lisa, moderator extraordinaire, thank you, thank you. We have a break now. It's supposed to be 20 minutes. We were on time until the last few questions, but so be it. Take 15, come back at 3, please.
Can you
He's right there. He's right there. We're okay. Good. Okay, welcome back, everybody. Take your seats, please. Yep, got it. Okay, welcome back, everybody. Thank you. We are on panel number 4. Congratulations, everyone, for making it to the afternoon. I have to say, this panel is Innovative Approaches to Global Health Education and Training, and I have to say, as much as I love the science all for the rest of the day, I have been most excited about this afternoon because we've been hearing all day, it's really the people and interdisciplinary training and intersectoral work that make a difference in global health. I want to point out that all 6 of the people on stage are products of the educational program of the University of Washington. Our moderator is Chris Elias, who's president of the Global Development Program of the Bill and Melinda Gates Foundation, a product of the University of Washington, and an affiliated professor of the University of Washington. And we're at the Gates Foundation, he's in charge of their work making health improvements deliverable to populations. He previously was at PATH and then previously was here, so he is quite intersectoral himself. And I think he's going to now introduce the rest of it. Thank you.
Thank you. And thanks, everyone, for being here this afternoon. And panelists, boy, do we have a challenge to keep up with the previous panels. But I know we can do it. I've been, we've talked over the last month, all of us, and I've been thinking about this panel, particularly over the last 24 hours. We're going to talk as the last panel today about innovative approaches to global health education and training. And one of the reasons I've been thinking about it so much in the last 24 hours is because I knew I'd be here today, but also because global health lost one of its most innovative educators and trainers yesterday. Hans Rosling from the Karolinska Institute passed away yesterday. And Hans, perhaps better than anyone else in our field, I think, has captured some of the challenges that we have talked about in the previous panels of being innovative, reaching audiences with communications styles, putting data, making fun with data. So I've been thinking a lot about Hans since yesterday and thinking about, over the course of today's discussions, about how do we respond to what are some pretty challenging times in terms of I think when I was a product of the University of Washington almost 30 years ago, the emphasis was on research, on science, on producing good science and publishing it, and maybe talking about it at conferences. And I think we were perhaps naive even then that that was going to be sufficient. I think we've learned, certainly in the last 30 years, but even more so in recent days, about the challenges of communicating science to effective policy. So I look forward to our panel discussion. What we're going to do is first we're going to hear from Patty Garcia, the Minister of Health from Peru, who's going to do a bit of a stage setting. And then we're going to turn to our other 3 panelists. You've obviously met Peter and Judy already in their roles. Judy is the chair of the Department of Global Health here at the University of Washington. Peter, the director of the London School of Hygiene and Tropical Medicine, and one of our keynote speakers from this morning. The other person you haven't met yet is Elizabeth Bukusi, who's the chief research officer at KEMRI, the Kenyan Medical Research Institute. And so what I'm going to do is ask Patty to go first, and then we'll come to Elizabeth, and then on to Peter and Judy. And what I'd like to do is have you all thinking, because I think this time of the day we want to have as much audience engagement as we can. I'd particularly like to encourage the students to think about coming to the microphones and sharing your perspectives on what is the next innovative thing in education and training. You're obviously engaged in the education and training programs of the University of Washington now, and it'd be great to hear your views as well as those of our panelists. But before we do that, let me turn it over to Minister Garcia to give us some framing thoughts.
Well, good afternoon, everybody. I hope you're still awake, and I hope that we can have in this part of the panel a great discussion, because I think it's not only a fact of discussing about global health, but creating the new generation. And if you see the title, it was the next generation. How do we do it better? So, first of all, when Judy and then Chris told me about this, the discussion was, so what do you think we should be doing better? And what do you think from the kind of things that you learn at the University of Washington, you would have liked to learn differently, or other things that you would like to learn? So that reminded me, I hope this works. Oops. No? Oh, that is me, okay? So I have to say that yesterday I was talking about all the things that I learned at the University of Washington, and I'm very, very grateful, and I gave my top 10. But here, you're gonna hear about the other things, the ones that give me nightmares every night when I say, like, why I never learn about how to do this. Now that I'm seeing, and I'm trying to work public health, global health in the real world. So that's kind of what I wanted to talk to you and share with you. And during the day, we have been talking about all the challenges that we have related to global health in this 21st century. And I think we have to review them, because those are the kind of things that we need to really be sure that we are addressing in the training of this next generation. So what we see, for some reason the slides are not coming well. So one of the things is we're seeing these demographic changes, epidemiological transition, and we have talked about non-communicable diseases together with infectious diseases. We have talked about climate change, and that is something that we really need to discuss, because that is definitely causing problems with health. And I mentioned yesterday that I almost didn't make it, because in these past 5 months, we have had in the country things that I have never seen before. So we have droughts, then we have fires in the forests that we have near the jungle and also in the Andes. And then we have landslides, because the land was too dry and it was raining. But it rained so much, then we have problems. And then we have these weird winds that push the clouds over the mountains. And so we started having these incredible, unexpected rains in the desert, so in the coast, and now we have floods. So this climate change is causing a lot of problems, and actually in these past months, I guess I have been having more problems related to climate change and human diseases than just human diseases alone. And so we have all these issues about humanitarian crisis, okay, that relate to climate change, to demographic changes, and to diseases that we have not been able to control. And we have the issues and the big morbidity associated with mental health in huge human communities and big urban cities. And everything within this interconnected world that is allowing us to share good things, but bad things also, like bad practices. So Peru is one of the countries, and I think it was mentioned, that has the highest rate, okay, of growing of these fast food restaurants. Although we have an incredible cuisine, and I invite you to try it, okay? But we also have all this fast food, and that's why people are becoming obese, and that's happening around the world. And finally, almost at the end, we have all this social pressure to do more things, But we have also the technological pressure and the pharmaceutical pressure for things that had to change, okay, that are not necessarily proven to work, okay, but are quite expensive and can really put in a specific challenge, a very difficult challenge, our health systems that are not prepared for these expenses. So this is what is happening in global health in the 21st century. Are we preparing our next generation to address all these issues? In general, we have to think about the curricula that we are using, but we will need to think about also what are the skills that we are addressing. So our objective, and we have discussed this also, is we need in global health to decide and to find a way of creating systems, health systems, that sure promote prevention and ensure access and care in all different areas. And so the question, are we training people with the right skills to address those challenges in global health? So all the ones that we have seen. To tell you the truth, it might be because I train in global health and I have been in global health for so long. I don't remember we used to discuss enough about issues of climate change, emergency preparedness, or others. So I think we have to look at this whole list of issues and see how can we address them when we are preparing people. But not only that, are we training people with the right skills to interact with the key actors in global health? And global health is a very complicated scene. So we have people, we have governments, we have donors, we have NGOs, we have media, and we have the private sector. And all of them are part of global health. And we need to find out how to address the issues and interact with them in global health. So I just want to give you my list of things that I think we need to really start thinking on the training of the next generation of global health. So number one, communication skills. And I think that's one of the key issues. And so we need to deal with the media. So media training is one thing that I learned that is quite important. But we need also to learn how to speak with policymakers. Everybody says that it's so difficult when you're a scientist to really reach the policymakers. But when you're on the other side, you hear all the complaints of the policymakers about what the heck these academics are talking about, okay? So what do they mean by this odds ratio, for example, okay? And so we really need to address, in order to create these bridges from science to implementation or policy, we really need to work on these communication skills. The other thing which I think it's important is some way, doesn't mean that everybody should become a journalist, but we need to work on some type of creative writing or journalistic writing without lying or creating false stories. I think we have to create stories to really make our point when we want to work in global health. Okay? It's great when you have a team and you have a communicator and other people, so that's wonderful. But sometimes you're alone in the field or you want really to do something. So I think that's another skill that is quite important. The other thing, we talk about social conflicts, that we have to deal with people, we have to deal with donors. Negotiation tactics, skills, and strategies are things that we need to develop in global health. I think fundraising, and I didn't change, fundraising, it's another important thing. And how do you do networking? Especially when you are going to be dealing with so many actors in the global health arena. Another thing which is key is task shifting, okay? And there is a discussion between task shifting and task sharing. You can share tasks when you have enough providers or enough people in the field. But we have heard that, especially in developing countries, several times what we are addressing is the lack of human resources. So task shifting is something that we have to discuss. Task shifting for maternal health, cancer, cancer management, we were talking about doing task shifting, for example, for chemotherapy in rural areas. So we have to start thinking innovatively about things that people in global health need to learn in order to be able to implement it later. Next one. So teamworking skills. You cannot do things alone. And for these teamworking skills, planning and organizing teamwork, how to delegate and supervise, and leadership skills. I think leadership is something that the University of Washington has been introducing earlier and has been working closely, but I think we have to really put that, give it the importance that it has, and it's very, very important from my point of view. There is another thing which I read like 3 or 4 books, and it was really, really helpful for me. How to deal with difficult people, okay? And in global health, you will need to deal with difficult people everywhere. The most difficult people for me are the Congress people, the congressmen, okay? But you can find it everywhere. And so there are ways in which the people that are more negative you can bring them from the dark side into the bright side. And so there are techniques for that. That's what I was surprised, that there are techniques to do that. And I think those are the kind of things that those skills that we need to teach also. Policy formulation and implementation, and politics, okay? The poker face sometimes, and how do you deal with these type of issues? I think those are things that we cannot be naive in global health, and we have to teach, and we have to discuss also. Next one, please. So my list continues, okay? And it doesn't mean that global health is global health by itself is broad, but we need to discuss these issues. Health administration, procurement, health economics. Because if you really want to convince a policymaker about something, you need to talk about cost effectiveness, and you need to talk about numbers. So we were talking about the best buys, right? So those kind of things had to be discussed and had to be included. Health technology assessment. And this is a key issue, especially when we are talking about the technological pressure to include within global health, within treatments and within interventions, things that could be too expensive and not necessarily are the best buys. Ethics, especially when we talk about corruption that we can see everywhere, and how can we deal with it, because that is something that you will see daily, okay? And you need to deal with it. Time management and survival strategies, okay? And finally, I wanted to put this also, emergency preparedness and response in disasters, because it may happen. It may happen when you work, but it may happen to you when you are working also. So, but I think the most important thing is to discuss how should we teach those skills, okay? And those contents. So I think traditional academic approaches are not really filling real needs. So in some way, we need to stop sitting people in classes and having these magnificent talks, okay? So we need to think about different ways of approaching, and probably we need to start training more in action with mentors, with opportunities to understand the actors in global health, with opportunities to see what are the processes, okay, what is happening in the real world. And I think we need, and there were some things and some words that I think are quite important, we need to start working bidirectionally, okay? So if we're talking about global health, we're talking about having a training to be a global player, right? A global actor. So how can we really, and this is something that we started to do with Joe Sant, how can we have these programs in which we have students from the north and students from the south learning together using technology, one on one side of the world and the other one, discussing issues that could be common but with different views, and eventually getting together in one side or the other side of the world and trying to approach these problems. So we had some examples. We had the Cuscaya program. Cuscaya means, it's a Quechua word that means working together. It's incredible that the Incas, that were the ancient Peruvians, had words, had one word to say we can work together. And they had one word to say to describe the place where you work together. Is the Cusca. So Cusca is the place where you work together, and Cuscaya is working together. So we had this program, this Fogarty program, where we are including students from the north and excluding from the south. They have some training, previous training, using technologies, internet and connecting, and then they get together and they try to approach one problem, solving it together. And they work for a year on research on the issues that are important for the country, but they discuss and they learn how to deal with these global health issues together. So I think there are lots of challenges, but unless we start changing the way we are training the next generation of global leaders, we're not going to be able to really reach what we want. Let's think about new contents, but let's think also about new approaches. There are excellent examples, but we need to be sure that everybody is able to address these issues. And I think we're all getting older. So we need to reach this new generation because problems are going to be still there globally. Thank you.
Thank you, Patty. And Peter and Judith, as you know, people who run two of the most important global health training programs, Patty has a long list for you. But before we come to you, we're going to make the list longer by asking Elizabeth to make a few comments. I think, Elizabeth, I'm guessing that as Chief Research Officer for an important institution in Africa like KEMRI, you're probably engaged in dozens of collaborations and partnerships with people nationally, regionally, globally. How does the world look from KEMRI in terms of how well we collectively are training the next generation of global health leaders?
Thank you very much. First, let me just say that this is the best time for me to have been on the panel because my body is fast asleep. It's probably around 4 a.m. Nairobi time, and my body doesn't know what I'm doing speaking. So anything that I do say, let me first say a disclaimer that I'm not responsible for anything that I say hereafter. And then I really feel very honored to be on this panel, recognizing that I'm probably the least distinguished among the many people sitting here. And my greatest call to fame is that I am the one student who King Holmes managed to get to do a study that he had wanted to get a student to do for a long time. It was called the Willie Wash study. And I was the only person he managed to convince to get that study done, and it was my call to fame. 20 years ago, I was a student at this very institution for the first time, and it's really a privilege to have come back. And as you ask, what does it look like when I think about training the next generation of global health leaders? And when I look back, Patty has really done an excellent job of stating all the things that I would have wanted to state and some more. So maybe let me just give you a few examples of how the things that she has said resonate for me and for the work that I do in KEMRI. I think in the last 20 years that I have been part of the global health world and arena, and again, I'm one of those people who did international health, not global health. Steve Gloyd was my lecturer then as well. And in the last 20 years, there's been a good job done of training those of us who have come to look at ourselves as being epidemiologists and global health leaders and doing research that we hope benefits our countries and health for the next generation. However, there are many areas that have been lagging behind. One of this is the area of ethics, and Patty has mentioned this. Research ethics, but also ethics in general. In Kenya right now, we have a doctor strike that has been going on now close to 60 days. The public health facilities are completely paralyzed. People have not been able to get health care. Of course, it does affect research as well, because a lot of the research work we do does happen in public health facilities. Now, I raise the issue of ethics, not just research ethics, but ethics in general, because even though the doctors do have some very good reasons why they have gone on strike, there needed to be some kind of a plan that at least managed some kind of health care so that the poorest of the poor, who are the ones who are really dying in Kenya, would not get affected. But one of the challenges is we have not been teaching clinical ethics to many of our doctors. We haven't. As a medical student, I was not taught anything about ethics. The very few lectures we had about ethics, the lecturers didn't show up themselves. So there was very little ethics to learn from them. So that's one area that we haven't done well on, and that I think we still need to do more work on. We cannot build a foundation of getting good data, doing good research, if the areas of research regulation and ethics are not taken care of. So that's an area that needs a lot of attention. The second area is just research administration itself. I've had the privilege of coming back to the University of Washington a number of times, and I've given a lecture on what they didn't teach you in grad school. And one of the things they didn't teach me in grad school, when you do get that grant, how do you manage it? What are the things that you need to do in order to get what Pat was talking about, the research administration, the procurement, the money? How do you actually get it out into the field? And though you have systems here in the developed world that probably make it relatively easy, in Kenya you can't cut a check for someone. They don't even have an account. So how are you going to get the money to them? So there are many things that we take for granted, perhaps when we write those grants and they're very well written. When you get down onto the ground, research administration is an area that's lacking, and it becomes a real problem. You have excellent scientists, they get the money, but they can't implement because the systems are not there to be able to support them. I totally agree with the issue of advocacy. And again, it's one of the things that we haven't really done well. Last year, I had the privilege of being hauled up to our parliament, but not for very good reasons. It's because there was some information that was provided to the parliament that was inaccurate, and I got hauled in and accused, actually, of perhaps pilfering money. Now, in Kenya, if you get accused that you might be pilfering money, everybody believes it because we have such a bad track record of corruption. But what it made me realize were two things. One, after thorough investigations, they found nothing, which for me was a tribute to say that indeed there was nothing I was doing that was inappropriate. But the thing it really made me realize is our parliamentarians understand nothing about what we're doing. And it's not because they don't want to, it's because we haven't told them. So they expect we are doing the same things that they do. And so they don't realize that we may be doing things differently. And it really made me realize that unless we have strong advocates that can really bridge between research and the policymakers, it will be very difficult for us to move the global health agenda. Let me finish off by just saying that communication remains a key part of what we must train. Communication and communication for advocacy. We must also ensure that there is strong mentorship. As Patty said, we're all growing older. Many of us will not be here in the next 20 years. I think people like my mentor, King Holmes, have done a good job because there's me, there's many others of us. But I need to do the same thing so that when I'm not there, there are others who carry that legacy beyond. We need strong institutions, very strong institutions that have systems so that it's not about me as an individual, but it's about a system that continues to do the work that needs to be done. And also true partnerships. I've had the privilege of being a partner and a work colleague with Jared for many years. We sat together in epidemiology. I realized many times that there are things that were said that I thought I understood that I didn't really understand, that he very happily explained to me thereafter. It was a partnership that was built then that has continued for very many years. But we need true partnerships that allow people to work equally and in their areas of strength and build on for each other. And the last thing that I want to say, which also I learned from King, is you never stop learning. I was impressed that even today, he's still taking notes. If you don't stop learning, then I think we will be able to continue to build very strong partnerships for global health. Thank you.
Thank you, Elizabeth. Peter, maybe we'll go to you. You've, what was it, 1978 you arrived here at the University of Washington? And you've been engaged in many other programs in Antwerp and London and on the advisory board, not just here, but in many other places. So you've seen a lot of the world of global health education and training. And so maybe whatever comments you were going to make and any comments you may have in reaction to Patty or Elizabeth's.
I can have the same disclaimer as Elizabeth. But no, I think that both Patty and Elizabeth gave the talk I wanted to give. But the scene is very different in Europe, to say the least, in terms of education and among European countries, where I guess like here, the whole higher education sector is under high pressure, and I think is at the verge of a crisis, but nobody wants to really admit it, or we're all very good at putting our head in the sand. Now, a few comments. One is, I think in terms of supply and demand, when it comes here to what we need in the world, and I was on both sides. When I was head of UNAIDS, I was very frustrated by the inability to recruit people who can do all the things that Paddy described. You can, in the best case, you have people with very strong quantitative skills, an immunologist and so on. That was a typical product from schools of public health or global health. And I would certainly not throw that away, because also in our, post-facto truth societies, we need not to compromise on that, on the facts and on the, and on the quantitative skills. But that's not good enough if you want to move agendas and if you want to change the world, because global health is about changing the world and nothing less than that. And so that's now on the demand. So that's when I was on the demand side. And in terms of the supply side, education is an incredibly conservative sector. And we're, for some good reasons, there is not much appetite to change things easily. And secondly, we're training people today for, the future leaders in 20 years or 30 years from now. That's what, and we just train people for the problems of today. And of course, you can't predict what the world will look like in 20 years. And so that's the difficulty that we have. So let me give you 3 points on it. The first one is on the what, in terms of innovation. And I think that's, Patty and Elizabeth summarized it very well. But I would like to add why we keep the importance of having, to train people who understand, who can analyze, and quantitative skills. We need to make sure that we train people in all the other attributes and competencies that we have. And that requires indeed different methods. And I think we should look at business schools, the case study method and things like that. When I mention that in my own school, that everybody, thinks I'm absolutely selling out to science. And I remember myself, many years ago, I took one of those executive courses at the Harvard Business School, which cost a fortune, but and that's where I was exposed to this case study method, and I revolted. In the first few days, I said, "This is absolute nonsense," because in our type of business, you try to demonstrate that something is wrong or is right or works or doesn't work and so on. Their case study, you just described how things went. You try to understand, and then sometimes the same factors lead to a bankruptcy and sometimes to a phenomenal success. It all depends. And but we need to rethink our our methodology there also on the what. And what's most important, I think, is to bring disciplines together. At our school, we have more and more master degrees with other institutions or mixing disciplines. It's a big challenge, culturally and so on, but we have we talked about One Health, with the Royal Veterinary College. We have one with on health economics and financing, that's with the London School of Economics. In mental health, it's with the Institute of Psychiatry, things like that. That's the, I have the easy task to say, let's do that. And then you get into the, the realities of the institutional, I don't know how to call it, but problems, okay? Now, on the how, and I think also that we need to infiltrate the rest of the universe in education. And that's what I meant also, that maybe at the end of the day, success is when there's no longer global health education. And that whatever you do, that it's in health or whatever, that it has that perspective. Now, on the how, we talked about case studies. We've been pioneers in what we called in these days distance learning. It was actually Harrison Spencer, who was one of my predecessors and was, killed in the summer, unfortunately, who launched that. And so we're offering a master's degrees, and that has allowed us to two things: have global reach, but also offer this to people who can't afford to stay away from a job for a year or so. And thirdly, more recently, it solves some of the visa problems that we are having, the visa restrictions. So that's something that we now realize. We were pioneers, but now we're getting behind in terms of the technology. So we have to adapt. We're also moving more and more into joint degrees with institutions in low and middle income countries. A lot of goodwill, very hard to do, but I'm firmly convinced that that's the way to go. And then in terms of particularly the postgraduate degrees, like the doctoral degrees, we're pushing people always nearly into a PhD type of program. And I think that for many, that's not the right approach, because that's great if you go into a research and academic career, but not if you are to be the global health leader of tomorrow. That's where the DRPH type of model is probably much better. And then my final point is that we've failed massively in, as part of our international development programs, now I have like a European perspective, to invest in higher education. There's been a massive, massive investment in education, primary education, secondary education. And tertiary education is always considered as a private good, nothing to do with development. But particularly for sub-Saharan Africa, in contrast to Asia and to a certain degree also Latin America, if the continent is not going to train the intellectual property lawyers, the engineers, the people who require higher education, it will remain a subsistence economy, extraction economy, and so on. And the quality of many universities today is much worse than 10 years or 20 years ago. And I was at the University of Nairobi in the 80s. And it was really a great place, but it's not always gone, most places have gone downhill because of a lack of investment, incentives. And so we should really think through how can we invest in it, not just do research there for publications, that's good for us, but really invest in that. And I don't know who should do that. I'm trying to convince in the UK Department for International Development to include that and see that as part of its development. And I think that's possible if you put some conditionalities in there that you don't subsidize the rich to get higher education. But there may be ways of going around that. Now my voice is gone. That's my other excuse.
Thank you, Peter. Judy, why don't you go? And then we're going to open up. I forgot to mention that Patty's going to have to leave a little early to get to the airport. So we'll have Judy's comments. And then particularly if there are any questions or comments for Patty before she has to go, we'll take those next. Judy?
Well, Chris, thank you. I think this is a period of incredible opportunity and need for innovation in global health education and training because of the grand challenges that we face, some of which we've discussed today, because of the profound changes in higher education that are occurring in the US, and Peter just alluded to them in other places. And here they include questions about the basic viability of the existing higher education or university models as we go forward, especially for public institutions because of the lack of funding. and also because of the advent of new technologies like e-learning to both enhance and extend our reach, which of course is especially relevant in global health because of our geographic scope and scale. Several of the folks on the panel have alluded to the notion that the driving force in innovation should be rethinking whom we're training and for what. And I think there are at least 3 points to keep in mind. First of all, as with medical school training, it seems to me we've got to prepare both practitioners and researchers, and Peter, you alluded to this before. We need to address the diversity in both realms. For a while, I led NIH's sexually transmitted disease research branch, and when I sat there, I thought we ought to be training researchers, right? And then I went to CDC and for about a decade led their STD and HIV prevention program. And it was pretty clear that we needed to train practitioners. So we need to think about that balance. The second is that there's a need for highly interdisciplinary and interprofessional competencies that provide both even more sophisticated health-specific technical skills with the leadership and management and policy development kinds of knowledge and skills that both Patty and Elizabeth talked about. And then third, there's a need for continuing education and training throughout careers, which dictates that we need a continuum that goes from undergraduates through to graduate and professional students and then to professionals in practice. So I'd like to highlight 3 issues or concepts. First, doctoral training for leaders in global health practice. I think there are a number of programs that do a pretty good job in preparing people for careers in global health laboratory-based research or clinical or epidemiologic research. We sort of know how to do that, right? But we expect leaders in global health practice to be able to work effectively across this incredibly complex architecture that's been referred to several times. Patty, you hit it in your slides. You know, it's the non-governmental organizations, the ministries, the bilaterals, the multilaterals, Gavi, the Global Fund, foundations, private donors, academia, and then you added media. And, you know, if you're really going to be a global health leader of practice in the 21st century, you got to be able to work across all of those. But there actually are no training programs in the world that we're aware of that offer advanced, hands-on, experiential training in more than 1 or 2 of those pieces of the architecture. So I think as a global health community, we really need to start developing some programs to address that gap, and here we're in the process of developing a doctorate of global health that is focusing on this, and we've talked about this a little bit. Number 2, on the research side, I think the code word is implementation science. I think this is the missing link in global health research, education, and training. So education and training in that area of research is missing. And I say that because I think this emerging scientific paradigm really is the signature science of global health. There is so much we know how to do, but we haven't used systematic scientific methods to increase the speed, fidelity, and efficiency and relevant coverage with which we go from that research finding to large-scale programs. And then the third area is the magic of e-learning. So there are tremendous opportunities, obviously, both locally and globally to extend our reach and do better in our training. So the question for e-learning, I think, is not whether we do it, but how to do it. And for me, the missing piece here, the neglected need, is actually research and evaluation around how we refine our approaches to the how part of what we do. So, for example, which formats should we be using? Flipped classrooms with facilitated discussions, in person or online, blended traditional or online formats, or straight e-learning, for which topics and which learning styles and which target audiences depending on the level of prior training. I think most of us would agree that what a freshman undergraduate needs is different from what a medical student needs, and that's different from what a professional in practice needs. And yet we haven't really gotten sophisticated about what each of them needs. And then, of course, we need to figure out the funding models for this. So I really look forward to talking about some of those issues, thinking about them together.
Thanks, Judy. So are there any quick questions for Patty, because she's going to have to go in about 5 minutes, so questions or comments for Patty, or if there are comments from students who want to share their perspectives, be great. We'll start over here. Uh-oh.
Well, thank you so much. Oh,
there you go.
Thank you so much to all the panelists. I do have a question for Ministra Garcia. I've lived in Peru for a couple years and spoken to a lot of health professionals and a lot of people who go to the health posts. And there seems to be a massive brecha, like a huge gap between these social, economic, educational, cultural, and language of the health professionals and the people they serve. Mainly I'm thinking of rural and indigenous folks, Quechua speaking, Shipibo speaking. And I'm wondering, is there a way we can make, or the way you can make, but also here in the US too, but in Peru, the healthcare professionals' education more relevant to the people they serve? Because I know a lot of people who, they don't go to the health post unless it's really urgent, because the healthcare workers don't speak their language, have prejudices, and don't stay even in the village where they're working. They go as fast as they can to the big city for nights and weekends.
Hey?
You want me to do it one by one? Okay. Yeah, you're absolutely right. And probably that happens in not only in Peru, but in several countries, okay? Right. So, so we have a big gap, and we call it the intercultural gap. So, and part of what I mentioned yesterday, that were the 4 pillars that we are planning to work in the transformation of the health system. So one of the pillars had to do with this issue about planning, not only the number of health professionals that we need, but also the profile of the professionals that we need and the distribution of the professionals that we need. In the profile, of course, one of the things that we need to include and to address in the curricula of these health professionals is to understand these intercultural differences, okay? But there is another thing that we're trying to work with the Ministry of Education, is the fact that in order for people to stay and to understand the people in certain community, right, it will be better if we're able to really identify somebody from that community and be able to help them to reach that level of training. So in other words, having health professionals from the same areas, which has not been one thing that has been happening, because for the people that don't know Peru, Peru has been always a very centralized country. So we have 1/3 of the population, so about 10 million people just living in Lima, which is very small compared with the rest of the country. And most of the universities have been located in Lima. So if you don't have the money and you don't have the opportunities, you will never be able to study medicine. So with the Ministry of Education, now we have these becas, they call Beca 18, so it's like a scholarship 18, which allows people from everywhere, from the most vulnerable poor communities, to study medicine. So we created, and maybe I should mention this because I think this is innovative. I forgot that we were doing innovative things in my previous life. So we created a new program, okay, that is called the Global Health Public Health undergraduate program, okay? So, and we got this scholarship for actually we created two programs. One that is for health administration, okay, and the other one that is for global health and public health. So we got these scholarships, and we're training people, and I'm so incredible, moved by this and proud of it, because we have every year for the past 3 years already, we have groups of 60 to 80 students that are coming from everywhere. So I have people that are coming from native communities, and when I was entering to teach a class that had to do with global health, I asked them to introduce themselves and say hello in their own languages. And actually I forgot them already, okay, but at that point I learned how to say hello in 18 different native languages. I never knew that there were so many. I knew about Aymara and Quechua, but there were at least 18 in the classes. So I think it's something that needs to be done. It's not easy, but it has to do not only with health, but also with education and with good planning. And I think we are on the way. There is a lot to do still.
Thank you.
Patty, I just want to make sure you don't miss your plane. I'd love you to stay longer, but did you have to leave at 10 too?
Yes. I
It's
just want to make one comment regarding what Judy was saying. It's true that we have to think about the whom, the what, and the why, okay? So I will add the why. So whom are we supposed to train? What are we supposed to give them, and why are we doing this too? But when you were defining the whom, I would say that it's not only the practitioners and the researchers, but I think we should also train the implementers, okay? And although you were trying to say that research, so implementation research, I think we should also train the implementers themselves as part of this whole spectrum of training. And there is one thing that we have been discussing, and King knows about this with SAFG, etc. Programs like Program Science, okay, which starts from the other side. So it's working with the people that are at ministries of health, at programs, understanding their data and understanding that things that they do could help, and collecting information could help them to do things better, okay, are things that we're not doing well, and I think we should include them also. Using the different ways of getting to them. So e-learning, maybe, practicing, sharing with others, etc. But I will add that too. And I will add another thing, is that we need to think about training global health to other people that are not in health, okay? So that's the other thing that we need to do better, because you were talking about medical students, but now I was telling you I need architects, I need engineers that start thinking about global health, because those are the kind of issues that we need. I think I need to leave. My plane leaves at 6 p.m., but this has been a wonderful symposium, a wonderful meeting, and I'm really thankful that you invited me. Thank you so much for being here. And I hope that when I go back, I'm still the Minister of Health for some time.
Patty. Patty, thank you so much. Travel well.
Yes. Thank you. Thanks, Patty.
Come
Travel
back soon.
safe. Judy, you look like you had a quick response, and then we'll go to the next question.
Right. Just, I think Patty's absolutely right. I was including under practitioners implementers, so I agree with her completely. And this issue of implementation science versus program science is a very long discussion, and but you know, I actually think those are two sides of the same thing. So again, as always, I would agree with her. But great.
Let's take the next question.
My name is Yue Zhang, and I'm an MPH student from Department of Global Health. And my question is, what do you expect from global health students to do in the future, and especially for low and middle income countries students? What do you think of their role in global health network? Because it feels like to me that, well, you're encouraging local students to go overseas and join the global health network. You want students from low and middle income countries to go back home and work on the health system in their own country. I just feel like it might be a totally different picture if more people from low and middle income countries to join the Global Health Network?
Peter?
Very good question. It is a very different perspective indeed. And we have many discussions on that at our school among the students. And this is about the why factor. Because still too often here, global health is seen as something for over there when it comes to individuals, students from high-income countries. And actually, it is, I wouldn't mind also that, and I think that global health education is probably one of the best ways to prepare for problems also at home, whether you are in high-income or low-income countries. And so that is not an issue. The issue is job opportunities are very different. When you have a global health diploma and you go in a low-income country, they say, what is this? This is, you know, this is for outsiders and so on. This is not a serious diploma. And so there, a degree that's in a recognized discipline is far more recognized. But it comes down to the fact that we need to really, I think, therefore, team up with institutions in whatever countries, in other countries, and together think through what is the market, the opportunities, because just producing students because we love global health, that's not enough.
Elizabeth?
I think there are many opportunities where one can give back. And when we think about global health, it's not about one particular country, because we are interconnected. And I think the question would be, where will you make the greatest impact? In the earlier training years, there was a requirement for those of us who were trained by scholarships that were funded through the US government that we would go back to our countries and make a difference. And I think there was a good reason for doing that, because there was a need in our countries to have a critical mass of people who are well trained, who are able to impact. A country like Kenya has benefited greatly, and I can say we do have a critical mass of individuals who are well trained. But having gone back home and been well trained, that has also offered me opportunities to work elsewhere. I've had opportunities where I've been asked to work elsewhere. I have chosen not to take those opportunities because my choice was to stay in Kenya and make a difference to Kenyans and to also mentor the next generation of Kenyan scientists. So I don't think it's a question of being made to go in any particular place. It's a question of you will have choices. And I would ask you, where will you make the greatest impact? Where will you make a difference? That's where you should go.
Next question.
Thank you. My name is Brooke Lochran. I work at the intersection of technology and health at Deloitte. I'm struck by the fact that in technology we're fanatical about capturing value from flows of knowledge, from networks, and it seems like there's been tremendous progress there in global health, but that there's still such an emphasis on training around stocks of knowledge. How can we create more incentives for the next generation of global health leaders to also engage in the flow of knowledge and in the networks that they're going to need to participate in with all these different stakeholders that have been mentioned so far?
Judy?
This is what happens when you're holding the microphone.
Yeah.
You know, I think several people talked about the importance of working in teams and across teams. And for anyone who's worked in global health, I think it becomes pretty clear that it's almost impossible to do anything really high impact alone in global health, that you've got to work across disciplines, across professions in a team. Sometimes that's a little challenging, and I think you're raising the point of how do we better both prepare people to do that, because there is an art to doing that, right? And then incentivize doing that. On the training side, since this particular panel is about education and training, there are, I think people are moving more to team-based projects as part of training. And it certainly is the modus operandi in business schools, as Peter mentioned. But I think increasingly we're doing that, certainly here at UW, in some of our programs. And I don't know if Elizabeth or Peter want to comment on this, but...
No, it's fine. I mean, we do the same.
Let me go to the right.
Thank you so much. This has been fascinating for me. I work at the Northwest Center for Public Health Practice here at the University of Washington, and we actually do training primarily at the local, state, tribal, and organizational level here, focused on public health practice, both in person and e-learning on many topics, including leadership training. So a lot of what you've all said today has resonated with me, especially in terms of training today for skills we're going to need in the future, despite not knowing what those are. And what the implications of that are for folks already in the workforce on leadership skills. And then also finally on this connection and overlap between what we call global versus local public health, including training people in global health who may not be designated in those fields. So my question for my work is, as we train professionals in my area in local, state, tribal, and organizational public health practice, giving them leadership skills and skills for changing times, how do we also give them skills, leadership and communication skills in particular, to connect their work to the global level and understand their work, even as small as on a local health department or tribal level, as part of global health work?
Okay. I think in the interest of time, what I'd like to do is maybe take the other questions and then have you respond to them as a group and make your final comments so that we finish on time. So maybe take one here, one there, one there, one there.
My name is Saida Haq, and I want to give some examples to show why ethics and communication is very important in next generation training. I had the opportunity to work with an USAID project, health project in Bangladesh, and I have observed few things that disturbed me. First of all, from our project, we are giving NGOs to distribute that accelerated nutrition to new mothers and also their children. And I was shocked to see the ingredients there. Those were highly refined carbohydrate, which we would avoid here. So I was not surprised when Dr. Craig had said that those nutrition really can cause obesity later in life. So these are replacing the organic foods there. So they're giving this packet food now to the new mothers in remote areas and packed from the Western companies. Tobacco industry. So our NGOs couldn't reach to some very remote areas to provide services. So I visited one of those very remote area, which was the poorest in the country. So we went to see that, and I was surprised to see that there are 3 spots in a small village where children are making tobacco. They are putting the leaves in the wrapper because it's this children's finger. And that tobacco company is an international industry. I forgot whether it was USA or UK. So the atmosphere was very unhealthy. They are all, and the elderly people were complaining that the landowner now substituting food, they are putting tobacco there instead of food. So I was surprised how tobacco company found this remote area, poor area to exploit. And another thing I noticed that in urban area, the children of middle class or elite class, they are now very fond of Kentucky Fried Chicken, McDonald's, and their parents, educated, they say this proudly. Instead of their homemade hot meal, they prefer fried chicken, those things. So I was thinking that how we can beat these industries processed food, sugar industry, fast food. I think maybe we can learn from them how to communicate, how to, as Lisa was saying, it's not a jargon and PowerPoint presentation, it's the humanistic approach to go inside and really mix at the local level. So I would like to hear about that. Thanks.
Okay. Thank you. Here?
I'm Hao from Wuhan University Global Health Institute. I'm also a visiting scholar here funded by CNB. Wuhan University currently is exploring the cultivation of undergraduate degree in global health. To do this, in China, we have our own background because now China is developing very fast, and China is expected to take more responsibility in global governance, and also the Chinese government also is willing to do this. But the problem is currently we are highly lacking of human resources in global health. So Wuhan University is authorized by the Ministry of Education to do pilot education. But there is a big debate in China. Some, especially in academia, one side hold that global health should not start with undergraduate education. Should start with a master graduation. But when we look to the world, in the United States, currently at least 5 universities in the United States have this undergraduate programs. Also in the UK, there are some universities launched undergraduate education. So my question is, in China, we have the undergraduate program because we have the demand, because current cultivation model can meet our requirements. For example, many undergraduates, they work in the pharmaceutical companies. But if we have our collaboration with African countries, if our undergraduates they work in pharmaceutical companies, they lack of the techniques. So for us, we have this kind of demand. But I would like to ask in the United States or the UK or in the other world, also the driving forces to have you consider to launch the undergraduate programs and how you do it. Currently, I'm also doing this kind of comparative education, comparative studies. So I'm really keen to know what's the difference of undergraduate programs in the world. I think we may need more models to collect more tailored undergraduate or master students. Thank you.
Great. We'll take the last 2 questions, and then maybe Judy, in your response, you could talk a little bit about the undergraduate programs here at the University of Washington. Yeah.
Hi, my name is Lauren Wu. I'm a senior here at UW, and I'll try to keep this brief. So I don't think any other undergraduate students have spoken yet, but I do believe that I'm speaking on behalf of many of my peers when I say that there's a lot of excitement and passion around global health education and around becoming aspiring global health practitioners and professionals. And every time we get the opportunity to hear from distinguished speakers like yourselves, so thank you for being here as well as the organizers, we have a bunch of students go up to them after and ask them, you know, how was it that with little to virtually no real world experience that someone or an organization took a chance on you to give you that experience, given that what you've identified in your panel thus far has been that there are lots of opportunities and gaps and skills we've identified that we need to train the future generation. But I guess for the current generation who are graduating from undergraduate programs and want to enter the field, I guess what would be some of your recommendations for, you know, maybe from personal experience, the domino effects that catalyzed the trajectory of your global health career? Thank you.
Great, thank you.
Thanks.
Rachel?
Real quickly. Rachel Nugent, RTI International. A couple of months ago, I had the privilege of hearing Julio Frank give a talk about his vision for the University of Miami, where he's now president. He's, of course, another lion of global health, like many people in this room. Too bad he didn't graduate from the UW, but he'd be here. But among the things he talked about in this vision is a university that is really a global university. And he talked about bringing down walls. Note to President, we don't need any walls here. Bringing down the walls of the literal walls because of electronic learning, distance learning, digital learning that's happening. Bringing down the walls of age because it's really a proposition of lifelong learning. And as I look at my young kids who are doing a lot of their learning online, you know, I don't imagine that they need to go to a place that has walls and classrooms to learn what they need to learn. But I do imagine that they're going to be learning decade after decade after decade, like the rest of us are just learning how to do. So I guess this is I think President Frank has a lot of interesting ideas for the University of Miami, but there are challenges to all of us in education. And I'd like to challenge you to tell us a little bit about how you see the UW and the Department of Global Health having a wall-less learning environment.
Great. I guess we'll take, you want to make a very short comment, and then we'll get the answers.
My name is Rachel. I'm an undergrad student at UW, and I'm currently taking global health class. So my question briefly would be, how do you create personal connections among the students? Because I feel like I'm getting lots of knowledge, including today, about global health, but as a student who live in have the privilege to live in developed country, I wouldn't feel the same as people who live in those countries where HIV and malaria and TB is very common. And I don't know how people's life is who have those diseases. So I feel like somewhat it's kind of like far idea for me. So I wanted to know how, as educators, how you create personal relationships, connect education, but also like passions with the students. Yes.
Great. So lots of great ideas and questions. Maybe Peter, maybe we can start with you. Respond to as many as you can succinctly and make your final comments.
Well, first maybe on the question that I found it most interesting was also how come that many of us, we made it without having all this
without getting the right training.
Education. And that's certainly my case. I can tell you when I investigated with far more experienced colleagues from the Centers for Disease Control, the first known Ebola outbreak, I had never been to Africa, I had never investigated an epidemic. I was not qualified for anything. Okay, I had a diploma in medicine, so at least so it was something. And I would say that, on the one hand, there are opportunities that you always should not miss, but times have changed. And it would not be acceptable anymore to have people who have not, kind of certain skills or in even a piece of paper would no longer be admitted in a country even, or in an institution for many reasons. So I think that's the way it is. And so the world is probably a bit more tough, but there are also far more opportunities because there's a whole global health industry sounds very negative, but I mean, it's just market and that's there. And it's the same thing is true, I think, for the personal relationship. I mean, sometimes we get students and they want to immediately go into a very big international institution and go in a very responsible place. I said, you start on the ground in an NGO and just learn it, and nothing can replace that. And I think that a third point I'd like to make is that we shouldn't underestimate the fact that in many countries there is not a cadre of, let's say, public health or global health professionals, and so there's no market. Take India, for example. I mean, we're working a lot with the Public Health Foundation of India. And there's a lot of interest in global health and public health, but there are no jobs. And if there are jobs, they're paid so little that they don't attract good people. So we need to be realistic about that. So all I want to say is that I think, since it's about the next decade, that the next decade will see major changes in, I think, in training, both in the how, the what, the wall-less, university. We work on that, but we are also restricted by a lot of regulation. But that's maybe more the problem in the UK than elsewhere. So support for higher education goes down, down, down. I mean, public support, regulation goes up, up, and up. So but that's my challenge.
Judy?
Well, let me work backwards a little bit. Rachel, in terms of your question about no walls, maybe I'm just being an old fart here, but I actually think that we're getting two different messages. One of them is the tremendous opportunity of e-learning, and the other is the fact that we have missed the boat by not having more experiential learning. And so I think that there will always be a need for some experiential component, particularly for, God bless you, global health. Because, I think global health is sort of like having a child. You can tell somebody who's never had a child or raised a child all about it, but until they actually have that baby and it changes their lives, they don't really understand what the heck you're talking about. And I think the same is true with global health. You can talk till you're blue in the face about what it's like to go live and work in Bangladesh. But I have to tell you, until I spent a couple, 3 years in Bangladesh, it just wasn't, I never would have understood it. And in fact, when people come here, I don't think they can understand what it's like to be here. It's not just for low and middle income countries, it's any place. You've got to go there and you've got to experience it. So I actually don't envision a time when we do all of our education without walls online. I think the reason I said what I said before is we need a better understanding of what combination of hybrid models, learning models, are best to accomplish the various things we need to accomplish for whom. In terms of entry points for careers in global health for students at UW, I think one of the wonderful things about this environment is that there are so many entry points, both within the university and in the larger community that's represented so well here at this symposium today, because we do have so many linkages with each of the organizations, and some that are not represented here, in terms of potential experiences. And particularly if you're ready to volunteer, just getting in touch with faculty or folks at some of the faculty here or at Washington State or some of the partner organizations, and trying to arrange experiential learning again. Opportunities to work on projects is a great entry point. There are things here like exploration seminars. There are our Go Health opportunities, global health opportunities that are other ways of getting started. And then in terms of undergraduate programs, I think the question there really is, particularly for China, and for all of us, is the balance between developing a pipeline of people over time and in the short term, how quickly you want to create a critical mass. And so I think in our partnerships with many of the universities in China, we've tried to thread the needle by doing both, but the strategy at Wuhan or any of the other universities, I think, depends on what you're trying to achieve. Here we are moving to develop an undergraduate major that will either be in global health or in population health more broadly, and there's a lot of discussion about that. It will take time, but.
Thanks. Elizabeth?
Thank you. I think I'll just say two last things. One is to the young lady who raised concerns about ethical behavior of perhaps providing nutrients that were not totally appropriate, or children who are involved in the tobacco industry. I think it goes back to what you said about ethics, that there will be practices that will not be appropriate. And the question is, do you have the skills, the training to be able to confront it in a manner that will allow a positive outcome in the end? So it's not just about facing it, but how do you face it? What's the best way to be able to do that? The last comment I'd like to make is, indeed, I think there won't ever be any training or any university that can teach everybody everything, and that can prepare you and teach you so that 30 years from now, you know everything that you needed to have known then. But I think the best thing, and I appreciate this about having been a student here, is that there are certain things that I did learn while I was here. One thing that I did learn was that I could try and do the impossible. It didn't matter how hard it is. I'd been given the skills and the training and the knowledge so that it didn't matter what I needed to face. I knew that there are places where I could find answers, there are people I could reach out to. And so what it taught me was that I could. And with the community and the network around me, that I could achieve whatever it is that I set out to do. So I think that is what we need to then prepare the scholars to be able to do. That, yes, you can't learn everything today for what you need 30 years from now, but what you're being taught now can help you navigate the next 30 years to still be relevant.
Thank you, Elizabeth. I want to make two comments in closing. One, just to build on some of the themes, a new program a new initiative that the Gates Foundation is about to launch with the University of Washington. You know, we've been thinking about how do you take advantage of some of these innovative approaches to training, distance learning, et cetera, and yet the value of being at an institution like the University of Washington. So we're about to launch our first cohort of something called the International Program for Public Health Leadership, which will be a training program for mid-career people from lower income, lower middle income countries, where and it's a collaboration with the Evans School of Public Policy and Governance here, as well as the Department of Global Health, and the Center for Creative Leadership, an independent organization, non-academic, outside of the university, but very involved in leadership training. And what we're going to do is we'll experiment this year with a cohort of 12 or 15 fellows where they'll once selected, do a 10-week distance learning program, then come here to the University of Washington for a two-week residential program, followed by 6 more weeks of distance learning, and then a final weekend program. And the idea would be to, if this works as well as we hope, to become a cohort that would continue, and over time we'd build an alumni network, and we'd bring in people from the university as well as the foundation's broad range of partners in the global health ecosystem to participate in that, both the distance and residential training. So we're going to launch that soon. I saw a draft of the brochure yesterday, but I guess it's not printed yet. So, March 1st we'll open the first set of applications. The second thing, just building on some of the comments from the undergraduates and reflecting on some of the conversations I've had with students following panels like this, both in my role at the Gates Foundation and previously at PATH, is that there are many, as you said, Judy, there's many points of entry in the ecosystem if you're willing to volunteer or do an internship, right? There's many internships, and India talked about them at PATH today, et cetera. What's missing in the ecosystem of global health is the first well-paid job. And I think that increasingly, I say this to the two of you as friends, and because I think this is, if you, again, Peter, you talked about learning from some of the practices of business schools. I think people used to go to Harvard and other famous business schools because they were Harvard and other famous business schools. But increasingly, given the cost of education, including higher education today, schools are being evaluated on their ability to place people into paid jobs, not just internship or volunteer experiences. And I predict that the 65 global health programs of U.S. universities are going to soon be evaluated on whether they can actually get people, not just a good internship, a good exposure, some experiential learning for a defined period of time, but whether they can really launch them on a career in global health and development. And I think we haven't had that before, and it's still an imperfect piece of our ecosystem. Because what students often say to me after panels like this is, we'd love to work for PATH or the Gates Foundation, but we read the job descriptions and you need 5 years of experience. Where do I get those 5 years of experience?
I have to say this because I have a 22-year-old son who is not in global health. He's in game design. And this is exactly the problem. You know, got all these skills, but not 5 years of experience, just out of an undergraduate program. And how do you get that first well-paid job? And I have to tell you, for him and for me as a mom, it is horrendous. And so I say that because I think it is really a challenge that we have to figure out in global health, but it is a broader challenge for this educational model in the current economy, both locally and globally. And you're right, we need to figure out a smoother transition.
Yeah, because I think to date it's been sort of the student's problem, and I think we have to make it the institution's problems as well. So maybe that's a good note to turn you over to final comments. Thank you all.
Thank you to our panel. You can go off.
Okay.
Good. Thank you. And thank you to all the next generation people who asked questions. That was the intention of the session, and we really appreciate it. We are going to be closing out now, and I'm going to hand off to Judy for our last words. Thank you.
So I get to thank Jared. Thank you, Jared. All right. I'm totally biased, but I think this was a pretty amazing day. You know, these discussions really have been far-ranging. They've been provocative. They've been inspiring, at least for me. And I think they've also been fun. In fact, this has been one of the best birthday parties I've ever been at. I hope that each of us leaves today with at least one insight and one new colleague. Let's see if I can make the slides work here. No? I'm upside down. You've got it? Help me out here. Thank you. One back. What I wanted to try to do was thank, first of all, our speakers and moderators, our planning committee members, again, our sponsors, very much, and then these logistics team members and other staff who, I have to tell you, have worked tirelessly for months to make this happen. So let's give them a round of applause. They've worked behind the scenes, but we wouldn't be here, and today would not have gone this way without them. And then I really want to thank you for being here and for making this such a rich and rewarding day. I hope you've enjoyed it. I do have one final thank you, which is really on behalf of our entire global health community. And it is to Lisa Cohen, who's stepping down as the executive director of the Washington Global Health Alliance. So maybe, Lisa, you could come up here. Under Lisa's leadership, WGHA has developed thousands of partnerships that have really benefited the world's most vulnerable populations. Lisa has really been our champion and has raised the profile of Washington Global Health organizations at the local level, the state level, and nationally. She's articulate, as you've heard, and insightful, and strategic, and most importantly, she's warm, and she's genuine, and she's a true friend. And so, Lisa, thank you.
please join me in thanking Lisa and wishing her the best of luck in your next adventure. All right. Way to go. All right. With that, thank you all so much. And let's make global health even stronger and higher impact through the rest of this year and into the future. Thank you all.